Sir, Dean sir, mute. You have to mute, sir. Dean sir. Okay, a very good morning to all our registered participants, our dignitaries, in our medical college, hospital and institute, as well as our eminent speakers and chairpersons who kindly given their time for this CME on recent updates in salivary gland tumors, clinicopathological perspectives. This is Dr. Anand. I'm Associate Professor of Pathology and in charge of molecular diagnostics and clinical research in SRM IST. And it is my pleasure to host this webinar. And we will be having a program in this manner. We start with the inauguration and then immediately followed by the scientific program. Dr. Jagdish Chandra Bose talking on pre-op diagnostic dilemma and salivary gland tumors, our surgeons' expectations fulfilled, chaired by Dr. Durema Valavan, our own medical oncologist in our hospital in SRM. This will be followed by a lunch break, and we will be having the FNAC of salivary gland lesion by Dr. Usha Kini, chaired by Dr. Sandhya Sundraman. And that will be followed by histopathology and immunohistochemistry and recent advances by Dr. Rajendran sir, and followed chaired by Dr. Chandra Mohaneshwari. So we will start with the inauguration ceremony first. We'll start with the invocation song. Just
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமெனத் திகழ்பரத கண்டமிதில் தெக்கணமும் அதில் சிறந்த திராவிடன திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
This is a virtual CME, but we just wanted to have you have a glimpse of our campus. It's a vast campus in SRM IST in Katangulathur. So we welcome you to the campus virtually, and our medical college, hospital and research center in Chengalpattu districts, our medical college, our hospital. And I request our professor and HOD, Dr. Jason Jacob John, to deliver the welcome address. Sir, over to you, sir.
Thank you. Respected Pro-Vice Chancellor, sir, Dean, sir, Medical Superintendent, Vice Principal, Deputy Medical Superintendent, Dean and Deputy Dean from SRM Dental College, Cotton Kotu, esteemed speakers for today's CME, chairpersons for today's events, dear delegates and friends. It gives me great pleasure to welcome all of you for this update on salivary gland tumors. At the very outset, I must thank our speakers for readily accepting our invitation to speak at the CME. In our institute, the postgraduate department was established in 2011, and since then, it's been a very meaningful and rewarding journey. And we're grateful for the support of the management and the administration at all times. It is very gratifying to know that we have over 500, the exact number is around 583 delegates who have registered from Tamil Nadu, Pondicherry, and various states of India. I would like to bid a very hearty welcome to all the delegates for today's CME. A wide range of lesions, both reactive and neoplastic, have been described in more than 500 salivary glands that are present in the human body. As we all know, cytology and histopathology are invaluable in the evaluation and diagnosis of salivary gland tumors with judicious use of adjuncts like IHC and molecular pathology. Most of us know that these salivary gland neoplasms, they are a very diverse group of lesions, and often they've got very overlapping features. And because of this, they continue to confound and perplex us both in cytology as well as in histopathology. The classification of salivary gland tumors has changed over the years, and now we are identifying previously unrecognized variants. And again, there are some neoplasms which simply defy categorization. From the pathologist, we move to the surgeon. What is our duty to the surgeon? What should the pathologist convey in the report? Our report needs to be prompt, it needs to be accurate, and it needs to be detailed. Ultimately, the report is important not only for the diagnosis, but also for the likely clinical course, and the therapy also hinges on the report. So I'd like to end by two very well-known sayings. A little knowledge is a dangerous thing. Drink deeply or taste not the Pyrenean spring. Experience is a hard teacher. She gives the test first and the lesson afterwards. Thank you, one and all.
Thank you, sir. Thank you for those nice words of introduction and welcoming all the participants. Next, we are having the virtual lamp lighting. We will next have a special address by Professor Dr. Sandhya Sundaram, who's Professor and Head, Department of Pathology in Sri Ramchandra Medical College and Hospital and Head of Clinical Services in Pathology. And Madam is also President of Tamil Nadu and Pondicherry Chapter of Indian Association of Pathologists and Microbiologists. And we discussed this CME before, and she said we'll do it in collaboration with the TNPC IAPM. And we are also, our college also, we are members in that. So Madam has been very encouraging to support and conduct the CME, and she kept on encouraging us till the end. So over to you, ma'am, to deliver the special address.
Thank you, Anand. First of all, a very warm welcome to everybody and a very good morning. My respects to all the dignitaries on the panel. And it is my proud privilege and a very happy occasion to be a part of this very interesting CME that has been put together by the Department of Pathology at SRM Medical College, Katangulathur. And I must say that they have designed it so beautifully with a clinical talk followed by cytology and histopathology, something that is very wholesome. And it is my proud moment that it has been under the aegis of the Tamil Nadu and Pondicherry chapter of IAPM. Many of our programs now in Tamil Nadu are under our IAPM chapter, and so happy that there has been such a huge positive response to this CME program. Almost 580 delegates have registered from across the country, as well as delegates from outside of the country. And I'm so proud that we have some excellent experts, and so happy that Dr. Bose is here in spite of his very busy schedule to tell us what he expects us from us as pathologists. And of course, Dr. Usha Kini madam and our own Dr. Rajendran. Just to say that Tamil Nadu IAPM has really been doing great work for the past 3 years and so many more years earlier. And we have had so many more members join us, both from India as well as abroad. And we hope that through this CME, many more members join us. We will be also having our TAPCon somewhere in July. And I'm sure just like the past years, where we've had 1,500 delegates, this year also we will have. And just as Dr. John had very beautifully put, salivary gland is a very, very dicey and a very tricky area for us, both in cytology as well as histopathology, because there are many entities which are very, very overlapping. And sometimes it really foxes us as to what particular entity. Sometimes in cytology, it's even difficult to make out benign from the malignant lesions. So I think this CME is so apt and so very well timed. And I think Dr. Anand has, and Dr. John and the entire team, Dr. Shiv Shekhar, the entire team has put together an excellent CME. And I think all the delegates are going to learn a lot from this CME. And I hope many more such CMEs are conducted under our IAPM banner. I also want to mention that Dr. Chandra, who's our secretary of the TNP IAPM, has been very active. We've had so many parallel programs going on, and it feels really great that our clinical colleagues, our surgeons, are also so actively involved in our program. Thank you once again for having me on board, and I wish the CME all success. And as we always say, learning is lifelong. Each one of us has a lot to learn from each of the CMEs that are conducted. Once again, thank you, Dr. John and Dr. Anand and Dr. Shiv Shekhar for inviting me over here, and all the very best. Thank you. Have a great day.
Thank you, madam, for your very encouraging words. And we hope to do more programs, academic programs with IAPM. Thank you so much. Next, it is my honor and pleasure to introduce our respected Dean, sir, Professor A. Sundaram, sir, who is not only an administrator here, but also a very senior professor of pathology and very much part of our department. He's a dedicated teacher, diagnostic specialist, and he's got a lot of research interests and keeps encouraging us to do higher things and advanced methods. Sir had introduced electron microscopy in MMCs almost 2 decades ago. And he has been very much a mentor to our department and always guiding us on all aspects. For this CME, from the beginning, sir has given his support and guided us all the way. Thank you, sir. And request Dean, sir, to deliver the inaugural address.
Thank you, Dr. Anand. Respected Pro Vice Chancellor, Madam Dr. Sandhya, Dr. Bose, Medical Superintendent, Vice Principal, Dr. Ushakini, my dear friend Dr. Chandra, and the delegates. It has given me a proud and privilege to form part of this team and also giving an inaugural address. And at the outset, I have to congratulate the entire team led by Dr. John and also by Dr. Anand for organizing this a very interesting CME program, the salivary gland tumors. The salivary gland tumors are really interesting, and they are, though they form a small part of the entire maggot of malignancies, this area, lot of interest is shown by the surgeons, pathologists, and also by the researchers. Many new varieties have come in the panel of tumors, the salivary glands. The classifications also has changed their meaning, and the postgraduates have learned a lot of idea about this latest development regarding the tumor classification, as well as the specific areas, the recent updates. The molecular diagnostic methods help us in making the diagnosis better than what it was before. When we were students, we usually know very few tumors about the parotid glands. Whenever we see a salivary glands, we usually talk about the parotid and very few cases of submandibular glands. And also, most of them we think benign, very few cases of malignancies, and fixed diagnostic criteria and fixed nomenclatures. Now, the tumors are varieties of tumors are occurring in this area, and diagnostic difficulties are many. And the interesting part of it is cytology and histopathology, correlations and histochemistry, and all these things help us making a diagnosis. And also we have formed very newer varieties of salivary gland tumors, which was not known before. And these are the interesting areas which are going to be highlighted during this session. And we have with us Dr. Bose, an eminent oncology surgeon, and Dr. Ushakini. She is a cytologist and known for the entire world. And we had many cytological conferences organized by Ushakini. And also the Madam Dr. Rajendran is going to discuss about the histopathology slides. We know the quality of discussions usually brought about by Dr. Rajendran, and the quantity of slides and he used to focus, and the discussions always very useful to our postgraduates, and particularly his personal interest and personal experience he used to share with the postgraduates, and the way he take classes for the postgraduates also used to be very interesting. Most of them liked by everybody. So those type of people are here to make this CME program wonderful. No doubt why the program is being liked by and shared by many people. I am very, very happy that the participants are from throughout the country, also from the out of country, because of this interesting topic chosen by the department. And I have to congratulate the organizers and especially Dr. John and Anand for bringing out such a wonderful program and inviting all the experts. I have to thank Dr. Bose, Dr. Sandhya, Dr. Ushakini, Dr. Rajendran for immediately accepting to participate with us with the program. And my special thanks to Dr. Chandra for participating as a chairperson, and hope this program is going to be a wonderful experience for all the participants. Thank you once again. My congratulations to the entire team of pathology. Thank you, Anand.
Thank you, sir, for your words of encouragement and best wishes and blessings. We will do more programs and develop the programs better. Thank you, sir. It is my honor to introduce our Honorable Pro Vice Chancellor, Professor Lieutenant Colonel Dr. A. Ravikumar, sir, who, since he has taken up the position in SRM Medical College Hospital and SRM IST, we've had chance to see that he's having a vision to take us all forward to greater heights. And he always keeps pushing us, nudging us to move forward in different ways, and expects a lot from us. But at the same time, sir also asks, how can I help to, to make it better? So he's always there to help us to move forward. And sir is an ENT surgeon, is professor of ENT and specializes in cochlear implantation, tracheal stenosis management, and also has a deep heart and medical education department also. Request our Pro VC sir to deliver the presidential address. Over to you, sir.
Thank you, Anand. Good morning to everybody. I feel happy and grateful to all of you to ask me to deliver the inaugural address, the presidential address. And at the outset, I wish to congratulate and compliment Dr. Jacob John and as well as his team, Jason, Jacob John and his team, especially Dr. Anand, who have put up this wonderful show, probably the first in the pathology department in recent memory. And they've tried to integrate and jointly involve clinicians and the pathologists, which is very good. Respected the dean and other dignitaries on the dais, as well as the invited faculty, notably Dr. Sandhya Sundaram, Dr. Rajendran, Dr. Bose, Dr. Ushakini, Dr. Chandra Maulestri, and others, and my dear delegates. It is indeed a very nice academic event that has been started now. I hope this inaugural ceremony finishes fast and takes you through the important nitty-gritties of diagnosing salivary gland tumors. The virtual CME has enabled us all to get together on a single platform and also at the cheapest possible cost and the shortest time interval, because gone are the days when we had to travel, stay, and then find vehicles to reach and then greet. All that time is absorbed now thanks to technology. And in that way, I think we must thank the pandemic also for doing this. Now, the virtual CME is on updates in salivary gland tumors, clinicopathological perspectives. Very, very aptly done, because this is one area which is I would say, difficult to master tumors of the parotid gland as well as other salivary glands. And we find that frequently we ask for many opinions of histopathologists and still we are confused. As an ENT surgeon, I can recollect my little experience in this aspect because I was initiated into parotid tumors when I spent time in the UK. The very first day I entered the OT, I was asked to assist in a parotidectomy. And then because in the ENT training, we did not include those days. It was a new thing for me. And since then, I developed interest not because of the gland or the tumor, because of the facial nerve, which as clinicians, we are, as ENT surgeons, we all are definitely worried about the facial nerve during mastectomy. And having had a further training in skull-based work, where we used to operate on glomus tumors, lateral skull base, again, we had to learn about the parotid anatomy. So it was partly by force, partly by interest that I landed up in the soup of parotid surgery. And then I had to find a good pathologist to give me a correct diagnosis. But the caliber of the pathologists I see now in the panel is so high that I think they are probably some of the best in the world. One important aspect in your CME is that the clinicopathological perspectives. Unless these two specialties think together, we will not be able to solve the problem of the patient. During my training as a postgraduate in the Armed Forces Medical College, we all had to do the evening rounds. And during that time, we used to be surprised to find two other specialists doing the rounds in the wards. One was the pathologist trainees, second was the radiology trainees. The training in those days was such that they had to see the patient both pre and post operatively, interact with the clinicians before writing a diagnosis on the pathology slide. I don't know whether that still exists or has it become irrelevant. This is something which I would like to throw as a question to the pathologists for taking part in today's CME. Because unless you know the clinical picture, and many of the clinicians are so poor communicators, unfortunately, that they don't give the real picture to the pathologists. So it was a convention in AFMC those days that pathologists and radiologists had to go to the ward or at least interact with the clinician before they write a diagnosis. Even in FNAC, I remember the pathologists rushing to me and asking questions before they gave a diagnosis. This was a trend in the Army Research and Referral Hospital also in Delhi. Now, coming to our pathology department, I think it's a very well-staffed, well-qualified, and very efficient and research-oriented department. I didn't have to do much except ignite a few sparks here and there, and they have caught on. And they have excellent talent here, and I think they need exposure. And I'm so happy to know that people like Dr. Sandhya Sundaram, who also happens to be the president of the Tamil Nadu Pondicherry chapter of Indian Association of Pathologists and Microbiologists, is here. We would request her help and guidance in encouraging more and more younger pathologists to have some sort of interaction with across all departments and various eminent institutions and try to get the overall standard of learning and teaching to a much better level. We want technology, but technology cannot replace the human being behind the technology. And molecular biology being what it stands now is definitely a huge advancement, but still we need the good pathologists to be trained. And in that, I think I can't find better teachers than the ones which are here. And I'm sure that with the inputs by Dr. Jagdish Chandra Bose on the clinical side, and Dr. Usha Kini, Dr. Sandhya, Dr. Rajendran, and Chandramouli Sri, we all will be richer by the end of the CME. I'm also equally happy to know that more than 200 postgraduates have joined the CME today, and they should be the ones to benefit the most. And I want to request them all to be active participants and ask many questions, clarify doubts, either the chat box or whatever way you can, so that we can enrich each other. This has been the way we did our CMEs in real form also. Our postgraduates were usually encouraged to be actively participating. So all in all, it's a win-win situation. And I once again thank the organizers for this opportunity. And on behalf of the management and administration of SRM, Faculty of Medical and Health Sciences, I extend a warm welcome to everybody and also wish you the very best of luck to enjoy this CME program today. Thank you very much.
Thank you very much, sir, for your encouraging words and suggestions that we will take forward. Thank you very much. The Department of Pathology has a presence in both. We call it a paraclinical department. We have a presence, active presence in the college as well as in the hospital, laboratory. And we, our administrators, including our Vice Principal Madam, Professor Dr. K.V. Leela, she's head HOD of microbiology. She is always been supportive of our department and give us suggestions to take the academics aspect in the college. We are very thankful for her. And our medical superintendent, Dr. Tangaraj sir, he's always supported us in all our requirements in the diagnostic section in the central laboratory and discussion with the clinicians regarding reports. And we are very thankful to him. Thank you, sir. And our Deputy Medical Superintendent, Dr. Al Balamurugan sir, is a professor of surgery, and we work very closely with him and his department, and we have clinicopathological conferences and surgeries, and we work very much with him, and thank you for his support. And thanks to all of them for encouraging us to do this CME. Thank you so much. The vote of thanks will be delivered by Professor Dr. Shivshekhar sir, Professor of Pathology.
All is well that ends well. It is a pleasure that I have to propose the vote of thanks on the inaugural function of the National CME on salivary gland tumors. All programs at SRM have been successful due to the continuous encouragement of the management. We are blessed with the constant support of our Honorable Pro-Chancellor Academics, Dr. Satyanarayan, in all our endeavors. Our Pro-Vice Chancellor, Dr. Lieutenant Colonel Ravi Kumar, has always been leading us on the academic fronts. This national conference would not have been realized but for his support since the beginning. Our Dean, Dr. A. Sundaram, has always been a pillar of support to the Department of Pathology. In this instance, not only was he sanctioning all that was needed, but also putting a stamp of authority in pulling participants from all over the country. A special thanks to both of you, sirs. Dr. Sandhya Sundaram, the president of the Tamil Nadu and Pondicherry chapter of IAPM. Thank you, madam, for your special address. We shall be carrying it to the students, and the link that you had explained between oncology, histology, and cytology shall very well be delivered. I thank the Vice Principal, Medical Superintendent, and the Deputy Medical Superintendent for their august presence. Regarding the guest speakers, Dr. Jagdish Chandra Bose from Sri Ramchandra Medical College, Professor Usha Kenny from St. John's, Bangalore, and Dr. Rajendran, a colleague of mine and a visiting professor from Sri Ramchandra Medical College, are all to be thanked for accepting our invitation and to deliver the best of lectures to the students who are awaiting them. These students have poured in from all over the country and even from the adjacent countries. I thank the chairpersons, Dr. Thuraima Valavan, Dr. Sandhya Sundaram, and Dr. Chandra Maulishwari, who have always been our friends in need and ardent supporters. The head of the Department of Pathology, the faculty members, and the postgraduate students have left no stone unturned, and they have been working throughout to make this a success. The ITKM head, Mr. Syed, audiovisual staff, Mr. Damodaran, doctors Sangeeta, Anusha, and Sweta, faculty from the departments of pharmacology and microbiology, have all been vital connecting links for this program. Once again, I thank all of you for making this not only the inaugural function, but the entire program a success. Thank you.
Thank you, sir, for your vote of thanks. We will now move to the scientific session after a couple of minutes, please. Thank you, one and all, for the dignitaries. Thank you. The scientific program is going to start. Now, the first talk would be the oncosurgery talk by Dr. Jagdish Chandra Bose, will be chaired by Dr. Thuraima Valavan, our medical oncologist. I request Dr. Muthu sir, our professor of pathology at SRM Medical College, to introduce the chairperson. Over to you, sir.
Thank you, sir.
Yes, sir. Go ahead.
Thank you, sir. It's my pleasure to introduce Dr. Thuraima Valavan, who is the medical oncologist in our SRM Medical College Hospital. Sir completed his MBBS in Chengalpattu Medical College and finished his MD General Medicine and DM Medical Oncology in Madras Medical College. Before joining SRM, he has also worked in many government medical colleges, including Thoothukudi Medical College, Madras Medical College, and the Omandurar Multi-Super Speciality Government Hospital. Sir has a good rapport with our department and discusses all the tumor cases, both personally as well as in the tumor. Over to you, sir, to chair the session.
Thank you very much, sir. Thank you very much, sir. We all know the salivary gland tumors constitute only about less than 5% of the head and neck cancers. It's one of the most important and dire since it is already always resistant to much of the treatment modalities. So only treatment modality which is highly useful for the salivary gland tumors is a surgery. And the oncosurgeon plays a main role for the curative of the patient. Though there are some chemotherapy which may be a role in the palliative setup, there is no role at present till now in the adjuvant setting to treat the salivary gland tumors. Nowadays, there are recently the upcoming molecular cytogenetics, so that the such as acidic cell carcinoma, which may be positive for c-KIT, and similarly salivary duct carcinoma, which may be positive for the AR receptor and EGFR receptor. We have come up with trials to show the role of the imatinib and cetuximab, and recently the androgen receptor positive in ductal carcinoma, we show some positivity in the enzalutamide and abiraterone. But till now, only the oncosurgeons has a major role in case of the salivary gland tumors. Now, today, I am immensely pleasured and pleased to invite our professor, because I worked in MMC Medical College during SAP period. My professor of surgical oncology at Ramchandra, Dr. Jagdish Chandra Bose, to deliver his talk. Sir completed his MBBS at the Tanjavur Medical College and completed his general surgery at Tanjavur Medical College. He is a best outgoing student and a receiver of gold medal in anatomy during his UG period, and best outgoing postgraduate in the general surgery department during his PG. He completed his MCH surgical oncology at Cancer Institute at Nadia. His field of interest mainly in the pelvic surgery tumors and head and neck surgery and salvage surgery after the post radiotherapy surgeries. He is has much interested in the microvascular flap reconstruction surgery. So I request sir to enlighten us with this talk. Sir, please.
So thank you, Dr. Durai. And it is nice to have a person who could have a similar interest to talk about. And my lecture today is going to be primarily on what a surgeon can do with salivary gland tumors. I want to start this lecture by saying that this is a very interesting topic chosen by the Department of Pathology from the SRM. I thank the management, the pathology department, and all the pathologists for giving me this opportunity, because we seldom have opportunity to talk with them and interact with them, except in tumor boards where we have some discussions. So my topic today is that what would a surgeon expect from the pathologist? And are his expectations fulfilled in the diagnosis of a salivary gland tumor before he starts operating on the person? Now, we know very well that most often when the surgeon encounters a tumor in the salivary gland, his questions are, should I go in and operate or should I investigate? Now, we know very well that everything starts with a very good history. So history taking and clinical examination can never be dealt away with any of the investigations which you may have. So it is very important to correlate your history, clinical examination with your imaging, come to your clinical diagnosis, then correlate your clinical diagnosis with your imaging and pathology, and then get to a decision as to whether this patient would require a surgery or not. As our chairperson was telling, we know very well that all salivary gland tumors would end up with the surgeon because these tumors require surgical management whenever possible. Whenever possible, in the sense, whenever you can adequately remove them, it is always better to have the tumors removed. But that doesn't mean that you should forego all these principles. That means a good history taking in the sense whether the swelling changes over time, whether the patient has got additional trismus, pain which is referred, variation with the meals, bilaterality, and the exposure to other radiation, current medications, and then a good clinical examination. A clinical examination starts with examining the patient, touching the patient, finding out whether the gland has got any focal or diffuse abnormality, and to examine the oral cavity completely, including a bidigital examination, and to look for all the cranial nerves. Now, palpation, as I was telling you, is a very important component in which the gland has to be palpated using one finger intraorally and another finger outside, because you know that the deep lobe of these glands are in very close proximity with the mucosa, and the enlargement of the deep lobe can be made out if you examine intraorally only. So it is a very important part of the clinician to take time and examine the oral cavity thoroughly and do a bidigital examination and correlate his clinical findings. Now, why is this very important? We can make out some red flag signs or document them in the case sheet, which is very, very important for anybody who is going to see these tumors. And this is very important because this suggests that the patient is going to have a diagnosis which can be made even by your clinical examination. Like when the patient has got involvement of the adjacent structures in the form of invasion of the skin, muscle, or bone, when the patient has got a nerve palsy, which may be a facial nerve palsy, or the patient may have a sympathetic palsy in the form of harness when you have a parapharyngeal salivary gland tumor. When a patient has got a recurrence, he has been already operated and he has recurred. When he comes to you with a nodal or a distant metastasis, you know very well that these are all red flag signs which will tell you that you are likely to face a problem which is likely to be a malignancy. Now, you know very well that salivary gland tumors constitute a very small portion of the head and neck tumors, hardly 2 to 6%. So the larger the gland, the more likely that you have a benign tumor, and the smaller the gland, you are likely to have more of a malignant tumor. So you know very well that in these tumors, a benign tumor is predominantly a pleomorphic adenoma, and a malignant tumor is predominantly a mucoepidermoid carcinoma. Now, what is very important is how to choose the investigation wisely before you go in and investigate the patient. It is not that you give a list of investigations to the patient to do them simultaneously and then come and meet you. You don't order something like an ultrasound, a CT scan, an MRI, a PET scan, all these together, and then give it to the patient and say, kindly have all these investigations done. That doesn't matter because you are unnecessarily going to do investigations which is not going to be relevant for a patient. So you need to know how to go about doing them in a proper order. Now, what is this order of investigation? Now, the most important investigation would be an ultrasound with the Doppler if needed. Now, the ultrasound can categorize a cystic lesion from a solid lesion and from a solid SOL to a diffuse enlargement of the parotid gland, which would rule out most of the benign conditions of the parotid. So an ultrasound is a good investigation to rule out most benign conditions or diffuse enlargement of the parotid and differentiate it from a space-occupying lesion in the salivary gland. So this investigation should be the first investigation which should be ordered in any parotid swelling or any salivary gland swelling. Now, this differentiates the tumor from the tumor-like conditions and the diffuse enlargement of the parotid. It also evaluates the neck nodes, and it can give you a guidance for doing a good cytological evaluation with a fine needle aspiration. So in these ways, you know that ultrasound can definitely guide you in choosing the right patient for the right treatmental modality. So you see some of the cystic masses that are known in the parotid, and these cystic masses can be differentiated from the solid tumors. Now, why should you know whether the tumor is cystic or solid? And is it important that sometimes a cyst can mimic a tumor? Yes, quite it's possible, because you know that sometimes we can have mucinous cysts, which can be like something like a non-neoplastic cyst, like a mucocele, which is very difficult to differentiate from a low-grade mucoepidermoid carcinoma, which can have a cystic and a solid component. And sometimes this may be non-mucinous, which may be lymphocytic or non-lymphocytic. And the non-lymphocytic cysts, which are non-mucinous, can sometimes be metastatic squamous cell carcinomas. And the lymphocytic variants are difficult to differentiate from the Warden's tumor. So 3 tumors which can show cystic degeneration would be a low-grade mucoepidermoid carcinoma, a Warden's tumor, and a metastatic squamous cell carcinoma, because they can have necrosis, and it is very difficult to differentiate between a necrosis and a cystic tumor. Now, what about the CT scans? Are CT scans useful in salivary gland tumors? A CT scan is useful especially when you have a bony invasion. So you find that a tumor is fixed to the bone or very close to the bone. The most important investigation is a CT scan, and it is mandatory, and it is given in the guidelines that a CT scan should be done to rule out a bony involvement in any patient who has got a tumor which is fixed to the bone or very close to the bone. In the same way, the CT scan can also tell you about the calcifications which are present within the tumor, and it can be sometimes helpful to differentiate in a challenging benign condition. Now, the most important investigation which is useful in a salivary gland tumor is an MRI. This is without question. And a dynamic contrast enhanced MRI is the most useful tool in differentiating a benign and a malignant tumor. Now, why am I saying that? This is because sometimes these radiologists can even challenge the pathologist in saying that we have a restriction diffusion in this particular point, which tells us that these tumors should have a high cellularity. So to that extent, the radiologist can go and challenge the pathologist. So the investigation of choice in a salivary gland tumor, no doubt, is the MRI. And we see here that the Tmax values and the washout ratios are different in different tumors. So the classical 3 tumors which you want to differentiate are the pleomorphic adenoma, the Warden's, and the malignant tumors of the parotid. This is of clinical interest to the clinician. We know that pathologists have about 40 different variants, but this is what is going to matter for your clinical acumen. So if you can find out that, as you see here in this curve, in some of these patients, you will find that they have a high washout ratio in the form of more than 40, which would signify that this is a tumor of high cellularity like a Warden's. And when a tumor has an intermediate washout, like in the between 10 to 30%, it is likely to be a malignant tumor. And a very low washout, like less than 10%, would say that it is a benign tumor like a pleomorphic adenoma. So a dynamic contrast enhanced MRI with the ADZ values and washout ratios have a very great value in differentiating different salivary gland tumors of histological nature. So we know very well that perineural invasions, which are specific for adenoid cystic carcinomas, are best made out with your MRI. And so what is the final conclusion? The final conclusion is, if your radiologist is so very definite that it is a pleomorphic adenoma or whether it is a Warden's tumor, do you really require a biopsy? So this is the question to be asked for the clinician. Can the radiologist replace a pathologist? So can the radiologist say that I'm pretty sure that it is a pleomorphic adenoma? Can you go ahead and excise the swelling because it's not likely to be malignant? Now, this is something which has to be answered because there are enough and more trials to show that that radiology can predict the histology to an extent of around 94 to 95%, but it is never 100%. So I would say that radiologists can definitely contribute to a very large percentage in making a good diagnosis, especially when it is correlated with a fine needle aspiration cytology. So this is my opinion on MRI. Now let us come to the functional studies like the technetium and the PET scans. These scans show a high intense uptake in a Warthin's tumor because of its cellularity and the high mitochondrial content in these tumors. And this is confirmatory of Warthin's. So what is the most important relevance here? We know that if a tumor is bilateral, you have a very high uptake and it correlates on radiology. Maybe some of these tumors could be kept even under wait and watch, especially if they are on elderly and they don't fit into certain criteria. Now, bilaterality of the tumor can be best assessed by these functional studies. And you know that there are certain tumors which can present to you with bilateral masses. The ones would be the lymphoma, the lymph nodes from a metastatic disease, and then we have some of the actinic cell carcinomas, which can present as bilateral tumors. Now, what is the value for other investigations? So now let's go to individual tumors, where you would see something like your pleomorphic adenoma. So what are the specifications or what is the beauty of this pleomorphic adenoma? This is the most common benign tumor which we would see. It may calcify. It has a low washout ratio. It can recur if it is enucleated. So you know that a good excision can take care of the pleomorphic adenoma to a very large extent. And malignant transformation in these tumors are known. So we need to be very careful, especially when the tumor is radiologically different, or when you think there are some clinical features to suggest that it could have a malignant transformation. Now, the next comes the Warthin's tumor, where you would see that it is often bilateral, and it can happen only in the parotid, and it is often related to smoking. It is multifocal, and it has a very high washout ratio of more than 40%. And as I was telling you, there is a functional uptake in these tumors with technetium and PET. Now, what about the malignancies? So we have tumors like mucoepidermoid carcinoma, which are commonest among the elderly as well as adults and the pediatric population. So this is the commonest cancer, contributing to more than 30% of the cancers. They have a cystic component, especially when they are low grade, and they can be mistaken for a benign lesion. So you find sometimes, because they think that it's a cyst, they are enucleated and the patients are sent to us. The only point which we can differentiate between these tumors with a Doppler is a high vascularity, which if you do even on an ultrasound, you will know that there is a high vascularity in these tumors. Next comes your adenoid cystic carcinoma. So these tumors are a little very peculiar in the sense they have a perineural invasion and a vascular invasion, and their behavior is so very variable from indolent to a highly metastatic type. So it is the second most commonest cancer, the parotid, and the behavior of the tumor is rather very peculiar. Now, there are other malignancies in the parotid, and I know that there are a list of them, which I could not give here because I think the pathology symposium, so you will see a lot of pathologists talking about various variants of this. But what interests the surgeon is that we have an epithelial and a non-epithelial variant. And in the epithelial variant, we have the adenocarcinoma, pleomorphic adenoma, the actinic cell tumor, the squamous cell carcinoma, which is a very rare tumor of the parotid. And then you have the non-epithelial variants like lymphoma and the metastasis. Now, the most important part where we come is whether we need a pathological diagnosis in every salivary gland tumor, which we should operate. Now, if you see the flow chart which is given there, you do an ultrasonogram. The chart says, if you are pretty sure and you are confident that this tumor is likely to be benign, you can directly do the surgery. But I would not vouch for it, basically because sometimes you may miss out on something. And having a pathologist input by an FNAC does not make you any different from waiting for a few days and talking with your pathologist to get this impression whether we can go in and safely remove the tumor, considering it as benign. So I would not choose the column which is on the left, where it says boundaries clearly visible, likely to be benign, you directly take up the patient for the surgery. No, I would not choose that column. I would rather go for an FNA with every patient where I see a salivary gland tumor. Now, the next thing it says is boundary is not clearly visible, large tumor in the deep lobe, the parotid, minor salivary gland tumors, doubts on benign character. You need to do an MRI. And if it is close to the bone or bone involved, then you do a CT and then take up the patient for surgery if it is resectable. So here again, an ultrasound is mandatory. So you cannot take MRI alone as a diagnostic tool. And MRI diagnosed Wardens and MRI diagnosed pleomorphic adenomas are basically about 95% safe. And when it is correlated with an FNAC, you can come close to 98%. So it is always preferable that you even take up these patients for an FNA prior to doing your surgery. So next comes taking the patients for an FNA, which may be even sometimes ultrasound guided. So here you see that FNA, again, is not a foolproof method. So FNA sometimes is evaluable, where the pathologist is confident enough to tell you whether it is benign or malignant. And so it can help you in dealing with the right patient for the right surgery. When FNA becomes non-evaluable, you can sometimes repeat the FNA, or it is preferable to go for a core biopsy, which is the aim of my talk today. There is nothing wrong in a core biopsy in a salivary gland tumor, provided it is guided correctly by an ultrasound to take a good representative tissue and get the opinion from the pathologist, because a lot is to be done based on what type of tumor you are dealing with, especially when it is malignant. And if on core biopsy, your opinion is still not very conclusive, it is always preferable to take the opinion of the pathologist on the table with a frozen section. Now, there are limitations. We would not say that every time the frozen section should be available, and it is mandatory. The frozen sections are often useful when your decision on the table is going to change and you're going to revise your surgery. So in that way, a pathologist help is mandatory even at the time of the surgery, because the surgical decision would vary and you don't want to go in again and try to do some surgery for the patient, because if you have done an inadequate surgery, it really matters for the patient. Now, what I want to emphasize here is FNA is recommended for all salivary gland tumors, irrespective of this nature, unless you are suspecting something like a lymphangioma or a hemangioma. And if it is a solid tumor, it is always preferable to have an FNA. A core needle biopsy is recommended when you have an inconclusive or a suspicious tumor, which is not correlated with your FNA, and if it is especially a non-pleomorphic adenoma and a non-Wertheim's tumor on an MRI. Inconclusive discordant FNA and the risk stratification on FNA is mandatory, and it is recommended as a guideline. So it is mandatory that all patients undergo an FNA and a risk stratification, without which no salivary gland tumor should be taken up for a surgery. Now, what are the limitations with the pathologist? The pathologists have their limitations in the sense the tumor is heterogeneous. And if you see this charts on the left, you will see that these tumors do not have a single component of cells. They have multiple components of cells. And so we don't know where from this representative specimen was taken and the adequacy of the specimen. So a representative specimen, an adequate specimen, and the heterogeneity of the tumor would go a long way in guiding the pathologist and telling you whether your results on the pathology or the pathology report are going to be helpful. Now, we all agree that pathologists are the unsung heroes of this meeting because you know that everything matters with the pathologist. So a precision and personalized oncology in delivering the right treatment for the right patient with the proper diagnosis, which matters, at the right time. Now, how can you do that without the pathologist? So pathologists are definitely mandatory. But what is the problem with the pathologist? The problem with the pathologist is often between the preoperative and the postoperative histopathology. The surgeon often expects only two diagnoses. So he asks the pathologist whether it is benign or malignant. Tell me whether it is benign or malignant, because I want to make a decision based on that. So you have to tell me whether it is benign or malignant, and if possible, whether it is low or high grade. So this is how we decide. But the pathologists have something like more than 40 tumors in the differential diagnosis. So the surgeon's difficulty often comes in facing the patients, and when you have something like an inconclusive or a discordant report, especially when the reports are released without discussing with the surgeon. So my humble request for all the pathologists is, please discuss with your surgeon before you give the reports, because the surgeon doesn't know what report you're releasing. And when the patients read the reports, they get into a lot of controversial discussions with the surgeon. So they say, now you say that it is benign, now the report is malignant, and it is discordant with the postoperative histopathology. So where did it go wrong? Why are we wrong first? So all these questions come to the surgeon basically because he's the one who is going to deal with the patients. So it is important that the pathologist discusses the report with the surgeon before he or she releases the report. Sometimes the footnotes suggest excision. So please don't put footnotes saying that kindly excise the tumor because we are inconclusive, right? So because patient comes and demands excision, when something like that is not feasible, you might have sometimes an inoperable tumor which is fixated. So please discuss with your surgeon, find out whether an excision is possible or whether a more representative biopsy should be taken, and then you release the report. It is always better for the surgeon to deal with the patient. Now, this is the TNM staging, which is given for the tumors of the salivary glands, where you would see that only a stage 1 is T1, stage 2 is T2 tumor. So you see a tumor which is hardly 4 centimeters becomes stage 2. And anything above that becomes stage 3. A T3 and the N1 tumor would become stage 3. And you see here, the involvement of the adjacent structures are considered as T4A and pretty advanced, locally advanced lesions, right? So any tumor which involves the adjacent structures or extensively involves the lymph nodes, in the sense when you have an N3 node which is larger than 6 centimeters, they all go into stage 4B. And the stage 4C would be a distant metastatic tumor. Now, where do we start the surgery? The surgery starts from a good history. If you see a good history of the parotid surgery tumors, it starts in 1785 with John Hunter in his casebook, where he records removing a bulky parotid tumor. And then it goes on to somebody who does a parotidectomy, sacrificing the facial nerve. Those are the eras when they did not have good anesthesia, good technology to help them, good hemostatic mechanisms to control the bleeding, where they did parotidectomy with very large tumors. And then came the era in 1913, where Blair said, isolate the trunk and dissect the nerve. That is when he said he started the principles of parotid surgery, which went on with 1921, where you have Sistrunk saying that there is something called a retrograde nerve isolation. Now, why am I saying about this history? It is important for the surgeons to know how the surgery evolved so that he can evolve himself to that particular extent. So you know that the nerve should be dissected in all parotid surgeries. So Blair started it when he started isolating the nerve. And then came Hamilton Bailey, who said that there are two lobes, the superficial and the deep lobe, and the pes cancerinus, which lies in between that. And then came the era of exposition of the facial nerve with a proper dissection, which is mandatory, which was well described by Hayes Martin in 1952. Now, this history tells us how the parotid surgery evolved, and it became more and more justifiable and rational. So the principles of surgery in a salivary gland tumor is an R0 resection is the primary stay of treatment. You need to remove the tumor monoblock, and you need to remove the tumor completely. Now, how is this achieved? This has to be achieved by a very good incision, a good exposition or extension of the structures which are nearby, and then dissect the tumor well away from the vital structures and remove the tumor monoblock. So these principles of surgery have to be followed. Enucleation is not the standard of care. If you try to enucleate the tumor, they recur, and you will have a prompt local recurrence in the extent of around 80 to 90%. Minimum surgery which is recommended is a superficial conservative parotidectomy in the parotid. Paralyzed nerve and encased nerves are alone sacrificed in malignancy. If a nerve is close by, just because for the clearance, you don't remove the nerve. And even if you have to remove the nerve or remove a segment of the nerve, you can always do a cable graft. The adjacent structures which are involved are alone excised. For the clearance sake, you don't remove the adjacent structures. Removal of the deep lobe is recommended only in high-grade tumors where the tumor lies very close to the deep lobe, or when a tumor really involves the deep lobe. Selective node sampling is recommended in N0 neck, that is node negative situations in a malignancy. In a node positive tumor, we need to do a modified radical neck dissection, that is an MRND. Metastatectomies or removal of the metastasis, especially in the lung, can be recommended when the number of tumors are less than 5, because adenoid cystic tumors, which are low grade, the patients can live a very long time with symptoms which are pertaining only to the metastasis. So this is in short the surgical principles or recommendations which I want to give. And this being basically a pathology CME, I don't want to take much time in describing each and every surgery and the steps and all those things. Now the incisions in a parotid. We know that we are evolving. We are evolving from a standard incision to a facelift. And now we have mini incisions where people are trying to do through robotics and minimally access removal of the tumors with high magnification. But those can never do unprincipled surgery. What I mean by that is, just because you want to do a robotics, you can't go and macerate, or you cannot enucleate the tumor, and that is not correct. All oncological principles are to be followed, and then you have to do the correct surgery for an individual patient. Now you see here a nice laughing patient with a good dissection of the facial nerve in removing the superficial lobe, goes a long way in helping you make your career. Now a pleomorphic adenoma of the superficial lobe just requires a superficial conservative parotidectomy. So the basic principle of any of these surgeries is to delineate the nerve very, very correctly. So you would see here that the nerve is well delineated and it is shown up there. Now, what about the tumors of the deep lobe? Here you would see that it is a total conservative peritidectomy where the deep nerve is seen there and it is dissected away from the carotid. And you would see that there is a part of the masseter which is involved, and that has also been dissected. On all the 5 branches of the facial nerve are clearly seen there. Now, what is the role for your reconstruction after such a surgery? So when you remove the deep lobe or when you remove the superficial lobe, you know that you are leaving behind a defect there, which would give a ghastly appearance in the form of a depression, especially in the retromandibular area. Now, this can be covered by using a good sternomastoid flap. So you just transpose the sternomastoid from the lateral to the medial end. Now, this gives you a reasonably good cover. Now, this you see is a large parotid tumor where the skin is involved, where you need to excise the skin, multiple neck nodes, so a classical neck dissection, and you see that we have done a pectoralis major myocutaneous flap for covering the defect after a radical surgery. So sometimes we face difficult situations where we have a malignant tumor involving the minor salivary gland, like this one in the buccal mucosa on the right side, where we have excised wide the tumor along with the skin, because you see somebody has done a biopsy through the external source, and you would see here that there is a involvement of the skin. So this is repaired by a nasolabial flap. And in malignancies, we need to do a selective neck dissection. Now, this patient had a residual mucoepidermoid carcinoma after the tumor was enucleated. So this patient underwent a peritidectomy followed by a selective neck dissection involving the level 2 and the level 3. So this is a total conservative peritidectomy, where you would see that the tumor is also involving the deep lobe, where the tumor is actually below the facial nerve, and you can see that it has involved a part of the masseter as well. So in these situations, sometimes we'll have to resect some of the branches of the facial nerve. So you see here, there are only the upper division, and in the lower division, you have the marginal mandibular, which is intact, and all the buccal branches have been removed because they are either encased or they are involved. So whenever you have an encased nerve or an involved nerve, only then the nerve has to be sacrificed. In all other situations, the nerve can be saved. So this is again a malignant parotid tumor with a skin involvement. We call this sometimes as an extended peritidectomy, which may be sometimes even total conservative. But you see here that the deep lobe is separately there, and the facial nerve has been completely dissected. Along with that, we have also done a level 2 and 3 clearance in the form of a selective neck dissection. Now, here I'm going to tell you how a plastic surgeon would help you in dealing with sometimes difficult situations where you want to tackle a tumor like this. This is a mucoepidermoid carcinoma of the heart palate. You can see a large tumor there sitting on the right side of the heart palate in this particular patient. So you see there is a schematic diagram which is given there by the side, which tells you that you have the tumor here, which is almost over the entire area there in the right side of the heart palate, almost up to the midline and even crossing it a little bit. Now in these tumors, because the pre-maxilla is going to be removed, it requires a very good reconstruction. So you need a very good plastic team to do the reconstructive work for you after you do something like a partial maxillectomy with excision of the premaxilla. So in this patient, you see how the reconstructive pattern goes. So you mark the area of excision, prepare a mold. So the skull mold is prepared. The extent of excision is marked. And then you make a metal plate on which you fix the bones. So 2 pieces of fibula along with the microvascular flap was taken, and this has been fixed on to that. And then this patient was repaired. So we need a real multidisciplinary work with a good plastic surgeon to reconstruct difficult situations, especially when we deal with minor salivary gland tumors, which may be parapharyngeal, in the palate, or in situations like involving the buccal mucosa or the tongue. So this is the patient. You can see that a part of the fibula has been taken and 2 pieces of the bone were anchored to that plate. And after that defect, this patient has been repaired with a microvascular fibula osteomyocutaneous flap, right? So such reconstructions are mandatory, especially when you do it on situations like this, where you want to give a good quality of life as well as a good survival for these patients. And this was a mucoepidermoid carcinoma arising from the palate. And see the end results. The patient has got a good outcome with a flap sitting in the palate, and she has been well reconstructed with an obturator and the teeth. So thanks to the entire plastic surgical team. Now, we see that after the surgeon does the surgery, there are situations where we will need adjuvant therapy. Adjuvant therapy in salivary gland tumors are needed, but in select situations. It is considered necessary in all adenoid cystic carcinomas because these tumors have a tendency to have the perineural spread, especially when your margins are close or positive. In high-grade tumors with lymphovascular invasion, perineural or nodal spread, a T3 or T4 lesion, especially when it is high-grade. Now, these are the situations where somebody would give a radiotherapy. Now, radiation within 8 weeks should be started. And so your reconstruction, whatever it is, should be good enough and the patient should be fit enough for the radiation. Preoperative radiation is recommended only in unresectable tumors, and the role of proton beam therapies are evolving. Now, systemic and targeted therapy, I think my chairperson, as he rightly introduced, said that has very limited role. And we see that it is often used only when the patient has got a symptomatic growth which cannot be removed. And the growth with the potential to reduce the organ function is there, especially when they are metastatic. When more than 20% growth is made out in 6 months in metastatic tumors, and the role in adenoid cystic carcinoma, as he was mentioning about the tyrosine kinase inhibitors, and in the non-adenoid cystic carcinoma about the androgen receptors, the HER2, and the checkpoint inhibitors are also there. Now, this role is a very limited role, and it is often held as only in the form of trials. Now, is there a possibility that we can observe the salivary gland tumors without doing anything? Yes. A Warthin's tumor is worthy of an observation, especially when it happens in elderly. So you see here a flow chart where it says the tumor can be managed with active surveillance if the patient does not desire to have the surgery done and if the patient is not symptomatic. So you can observe these tumors if you are pretty sure that it is a Warthin's tumor. So what is the follow-up after you do a surgery or you manage a patient? A history and clinical examination once in 3 months, primary site evaluation to rule out a recurrence in 6 to 12 months for 2 to 3 years, and a CT chest in high-grade lesions up to 3 to 5 years. So I think I'll close my talk with this, and I will invite any questions if you have any, and for the panelists or somebody to give inputs into my talk. So thank you very much. Nice of you. I'll stop my share here.
Sir, thank you very much, sir. Thank you for enlightening us regarding the surgical management for the salivary gland tumors. We all know that medical oncology has a very limited role. Though surgical has come, whether it is benign and malignant, there are two options. We have only one option, whether it is curable or incurable. That's all. Only thing, if it is a curable, only the surgery is the management. If it is incurable, we can go for the palliative chemotherapy in salivary gland tumor. Nowadays, some of the PDL1 inhibitors and some molecular and immunotherapy has been in trials, but till now it doesn't have any proven role according to the guidelines as such as the NCCN and ESMO guidelines. Thank you very much. Thank you very much for the enlightening.
So Anand, we have any questions?
Yes, sir,
like even from the attendees or
audience, sir.
Right, yeah.
Yes,
No problems. I can wait. And even I would
Yes,
like to have the comments from the pathologist because
audience participants and other colleagues, please put your comments or questions in the Q&A or chat box, please.
Anand, can I ask a question?
Yes, ma'am. Yes, ma'am. Please go ahead, madam.
Madam,
First of all,
I am
thank you.
awaiting your question only.
Thank you so much, sir. First of all, for that excellent clarity. Really, I learned so much. Sir, one thing you had mentioned that not to write excision. I do understand that, sir. But sometimes when in an FNA, we get only a focal area and it becomes sometimes difficult to interpret. We don't know the rest of the lesion. Because we are not sure, we tend to put this line saying that excision of the entire lesion to see the rest of the area.
Right.
Now, how is it taken from a surgeon's point of view, sir? If
Right.
you don't want that line,
No,
we may
we
have to
don't.
rephrase a little bit and how to put it better way. That's what
Correct.
I meant.
You are very right. Say, for example, I agree with you that sometimes it's very difficult to conclude with whatever you are seeing on the sections, what it is, and whether it is really malignant or non-malignant and what type it is and all that. But what happens is some of these lesions are not excisable. That is one. Two, excision biopsy is different from the radical surgery which we would plan. For example, if there is a deep lobe lesion, we don't do excision. We do a total conservative peritidectomy and send it to you for a frozen section, right? If at all you want it. Because as I told you, sometimes we have to decide on whether we are going to remove the lymph nodes or not in this particular patient.
Right.
So if you give a report of malignancy, I'm going to remove the lymph nodes. If you're going to say it's non-malignant, then I'm not going to remove the lymph nodes. Why should I remove the lymph nodes, right? So it becomes over treatment if I try to remove the lymph nodes unnecessarily. So in that way, a benign or a malignant report is mandatory for the surgeon to decide on the table. Now, the variants of the malignancy, we are not very much interested in. So whatever variant it is not going to be a very big way in the managemental protocol, correct? Unless somebody is interested to know whether it is low grade or high grade, correct? So what we want to know is basically first viewpoint, as I was telling you, is whether it's benign or malignant. If you are sure that it is malignant, then can you give us whether it is a low grade or a high grade disease? If you could give us that, because this is going to change the line of our surgical approach. And that is why we need that. Now, histological differentiation and all that is more useful in the post-operative setting where we might be planning other treatment. Like, for example, if you give us an adenoid cystic carcinoma, I will be irradiating up to the base of the skull because we know that these tumors can spread along the perineural sheaths. So in that way, the treatment profile may alter a little bit. but that is needed only in the final histology. And the other point, what I was trying to say is, for example, the pathologist says that on an FNA, that there is a suspicion of malignancy, correct? And then on the final histopathology, you say that it is benign, right? Some of the patients are unhappy. We say you have to be happy, you got a benign report, but they are unhappy. They are telling us, see, the pathologist picked out something which made her say that it is likely to be malignant. So have you removed that or not removed that for me? This is what the patients will come and ask me. So they ask me, the pathologist has reported, they come to me with a pre-operative report saying that suspicious of malignancy in this report. Now, they say it is benign, sir, but here they said suspicion. Have you removed that lesion or that lesion is still there with me? Because there was a suspicion of malignancy in that. Now, why are they not writing suspicion of malignancy in this report, right? Now, this is because the surgeon is facing the patient. We come across such questioning because, you know, the patients are nowadays very anxious. They want to know what they have and they want to really be very sure that it is not malignancy, right? Some people are very happy when we tell them that it is benign, but some people are really not very happy. They are still suspicious. So they think we have left behind something and the pathologist has seen something. They have put a needle, they have seen, and you are not seeing it. That means there is something which is left out in the patient. So this is the interpretation the patient comes to us with. So that is why whenever you release the report, if you could please talk with us and let us know what you're going to release, it will be easier for us to tell the patient. Now, there are situations, as you rightly put it. For example, we did an FNA. The FNA says that it is likely to be malignant, right? And then we do a core biopsy. The core biopsy again gives us an inconclusive report. So now what we do is we tell the patient, see, we are not getting adequate reports on these, both the procedures. So what we are trying to do is remove the tumor, send it for a frozen section. We don't call that as excision. We call it as a peritidectomy, right? Which may be either a conservative or a total conservative peritidectomy. Now, if you write excision, I will tell you the reason why I told that. The patient will come and tell me, sir, that doctor has written only to remove the tumor. Why do you want to remove my parotid? This is what the patient will come and ask me. He will say, the doctor has asked you only to remove the tumor. Why are you saying that you want to do peritidectomy for me? Correct? I don't want my gland removed. So now the interpretations are variable between the patient, what the pathologist wants to mean. The pathologist wants to say, do whatever is possible for the patient, remove it and then send it to me. But that doesn't go across to the patient. The patient thinks that doctor has recommended only removal of the tumor. This doctor is telling he is going to do the parotid completely. So I am scared. I don't want my facial nerve removed. So he says, just excise the tumor, send it to the pathologist. She or he will tell you whether it is malignant or benign. Then you decide, right? Okay. Now this I have had it from one of the educated patients. That's why I'm telling you this.
Okay, sir. Really, very, very clearly put, sir. Now I got the actual pictures.
Okay.
Because we, as you said, we put it because we feel we like to see the rest of the tumor, but for the patient, it doesn't mean.
Correct.
Absolutely. Very beautifully put, sir. Thank you so much, sir.
Thank you, madam. Nice for asking because
yeah, because this is something which we do, as you said, it's very rightly. Now I get the perspectives. Thank you. Thank you, Anand. I just wanted to ask.
Sure, ma'am. Sure, ma'am. Sir, one of the participants has a question.
Yes.
He's mentioning that in the report and advice, instead of saying excision biopsy, whether we can just mention biopsy so that the surgeon can convince the patient for core biopsy or radical surgery.
Correct. Now, see, what I was telling you, I want you to understand that when an FNAC is inconclusive, we always recommend a core biopsy, and that should be done with the guidance of the radiologist because he can get you a better specimen with a more representative area. That is point number one. So after an FNA, we do a core biopsy. And after the core biopsy, if the core biopsy is not sufficient or giving you the adequate report, then you need to talk with the surgeon. The surgeon will say what is going to be done. For example, you have an inoperable tumor. In an inoperable tumor, we can't remove the whole tumor. So the surgeon will say whether he will do an open biopsy where you remove a small segment of the tumor and then give it to you for sampling. Okay, so that may be needed sometimes. So you have a very large neck node. Repeatedly, you try doing a biopsy. All your biopsies will be negative, especially when there is a huge necrotic component. So we need to make an incision, take out a chunk of tissue, send it to you, confirm with the frozen section that the tissue is adequate. When you say that there is an adequate tissue, we close the patient, right? And then you give a report, we get a conclusive report. That is called an incision biopsy, right? In an inoperable tumor. Okay, now let us deal with the situation where you have an operable lesion. In an operable lesion, whatever is surgically deemed for the patient, whether it is benign or malignant, will be done, right? The tumor will be removed. For example, if it is a deep lobe parotid tumor, that's what I was discussing with madam. We need to remove the whole parotid. And that will be sent to you for a frozen section. We don't do excision of the tumor alone. So the idea here is we can't do excision of the tumor alone in a parotid. Even in a pleomorphic adenoma, if I'm trying to do only an enucleation, you know that the chances of local recurrence is very high. So I'm not going to enucleate the tumor. I'm going to do a superficial conservative parotidectomy or a total conservative parotidectomy and then give it to you. Now you report in frozen whether it is malignant or benign. Then if you report malignant, then what I do is I clear the neck nodes. If you report benign, I'm not going to clear the neck nodes. I will just come out excising the parotid alone. So the definitive surgery will be done and a frozen report will help us guide whether we should extend our surgery or we don't extend our surgery. Is the point well taken now, right? Have I answered your question, doctor?
Yes.
Thank you.
Yes, sir. Yes, sir. Yes. Sir, I have one question of my own.
Sure, sir.
Just wondering about mucoepidermoid, if it's a low-grade mucoepidermoid or where the mucin content is more.
Correct.
And how would you approach the surgery? For example, if we touch the lesion, whether it will extravasate and can it lead to seeding? How will you manage?
Right. See, your question is very correct because there was an issue previously whether needle track seedlings could happen. But they say it is so very negligible and it is over exaggerated. So they personally feel that if it is a high grade disease, the possibility of having needle track seedlings can happen in a high grade lesion, especially when it is done repeatedly. See, now they don't put repeated needlings, right? They have what is called as a coaxial needle. They put the needle once, they have a sheath inside, they remove only the central core and they keep putting it again and again. So if you repeatedly keep puncturing the tumor multiple times with multiple needles, with large bore needles, it is quite possible that you can disseminate the tumor along the needle track, especially if it is high grade. But if the tumor is superficial, you are using a coaxial needle and you are puncturing it only once, then the probability of needle track seedlings are very, very low. I can say it is less than 1 to 2%, right? So I think it's quite negligible. That is point number one. Point number two, in a mucinous tumor, if you think your biopsy by FNAC is not helpful, and the radiologist says that it is a clear cyst with no solid components, all you have to do is to remove the tumor completely and give it to the pathologist for a frozen, right? The reason being, any number of biopsies are not going to help you in a cystic neoplasm with a very small solid component. So in these lesions, the removal is the answer. You can't have biopsies any number because that's not going to help you. It's going to yield just mucin, and that's not going to give you any conclusive report. Unless you have a solid component, or unless you have a component which has a high vascularity in one of the edges of the cyst, where you think it is important, and you can use that particular area to be guided by a needle and a biopsy taken properly. Correct? So I would personally, if you ask me, a mucoepidermoid carcinoma with a large cystic component, right? And you think that there is no solid component which is made out, I would rather go in and remove the tumor, right? And it is not going to be anything big different from the surgery which I'm going to do for a benign tumor. See, because in parotid, as you know, there is very little clearance which we can give. The clearance would be only in millimeters, right? If at all you want to give closer to the nerve or closer to the other structures, it will be only in millimeters. You're not going to have centimeters of clearance in parotid, right? So I would rather remove the tumor and send it for a frozen. And if my pathologist says that it is malignant, then based on the size of the lesion, I would decide whether I would remove the neck nodes. For example, in a T3 and T4 disease, it is mandatory that you remove all the neck nodes and send it for a proper histopathological examination, even if they are not involved. I mean, even if they are not involved, because it is needed that you have to sample the nodes when it is T3 and T4, right?
Okay. One more question is that this association of smoking and Warthin's tumors. Is this something we see only in Western literature, or have you observed in our patients in India? Your experience with that, sir? This
we see such association. We see that association, but it often happens in a very elderly group. It's not during the smoking ages that they come to us. They come to us at a much elderly age, when they are 80 or something like that. They come to us with such tumors. I don't find them in an actively smoking group. I find them more in a very elderly group, right? It is there. It is definitely there. Smoking is associated with increasing incidence of Warthin's, right?
Yes. Thank you, sir. No more questions, sir.
Sure. Thank you.
Thank you, sir. Thank you for such an enlightening talk on a very difficult topic. And I think a lot of our surgery faculties and postgraduates, as well as pathologists, have benefited from that. Thank you so much, sir.
Thank you very much, Anand. Thanks, everyone.
Thank you, sir.
All the attendees and the panelists, everybody. Thank you very much.
Sir, this is your participation certificate as a
very nice,
speaker.
Anand.
We will email it to you, and also a hard copy will be sent to you.
Very nice.
Thank you so much for spending your time with us.
Thank you very much. Nice of you. Thank you.
Durai, sir, this is your certificate as for a chairperson. Thank you for spending time with us and working closely with our department. Thank you so much.
Carrying this session. Thank you.
Thank you very much.
This comes to the end of the first talk. So participants, we will be breaking for lunch now, and we will resume at 1:30 p.m. sharp, and requesting all of you to join back, log in back at 1:30 sharp. Okay, thank you so much. We'll be pausing the session now. Thank you. A very good afternoon to everyone. I think we can resume our scientific session for the post-lunch sessions. And we are going to have the first session by Professor Dr. Usha Kini, madam, and it will be chaired by Professor Dr. Sandhya Sundaram, ma'am. And I request Dr. Kalaivani, ma'am, Professor of Pathology, SRM Medical College, to introduce Sandhya, madam. Over to you, ma'am.
Thank you, sir. A very good afternoon to one and all gathered here. I'm very delighted and honored to introduce our Madam Dr. Sandhya Sundaram, HOD and Professor of Sri Ramachandra Medical College Pathology Department, and also President of Tamil Nadu Pondicherry Chapter IAPM. Madam has completed her undergraduation from Burdwan Medical College, West Bengal, post-graduation from Madras University, and PhD from IIT Madras. Madam has got expertise in most of the specialties of pathology and also has got special interest in genitourinary, gastric, breast, and molecular pathology. She has published more than 80 papers in both national and international journals and received several research grants on GU cancers. And not only that, Madam is a chief editor for a book titled Handbook of Pathology for PG students. And also, Madam has written foreword of the most iconic book in pathology, Rosa and Ackerman Surgical Pathology, South Asian edition. And number of awards for her achievements are many. To mention a few, she has got award named Power Grant for Women for Research in Breast Pathology by SCRB, Government of India, and BRNS Research Grant for Cancers of Head and Neck. And Sri Ramachandra University has awarded Ma'am Dr. Lalita Kameshwaran Gold Medal for publication with highest impact factor, that is 11.8. And we are very happy to welcome you here, ma'am. And I would like to call upon ma'am to chair the session. Over to you, ma'am.
Thank you so much for that lovely introduction. You've not left out anything. So very happy to be here. And it is my proud privilege to introduce Dr. Usha Kini, who is my friend for so many years and a great colleague. And currently she is the Professor of Pathology and Head Translational Research Lab for Gut Motility Disorders, St. John's Medical College, Bangalore. And Madam needs no introduction because she's so well known in all circles. But just to briefly go through her CV, she did her undergrad from Bangalore Medical College and her postgrad from St. John's Medical College, followed by her DIP in B Pathology. She's a fellow of the Indian Academy of Pathologists, and now she's the secretary, a very powerful post in the Indian College of Pathologists. She's not mentioned it here. And she's also a fellow of Academy of Medical Sciences. She can talk about any subject, but her area of specialization includes non-gynec cytology, pediatric pathology, gut motility disorders, particularly Hirschsprung's disease, where she's contributed a lot, and GI pathology, pulmonary, ophthalmic, and endocrine pathology. She has more than 132 international national lectures delivered. She's won several awards, to mention a few: National Merit Scholarship holder from Ministry of Education and Social Welfare and Government of India. Dr. M.R. Parthasarthi and Dr. A.V. Ramprasad Silver Plaque Oration at Belgaum 2015, Karnataka Lifetime Woman Achievement Award 2020. And she was the president, she served as president of the Karnataka chapter of IAPM, and she took that to great heights. More than anything, Madam is a very soft-spoken, extremely affectionate, and somebody whom you always have a great pleasure when you interact. So happy to introduce you, Dr. Kini, and the stage is all yours. Eagerly awaiting your talk on a very important topic. Thank you, Anand.
Yes, ma'am. Usha Kini, ma'am, you can start to share your screen. Yes, ma'am. Madam, please turn on your video also. Sure, ma'am.
Madam, can you hear us?
I can hear you, ma'am. For
No,
Usha, ma'am.
Usha, madam, I'm just asking Dr. Usha.
Yeah.
Very good evening, good afternoon, probably, yes. Thank you very much, Dr. Sandhya, for introducing me, for the good words that you spoke about me. But when it comes to salivary gland, yes, I think that's the trick. It's a very tricky topic, and I hope I do my best. But I know let me thank Dr. John, Jason, the head of the department, and Dr. Anand, who have constantly been in touch with me and giving me to be in the midst of you all to present this topic on cytology of the FNA of salivary gland lesions. So as it comes to us, I have titled it as the good, the bad, and the ugly. I'm very fascinated by the most influential Western movie that is ever made, I suppose, and that's how I consider it, and especially its music, and that is the good, the bad, and the ugly. For it refers to three main characters in the movie, played by the good, and you all know it is Clint Eastwood, and Lee the bad, and Ellie the ugly. But here we have the salivary gland lesions behaving in these three ways, the good, the bad, and the ugly. And I want you to take you through this movie and hope you enjoy it. The movie is not about purely, it's about the cases that I have diagnosed where I have got it wrong, and many which I have missed. And of course, the so-called the badly where I've totally gone wrong. I hope you enjoy this session of mine. And with due regards to all my teachers, the patients who have helped me to come up with this presentation. So the salivary gland tumors, as we all call it, it's a most diverse lesions. It's very complex. It has a marked morphologic overlap between the neoplasms. That's why it's so well known and we are so uncomfortable with, because we do not know at times, are we dealing with a benign or a malignant? Sometimes leave alone inflammatory lesions give us a miss. So these three M's, the most diverse, the most complex, the most marked morphological variations make the salivary gland lesions. Probably I'll put the word tumors in brackets, a very difficult or a challenging subject in cytopathology. So what is the role of FNA? But we know that we all feel it. It's, we are able to put in a needle into this, and I'm sure it's 100% hit lesion. It is not so that, the needle can miss the lesion. So we are not worried about that. You know, a very good doing an FNA will easily get the material. The problem is when it is mixed with mucin, will it have the cellularity? Will it get stained because mucin comes in the way of staining? So we come across a lot of issues as in when we go by. Then the effectors of cytomorphology, it said that the sensitivity is up to 85 to 100%, but the specificity is only about 48 to 91%. This is according to the clinical trial. That's how they have found that we can't be very specific when it comes to this. Then, but if we combine with FNA and frozen, it's about 95% accuracy. But I don't think FS or frozen should come in this scenario. So what is the rationale for FNA in salivary gland lesions, bar tumors? Especially it is a pre-operative technique. And what is the guide, or what is that we employ this as a guide to the surgical management? We just heard Dr. Bose talking about the surgical implications management in these salivary gland tumors. But let us see what is that we need to know, the little that we need to know of and must know to take this topic forward. One is non-neoplastic. When you say non-neoplastic in your report, what is the implication to the surgeon? He is to just kind of follow it up unless the patient says, please remove it. Okay. So otherwise, surgically, the case will be followed up. When it comes to benign tumors or low-grade carcinomas, it is of limited resection. Okay. Now, so when it comes to high-grade primary carcinomas, it is going to be a radical resection with the nerve sacrifice. Which nerve are we talking about? Is the facial nerve. And the lymph nodes is the head and neck lymph. That's the cervical lymph nodes. So it's a major surgery. And when you have lesions which you were lucky enough to call it metastatic to parotid, probably it's only a lymph node resection because primary would be handled elsewhere. And when we diagnose lymphoma, it's totally a different platform. It's going to have a heme reference and treated accordingly. So if this is the rationale and guide to surgical management, so it shows that how important it is to rightly word your report of a cytology because it is pre-op so that the surgeon can be prepared accordingly. Now, what are the surgeon's priorities? So he always thinks, do I need to operate? If so, what type of parotidectomy? So these are the questions he has in his mind, and he looks forward to answers from a cytology report. So would he be doing an extracapsular dissection or a superficial or a subtotal or a total parotidectomy? Or is a neck dissection necessary? So likelihood that the facial nerve needs to be sacrificed. No one likes to sacrifice a facial nerve. It's such an important nerve for a human being for all the facial expression, and no one likes to give a consent for a facial nerve resection or sectioning. So it all proves that a definite cancer diagnosis is a must for any of these FNs that you do. So unless you're 100% sure, you cannot call it malignant because of the implications that is associated with it. So what's the cytologist's role? Yes, so we need to make a diagnosis as close to as it could be to be specific, as to at least say benign or malignant, if not name or give it a name, and grade the tumor if you think so, if it's malignant, whether it is low or high grade. So these two are a must. And mind you, FNA, normally the way we look at it in the routine practice, it's looked as a screening test. But in cytology of, that is in salivary gland, it is more than a screening test because you're going to give a diagnosis which could be as close as possible to guide the surgeon for a definite surgical management. So we should do and can do better if we use our expertise while doing this FNA. So let's know why Milan system of reporting. You know, the Milan system which has come into practice now, and you know that, there's a lot being spoken about. I'm not going to read volumes of this. There are lots of pros and cons, and the way that it has been evaluated by different authors, practiced by different pathologists. But one thing for sure, it represents a standardized, evidence-based reporting system for salivary gland FNA. And you know that we don't have a uniform system for salivary gland FNA, and hence the system has come into place. And it probably started sometime in 2015 in the OSCAP meet. It started as a simple idea shared among the colleagues, developed as one of a scientific plan for the Milan system. And I was lucky enough to be at that OSCAP meet. It was held at Boston, Massachusetts. And 3 months or 4 months down the lane in September, the meeting was held under the aegis of the European Congress of Cytology in Milan, and hence the name of Milan system of reporting. So it seemed a very ambitious timeline right in the beginning, but it came into effect very soon. And all the 3 cytology bodies, that is International Association of Cytology, European Congress of Cytology, and the American Society of Cytopathology, got together to bring this system in place. And what is beautiful about is its reproducibility. Suppose if one reports on this system, the same smears if seen elsewhere should also be, the report should be reproducible. It had 49 specific questions to the taxonomy, so they were handled by 515 international participants and 40 faculty from 13 countries. So a lot of effort has gone into this, and that's how this Milan system has made its appearance. We know that this kind of system of reporting exists for cervical. That's where it started, okay, gynec, and thyroid, bladder, pancreas, lung, as well as in breast cytology, and now we have it in salivary gland. So putting in the words of Leonard de Vinci, he says that knowing is not enough, we must apply it. And being willing is not enough, but we must do it. So that is what tells us that though we know about it, yes, how much do we practice? And is it practicable? Is it feasible? So let us look at it. And how much do we have to really know to do it? And it says nothing can be loved or hated unless it is first understood. So if it looks complex, I'm sure we are going to hate it. But if it is made user-friendly, and let us see, maybe it may get modified onto. And the third is the noblest pleasure is the joy of understanding. And that is why we are all here today. So this Milan system of reporting, like the other systems of reporting systems, they are classified into non-diagnostic when we have a very insufficient cellular material for a diagnosis. The second is non-neoplastic, when we are very, very sure that we don't have anything which is proliferating over there, but probably related to inflammation. And hence, this is more or less looks easy, looks comfortable for people. But then sometimes when you have lymphoid infiltrate and you want to call it reactive and not lymphoma, etc., in certain institutes, a flow cytometry is recommended. And the third is the ATP of undetermined significance. So this is where the problem lies. This is sitting on the fence. I'm sure this is the same case in thyroid or anyway where the samples are indefinite for a neoplasm. So the cytologist is not sure whether it is a neoplasm or reactive. So we always say in this, when it comes to this particular ATPR of undetermined significance, a neoplastic process cannot be excluded after examination of all the cellular material. So this is indefinite for a neoplasm. And the last is the neoplastic. So if we look at the neoplastic, we have benign. It is exclusively reserved for the benign neoplasm, which come under this entity are the pleomorphic adenomas, the basal, the Watkins tumor, the lipomas, the neuromas, etc. Now we have the most important, the so-called SUMP, that is the salivary gland neoplasm of uncertain malignant potential. And it is exclusively reserved for FNA samples that are diagnostic of a neoplasm. But then you're not sure, because of their cellular, you're not sure whether are you dealing with a cellular benign lesion or a neoplasm with atypical features edging towards malignancy, which is of low grade. So this is a section which we need to worry about, we need to be very careful about, but this is, sitting, trying to between cellular benign and a low grade malignant. So that is known as the SUMP. And the fifth one is the suspicious for malignancy. It is for features that highly suggestive of, but not unequivocal for malignancy. This is especially for the high-grade carcinomas, which are on histopath follow-up, because you do not know. It says that an attempt should be made on histopath examination to subclassify the neoplasm. Okay, so which type of malignant tumor is suspected or provide a differential diagnosis is what is needed to be put under this entity. And of course, the malignant is when we are very sure and we go about it and subclassify if possible to say what type of tumor it is, whether it's a mucoepidermoid, if so low grade, high grade, etc. So why are we to divide them is because of the risk of malignancy, like any other reporting system that we have. But what is very interesting in this is that when it is of the SUMP, it carries as much as 35%, and hence when in such a doubt, straight away the surgery is indicated. So what terminology you use in your report depends or it leads to the type of surgery, because it also tells you the percentage of the risk of malignancy. So there is no doubt when it is suspicious of malignancy or malignant, it is very high. Now coming to salivary gland, to a normal, so we go on to the cytology part of it. And we need to know that there are three major salivary glands. One is the parotid gland, and with the Stenson's duct. Are you able to see my cursor?
Yes, ma'am, we can see your cursor.
Okay, I just thought I use a felt pen. Okay, oh, that is not good. Okay, I'll change it. No. Sorry. Okay, I'll take it to the arrow itself. So the parotid gland with the Stenson's duct is the most important, was one of the majors. The second is the submandibular salivary gland with its Wharton's duct, which opens at the undersurface of the tongue. And the third is the sublingual gland, which has multiple small ducts which open again on the undersurface of the tongue. Apart from three major, we have hundreds of minor salivary glands which are not obvious on gross examination, but possibly with microscopy alone. So do they pose a problem for us? Yes, I think so. We need to be aware of it, and probably we have a few cases which we'll be discussing on them. Now, the terminal duct lobula unit, or so-called ducto-acinar unit, has the acinus at one end with the myoepithelial cells at the periphery, so that when they contract, they squeeze out the contents, nothing but the secretory granules, which are secreted into this intercalated duct, and later on to the striated duct and the excretory duct. So each one of them is important for us to know, because the various types of lesions that arise from each one of them are going to be different. And that is why this little attention to the microanatomy. Now, this is the normal histology. So we have the acinar cells, and we have the small intercalated ducts lined by tall columnar epithelium. What you need to know is the adipose tissue around it. But can you pick up the myoepithelial cells in this? No, which is a very important component, and hence a calponin, if done so, will identify the rich myoepithelial component of this salivary gland tissue. Now, this aspirate, when we look at it, we could see the acinar cell component, where the cell outline is indistinct. They have a very finely vacuolated cytoplasm and nucleus, which is large but vesicular, but no nucleolus. And they usually in such tight clusters, and the secretions may ooze out, and they may have little granularity. The so-called zymogen granules would be at the periphery. Whereas these are the monotonous sheet of the ductal cells. Okay, they are the classic epithelial cells, and they are monolayered, and they are very often interspersed. So when we aspirate, it's quite often that you could get both of them in the situation that you are in. Now, this is one aspirate. You would see that I would be focusing on smears, which are probably PAP or Leishman or H&E stain. So depending on the scenarios that we have been, many are comfortable with H&E stain because they help them to collate with the H&E paraffin section, but nothing like looking at the Leishman stain for the background stroma. Now, this is the nothing but the acinar cell components, and here is the ductal component. So very distinctly seen, and in the background, we have a few RBCs. So this is purely a ductal epithelial component, the surface of which is like palisaded. This is an acinar cell. So this is how you look like, they are a conglomeration of cells. Some people may look at it as a giant cell, but it is not. It is rich in granules, and it is a acinar cell. Same so here. Now let's look at this case. So I will try to evaluate situations using the cases that I have encountered. This is a 40-year-old male with bilateral painless enlargement of the parotids. So when it is bilateral enlargement, and it included even the submandibular. So the best way to focus is look straight at the person, and you can make out at the enlargement of the parotids on either side. And for submandibular, the patient has to elevate his neck. Now, this is the aspirate that we have had. You see that there are nice clusters of the acinar, quite cellular. There's several fragments of them, and the background shows some adipose tissue. This is the higher part of the same to show the intermingling of the adipose tissue with the salivary gland material. Now let's go higher on to this. These are nothing but the acinar cells. Agree with me? And these are probably look more eosinophilic. These are the intercalated ducts. because they are three-dimensional, the photograph, the image doesn't look well focused. That's always the problem. And they are pretty thick because you cannot try to crush them because they are so rich in all these granules. They are quite, like balls they are. And this is the fat around. You might be stressing, you might be asking me why I'm stressing on the fat around these lobular units. And to get to see the ductal cell plate very clearly, you see the acinar cells go out of focus. So this is this is how you see a monotonous sheet of ductal cells. So they look like as if they are of normal morphology. Only thing is you have quite several clusters of the ducto-acinar units, and that you have lot of fat in between. Here is another cluster, so neatly seen, and you see some of these myoepithelial cells which are so fragile, they are in the background. So this is the close-up that some of them could also have vacuolation, fine vacuolation in these cells. So this was called as benign non-neoplastic with normal salivary gland elements. So, but why bilateral enlargement? Why submandibular gland involvement in this case? So that is where our role comes in we are basically physicians, aren't we? Maybe we are pathologists thereafter, but we have a patient here in front, and we are just not here to just look at tissue or material under the microscope. So the case is that this patient, okay, so the comments that were given to this is correlating with clinical scenario. So the clinical scenario in this patient was that he was a diabetic. So he had a metabolic disease, and we very well know that it is quite common to see this entity of diffuse enlargement of the parotid as well as the submandibular in the condition known as adenosis. So it's also called sialosis. It's a chronic inflammatory non-neoplastic bilateral or often painless enlargement of the salivary glands, most often affects the parotid and associated with malnutrition as well. And it's also to be due to autonomic neuropathy. So these cases do not need surgery, do not need management. They just need to be followed up. But if you tell the surgeon, yes, this is normal thyroid, he wouldn't believe. And hence this condition of sialoadenosis. So how does sialoadenosis differ from normal thyroid and normal salivary gland? Is because of the proliferation. There's so much of abundant salivary gland terminal lobular units that it tells you is there's a lot of material, but all in proper proportion. So, and hence the word sialoadenosis. So when we have this epithelial proliferations by neoplasms without myoepithelial or strobal component, one should think of normal salivary gland, which could be seen this way with the ductal component or sialoadenosis as we have demonstrated. Or one could see also in oncocytoma when the lining epithelial cells of the ducts become large and eosinophilic. So that case got biopsied because the surgeon wouldn't believe us. And here he shows that lobular enlargement of each one of those units. And close-up of this shows that there is some amount of myoepithelial component. This is just like the way we would describe adenosis in breast. So it is something similar to that. So this is sialoadenosis. Another component that might come up to us sometimes is when there is salivary duct obstruction because of the stones or the mucus plugs, or due to extravasation, the gland could be affected subsequently. And in such situations that this mucus, so when we aspirate, we may have a heavy load of mucus coming in our sewage, but you might miss the pathology which might be there. In this case, it could be a sialolith, or there could be a tumor or anything in the lumen that could be obstructing, causing this mucus collection. So in this case of cyalolithiasis, when it's a stone, one would be able to see lot of crystals. This I have taken from this paper. But am I audible? Sorry. Any issue, Dr. Anand?
No, ma'am, we can hear you.
Okay. So this could be a picture of cyalolithiasis. One would see a lot of crystals in the background, and we know that, yes, we are dealing with such a case. Or a simple cyalogram done will show a stone, and sometimes so much so one can feel across the skin such a big salivary duct stone. But this is a case which had baffled us. This was a 3 by 3 centimeter, which was a soft, non-tender cystic lesion on the right cheek, situated anterior to the masseter. Okay.
Hello.
And the whitish serous fluid was seen to flow from the orifice. And so what did the surgeon, he asked us for an FNA on this cystic lesion. And in the meantime, after we had finished, he did a xylogram. So we had an image. I'm sorry, this is a little old image, but you could see that there is a large cystically dilated.
Everybody's here. And this confusion is over. People don't know which side they're supposed to go. Everybody knows, no? C batch. Tomorrow, what practical you have? So this confusion should be clear. People are going from one.
And this is a cystic lesion, and this is filled with the opaque material. So this was the aspirate, which shows dispersed macrophages which have a vesicular nucleus shaped with lymphocytes in the background. Okay. And here are these macrophages. There is a very dirty background, lots of neutrophils. But in addition, we saw some structures which are round, which we thought it could be an artifact. It had something dark. We thought maybe epithelial, maybe the nucleus, which had shown some changes. Yes, which showing some degenerative changes, because the loculated mucin must have caused degeneration of the epithelium. But we were for a surprise when the lesion was sent. This was the dilated part, that was the cyst, which is lined on the surface by the pseudostratified epithelium, and underneath you have this large lymphoid aggregates, and we have this cystic structure with certain elements in them which are like small spore-like structures, which were nothing but the sporangia. So that made us go back to the smear and look for these. So we find many of these which we thought, yes, they must be the nuclei of some of the cells, but they were not. But these were the clear sporangia, the spirules of which we have a double wall, and this was in a giant cell. So this was something which we had missed out. And we said, yes, this is the final diagnosis, though we called it benign non-neoplastic and was a cyst. That was a case of rhinosporidiosis of the parotid duct cyst. So these are simple cysts, but yes, but it baffles us when we come across certain situations like this, and especially the rhinosporidium, because his treatment is going to be different. And I thought this was interesting from the cytology point of view, but then we mistook it for degenerated epithelial cells. So as we talk about the xylogram, this was one such picture which was very interesting. You see a snow stalk pattern of the salivary gland. And this is very often seen in Sjogren's syndrome, and so classic that the surgeon or the physician may not even do a biopsy of the mucosal glands of the lip, because this talks about the leakage of the contrast medium through the damaged duct walls. And this is supposed to be very, very classic. So we need to know about this. because many times we get mucosal lip, that is the biopsy, to assess the involvement of inflammation of the mucous glands. This was a 3 to 2 centimeter swelling in parotid in a HIV positive patient. Not very cellular, but scattered lymphocytes. They looked very, it looked like a double population. So it was nothing interesting for us. And this was another field. So we said, okay, and that we said non-neoplastic FNA, but it was a 3 to 2 centimeter swelling. It was a little firmish, but then if it was just lymphocyte rich, we're wondering how could one get only lymphocytes and no epithelial cell. So we said the nature of the cyst cannot be ascertained due to lack of the epithelial cell component, and asked for excision of the cyst. And the so-called cyst, or what you call it as the swelling, was this. This was the salivary gland, and this was the nodule, which felt cystic because of the contents. It was empty inside, filled with mucin-like material. Okay, this is the higher, lowest magnification. This is the salivary gland. This is the lesion in relation to the salivary gland. Okay, so it made us look as if it's arising in the salivary gland. But, and when we went closer, there's all the contents in the so-called cyst. And this is how it is. It was sort of very clear, probably had few lymphocytes. And the wall was purely lymphoid. And it showed cyst germinal centers with polarity. So this was nothing malignant. But something more to see in this, that there were few giant cells, multinucleate giant cells, and there were a lot of these cells which were going into, sort of giving a very unrest feeling to this lymphoid parenchyma. And the surface was covered by this something like an epithelium, which was nothing but the stratified squamous epithelium. So what we did was we stained with the CK to make sure that what type of epithelium, and this was cytokeratin fiber 6, and it was very classic. So we could see the epithelium covering the lymphoid, but it's not a lymph node, and there were secretions in this. A needle had gone into this, but had not touched onto this part. That is why we had no sort of cellularity because of the lymphoid cells in the smear. And this is how it shows the lining epithelium of the cyst. So this is nothing but a benign lymphoepithelial cyst. So this was called non-neoplastic, but then this was a HIV patient, and they wanted to make sure that such a big 3 to 2 cannot be ignored. So they biopsied. And this such a benign lymphoepithelial cyst is HIV associated. And the lymphoid hyperplasia is in combination with the epithelial component. And it is very classical with the lymphoepithelial islands, which I showed it to you. So if one sees lymphoepithelial cyst, remember that this patient could be HIV positive. So this is one of the few warm-up slides. 21-year-old female with 1 centimeter nodule in the parotid. And you will call this a granuloma, which is nothing but a 3-dimensional structure with having epithelioid cells. Okay, that's crisscross. And we say, yes, this is like a bata slipper shaped, or whatever you call it, that are a lot of lymphocytes. And if you see, there are many of them in the background. They are discrete, they are small, and luckily I could see one multinucleate giant cell. But yes, this prompted us to do ZN, and ZN was negative. But you know what, this patient had no other lymph node positivity. This was the only one. And they were said, yes, let us do a resection. And this was the specimen that was received. Here we see the lobules of the gland well preserved. And in each one of them, there is something like a granuloma. If you see, there is one, but there is no fibrosis if we go closer to it. Yes, in between the glandular component are these isolated granulomas. There is no fibrosis, there is no impact on this. So there is an element of early necrosis, and this was something unusual. The giant cells were at the periphery, yes, but no other lymph nodes did this patient have. Interestingly, this patient had ACE values very high, and it was concluded that this was a sarcoid. So the final diagnosis was signed out as sarcoid in this patient who presented with classical multiple, maybe the naked granulomas with multinucleate giant cells. So the FNA report was benign non-neoplastic granulomatous inflammation to rule out tuberculosis, sarcoid, which is always the runner should be. And of course, this patient with ACE values was confirmed later as sarcoid. Now, this was an FN that we see that there are numerous, it's very cellular, agree, but what is cellular? The macrophages, some exfoliated cells in the background. But there are no atypical cells. They seemed quite innocuous. Going closer, yes, there are a few neutrophils. The background seems a little dirty, but otherwise look, yes, and this was called as the branchial cleft cyst because of the location in the front of the masseter. So sometimes in this branchial cleft, one could see large epithelial cells, the squamous cells, which may be keratinized, and this might give rise to a lot of worry. So this is called as a mixed inflammatory pattern of the smear, and the diagnosis was benign non-neoplastic cystic lesion with superadded inflammation, and this needed an excision, and this is how it looked. So it was single. It was lined by lymphoid tissue. On the luminal side was this lining of the epithelium, which was very indistinct. So this was a mixed lymphoid pattern. So coming to branchial cleft cyst, what intrigues us is that as it arises, the first branchial cleft cyst is the most common, but it's related to the ear. Okay, and that constitutes just about 5 to 8%. But what we encountered is the 90% of the lesions are arising from the second branchial or whatever, rising from the pouches 2, 3, and 4. And they are the most important. And of course, the third and the fourth branchial cleft cyst we wouldn't come across, and that's not the topic of the day. And so one needs to be very careful of the branchial cleft cyst to look at the contents. One is it's got a very dirty background as demonstrated, and sometimes the surface lining epithelium may show a metaplastic change in like squamous and may give rise to a problem. Sometimes one may be asked to put a needle into the mucosals, but it is not worth it. They easily rupture. Same so with the ranula. These are a few surgical cases, but they are very straightforward. So when we have mixed inflammatory pattern as this, one should think of acute chronic sialadenitis, which could be always when there is an inflammation. Please look what may be the cause for the inflammation. It's the dictum in cytology that if you say, yes, there is inflammation, our duty is probably to say why the inflammation. Find the cause for the inflammation, because we have all gadgets with us. We have a microscope, we have the reagents, we have the various stains, we have the material. Moreover, we have the patient with us. So if we can pick this up, find the cause for inflammation, the treatment is so simple. The second is the granulomatous sialadenitis. The other one is the necrotizing sialometaplasia that one could come across. And of course, the last is the branchial cleft cyst. Now, coming to some situations that we could come across is the multicellular theory that has been ascribed to lesions that could arise from salivary. I thought I'll deal with all cystic lesions which so-called fall into non-neoplastic or category 2. So now coming further on, now we are dealing with something more cellular. The first one is the striated duct. When we have lesions arising from striated duct, they are the oncocytic tumors because they have a lot of mitochondria in them. You know, that is why you get oncocytic neoplasms. Sometimes tumors could arise from the acina cells. They could be known as acinic cell carcinoma. Excretory duct is they are lined by squamous cells, and hence you could get squamous cell carcinoma, or there could be some amount of mucin or mucocytes being involved there, so mucoepidermoid carcinomas. And when we have this intercalated ducts with myoepithelial cells, this is where you get the so-called pleomorphic tumors, pleomorphic adenoma, etc. So with this prelude, I'll take you to the salivary gland tumors, and they constitute less than 1% of the head and neck tumors. You know, they look like as if, yes, we need to worry so much, yes, because they are a concern for us. For one reason, yes, benign, malignant, if malignant, the neural invasion of facial nerve involvement is so tragic that is where we need to be very careful, diagnose these conditions before they involve the facial nerve. They're most common in adults. There is an increased frequency in females, especially the walk-ins. And we have first-line screening test, FNA. No, we call them now as little more than that. It can't be just screening. And as we all know and have, etiology is not known, so we do not know what causes the salivary. So these are some rare things that are associated with salivary gland tumors, and the clinical staging here is very important. IHC is slowly catching up when all our tumors have our IHC well laid out, but in salivary, just about the last 3-4 years, I think the first paper came up in 2016 to 17, as to say the new method in diagnosing and confirming salivary gland tumors, and followed by the molecular techniques. So the rest of it otherwise has been the same for the last so many years. Now coming to the distribution of tumors in the major glands, whatever it is, parotid has the highest, 70% of the tumors are in parotid. And the other 20%, you know that this is in minor salivary gland tumors. So mind you, that when we talk about 70 in parotid, the other 20 are minor. So the hundreds of minor salivary glands all over in the head and neck. And of this major, 80% are benign. So we can have a sigh of relief when we say, yes, 80% benign. But what about the other 20%? They are the mucoepidermoid, the adenoid cystic, and the other subequivalent. So when you are doing an FN, yes, most likely that you're dealing with tumors of benign are likely to be. Next comes mucoepidermoid. So mucoepidermoid is the most common malignant tumor, followed by adenoid cystic. Now coming to minor salivary glands, the palate is another one which gives a lot of headache, and that is where one can get salivary gland tumors. You can get in the upper lip, tongue, cheek, etc. And the tumor type again is the pleomorphic adenoma in the minor salivary gland, but it's only in 40%. So what does that mean? 50% are malignant, 50% are benign. So the general rule, as Dr. Bose was stressing upon, the smaller the gland, the involved salivary gland, the higher the possibility of tumor being malignant. Suppose you are dealing with the sublingual gland or the palate, may most likely that you're dealing with malignancy, 50% chances. Whereas if it is parotid, etc., it's only 20% chances. So the benign versus malignant. So smaller the gland, higher the chance that the tumor is malignant. Now coming to this parotid mass in a 50-year-old male. These are classical slides. I'm just going to go over it quickly. This is a very cellular aspirate. You find it has a cellular component, which is epithelial. It has a myoepithelial component, which we see as small, round, oval to round cells with very fragile cytoplasm. Many of them are bare, and we call them as naked nuclei, and amount of much stroma in the background. Not very clear, but we'll have to look around. But you could see that there is some stroma which are stained pink. And here we see them, at the, surrounding each one of these cells. This is, you see that they are rather fibrillary. This is the stroma, and, very bland appearance, quite cellular, very nice spread. Okay. And this is how it's likened to a Christmas tree pattern. This is so classical. The bright magenta, the color that the stroma picks up, the myxoid background takes up, emits this myoepithelial cells, is very, very classic of pleomorphic adenoma. So when we have epithelial neoplasm with abundant myoepithelial stromal component, we need to think of, yes, that's definitely not simple. It's not neoplasm, it is a neoplasm. And are we dealing with pleomorphic adenoma? So there is no nuclear changes, there is no atypia, very good, very well behaved cells. So we would consider this as pleomorphic adenoma. So this pattern arrangement helps, at least helps me to look at this, come to a conclusion much better than just thinking otherwise. But is it malignant? I don't think so. We don't have any of these features which makes it malignant. So we are dealing with pleomorphic adenoma, where we have epithelial neoplasm with abundant myoepithelial stromal component. I've just taken pictures from here to show how one could have so much of myxoid material in the background that the myoepithelial cells may look like, the classical glandular pattern, or they should be a pseudocartilaginous pattern, or it could be that you will see the clear cell nature of the myoepithelial cells giving sometimes a clear cell pattern. Okay. And this thought a little bit of history, why pleomorphic, I don't know why I called it pleomorphic in the first place. It has given, gives it a lot of problem to our undergraduates because it's pleomorphic. They call this tumor malignant. But it is not meant to describe the atypical cells, but it's meant to describe what affects the mesenchymal metaplasia that is seen with the myoepithelial cells forming it. So what could one see as mesenchymal metaplasia is the stromal changes, which may look like chondroid or myxoid, or chondromyxoid or osseous sometimes, so much so, and adipose tissue. These two are very rare. Adipose is extremely rare. Chondroid and myxoid is the one. But once upon a time, this was thought to arise from multiple germ layers, and hence the word mixed tumor. Okay. So the most important of this is the epithelial cell showing squamous differentiation, or it may show oncocytic differentiation or mucus. So this is where the metaplastic component from the epithelial cells, or it could be even from the myoepithelial cells, where they may look like plasmacytoid, or they may look oval shaped. So this is how the various two types of cells in the pleomorphic adenoma. Sometimes the aspirate could get keratinized cells. So that gives a lot of problem, anucleate squamous. And this we had in a case, it was a very small, tiny nodule, which prompted us to call this a keratinous cyst. We couldn't even get to see any other element. And our needle had gone into this huge keratinous cyst-like areas in case of a pleomorphic adenoma. So one must be careful enough to do a FNA which is multidirectional, aspirate as much as possible, but be careful, watch out that you don't hit the facial nerve. Sometimes squamous metaplasia can be quite worrisome and they may also undergo calcification like this. Or you could have the matrix, which is so abundant, okay? And someone could also see mucinous metaplasia. So when our FN goes into this is where the problem comes. Oh yes, I am seeing mucin, I am seeing squamoid cells, am I seeing this? So is it mucoepidermoid? So this kind of worries do come across. And that is where we said, yes, salivary gland has a very complex presentation, complex morphology. That's where we sit at the fence. Sometimes one can see crystals which can come in your smear and someone could get even adipose. This is where myoepithelial predominant aspirate. So then one could even call this a myoepithelioma because this has nothing but only myoepithelial cells. So, but the problem will arise, in those cases when you see that the mass is rather huge and it looks irregular and it looks matted. And the matting could be because of this, sometimes with capsular extension that one can see. And this was a case that we had multiple pseudopodia of the nerves, of the pleomorphic adenoma tumor part in the periphery, giving rise to recurrence in this patient. Probably 2 or 3 times this patient underwent surgery. So much of pseudopodia of the so-called the main tumor into the adjacent soft tissue. So they have the myoepithelial component and the stroma. Someone looks at it, thinks as if it is a nerve sheath tumor, but it's a pleomorphic adenoma. So this is such a beautiful case. I thought I'll just share it with you. Okay, so pleomorphic adenoma, as we know, yes, benign epithelial tumor, but it has such a variable epithelial mesenchymal transition that it gives a lot of worry for the pathologist. And also the variable degree of secretion, as well as the differentiation, as well as the many types of metaplasia. So I always say pleomorphic adenoma with many phases. So we don't know which phase is one that comes up on our table when we have to diagnose it. So these are some, but when we do special stains like SMA, calponin highlights the myoepithelial component, and they are as well as S100 positive. Now coming to the parotid mass in a 35-year-old female, it's a parotid mass, okay? Quite simple. Let me just, I think this way, I'll just shift it, yes. So this was aspirate from the parotid. Yes, it is very cellular and very cohesive clusters. And we find, yes, there is some amount of myoepithelial cells, but what is very typical is, it's like a pajama pattern that we normally describe for aspirates from the GI mucosa, when we get to see like that. More of this, yes, very bland looking, but there is peripheral palisading. See the peripheral palisade wherever you see it, very distinctly seen. There is there is so much of overlapping because they are 3-dimensional structures. So your needle has pulled out that as such. So this is how it is, very bland looking. and very cellular, but no nuclear atypia, no, apart from few myoepithelial cells, but the lesion doesn't seem to be otherwise, angry looking. So this is where, it was a cellular, we call it as a cellular tumor, benign, and most likely to be not a pleomorphic, but a basal cell adenoma. So the diagnosis was cellular aspirate neoplastic benign favoring a cellular pleomorphic adenoma bar basal cell adenoma was the diagnosis. Now coming to this 50-year-old female, yes, we have this cluster right in the center with lot of neutrophils. So this lesion being closer to the oral cavity, and that it might be in relation to a duct or whatsoever, we could have lot of inflammatory changes in relation to the tumor. But here you see there is lot of epithelial component which is turning oncocytic, and much more of this very classical oncocytes, cytoplasm where the nucleus is in the center, very granular cytoplasm. So I'm sure all of you would be thinking it is nothing but arising from the intercalated ducts is the Watkins tumor, where we have the ductal epithelial cells and and the lymphocytes which come in, giving rise to the classical Watkins tumor. So it's also called was called papillary cyst adenoma, lymphomatosum, but no more. It is called as the Watkins tumor. So the lymphocytes and the glandular component could vary. The lymphocytes most often are of double population, sometimes maybe so little and maybe only epithelial component of oncocytes, giving rise thinking of an oncocytoma, or only lymphoid where someone would think it could be a lymphoma. So it depends on what we aspirate. So here is, we have a very cellular smear aspirated from a parotid mass. This is the trail, and going closer, yes, these are the several cellular clusters of epithelial cells, very classically have cytoplasm which is rich, eosinophilic, granular, and very classically goes in for an oncocytic, and this is how it is. But the rest of the smear had this kind of an aspirate material where it is sheets of polymorphs, and sometimes we're seeing these kind of cells, one kind of mitosis here, very pycnotic nucleus in some, but large. So are they degenerating epithelial components, or are they truly atypical? Here are some more. Here is something like a tadpole shaped. Okay, so this is how one would think, yes, are we dealing with something, atypical in this so-called Watkins tumor? If we do a PAP, those keratinized cells may look like this, become very worrisome. Are we dealing with malignancy? So this is where we'll have to sit at the, be very careful when calling it. And I would put this under the sum. But this is a very classic Watkins tumor, unlike what I had shown. Here you have oncocytic with lymphocytes in the background. So when we have lymphocyte only pattern, this is where one would think whether it's reactive benign lymph node or malignant would be a malignant lymphoma. But this was a cystic lesion with squamoid cells. The question could also come whether it could be a squamous cell carcinoma in the background of a Watkins. But when resected, it was a classical Watkins, and these were the contents which were aspirated, and probably they were all degenerating. So we were taken for a ride of a simple Watkins turning out to be, we thought it could be a low grade carcinoma. So this is nothing but a classical Watkins. Now this aspirate, if you really look, you have wisp of cytoplasm for these cells which are single and scattered. They all look the same. They have oval nucleus, but cytoplasm very wispy. So whenever we have a cell with the nucleus which is oval, and that too from the parotid, yes, John, you need to be careful. Some look like they have a little more cytoplasm, but they are all oval shaped, yes, and some have nuclei which are larger. But these are nothing but the myoepithelial cells. This was from a classical myoepithelioma that was diagnosed in the parotid. So this is how the myoepithelial cells look. Okay, sometimes instead of they being oval, they could be round, but they have a very fine nucleus and cytoplasm because it is so delicate that you may not appreciate. So it all depends how well one makes a smear. If a little pressure is put, they could become naked, or if not, if little thicker, you can appreciate the wispy cytoplasm. So that was myoepithelioma. This is a very classic, you know, the hyaline bodies rimmed by the baseloid cells. They look baseloid because they don't have much cytoplasm, very large, I mean, not very large. They have a dark nucleus and they seem to be running. And they are seen in between these eosinophilic acellular globules and very classical of a adenoid cystic carcinoma. So there is no other diagnosis than calling it an adenoid cystic carcinoma. Very, very distinct, very classic. And this is from the FNA of that tumor. This is where you get to aspirate the adenoid cystic. So this is a very classic, nothing much more of it, I'm sure, will be dealt by Dr. Rajendran subsequently. But this is, you know, how could one guess, one hint at, you know, when you're doing an FN, is that if the patient complains of severe paresthesia of the face, yes, or something to do with, you know, when you aspirate, you know, the material is very mucoid and the patient is, you know, very uncomfortable, and the needle, when it goes in, gives rise to that, you know, as if the nerve has been hit. You know, this all indicates of neural involvement in these patients. So here is you have neural invasion, perineural invasion by the tumor. So very distinct that one can get in adenoid cystic as well as in salivary gland. Next is the 20-year-old parotid mass. Here we have a mix of cells. We have an epithelial component. We have some amount of stroma. Do we have some myoepithelial as well? Maybe, but what is very striking is this myxoid, or is it myxoid or mucinous background? It's mucinous, they don't have cells. So probably it's mucinous. Here is some acinar cell component. Okay, so we don't know what we dealt with, but the specimen came along very quite distinct. So what we were dealing with was this normal salivary gland here, and we had large cystic spaces which were lined by tall mucin producing epithelium. So we were dealing with a very well differentiated or a very low grade mucoepidermoid carcinoma. So it has the mucinous or the mucocytes, and you have the epidermoid component, I'll show you later, and the intermediate cells. So it was a low grade mucoepidermoid carcinoma. The situation is not so simple sometimes. This is where one would appreciate the intermediate cell component, this part of the cyst. Okay, I'll show you on. And when we do AB pass, it will help us to pick up the so-called the epithelial, the mucin filled or the mucocytes. And here we have the cells which are in between the epidermal and the mucosal, not so well differentiated, they constitute the intermediate cells. Sometimes it's not very clear in which direction they go to. Some of these cells have finely vacuolated cytoplasm, and here is your mucin-filled cell, very classically seen in mucoepidermoid. Sometimes the stroma could be so hyalinized and may look as if we are dealing, as you get in your aspirate, one may get this kind of hyalinized stroma as well. So lymphoid background could be seen, which could be host response. This is where the mucin producing one. I'll jump this because this will be dealt in great detail by Dr. Rajendran. Now this 30-year-old with the right cheek swelling, you see that the aspirate is so cellular, so much so it's abundant. The cellular component here, the nuclei are very, very small. This is taken at 50 mu, that is probably at 1.25 magnification. And here we have a cellular component and we have a second component in the background as well. And these are looking at the morphology very much similar to that of the acinar cells that we saw in the initial slides. But you see that many of these have come out into the periphery as Bay nuclei, and they have the same nucleus as that of this. So tells you that there is so much proliferation of that of these acinar cells, and they have a lot of granularity of the cytoplasm, which is also appreciated in the background. And closer view, some of them show some amount of clearing, but they are all pretty small. They are three-dimensional structures, and this is how they are. You can't draw an outline for these cells. Very rarely that you can, but they resemble so much like acinic cells, and they have nothing else but other than acinus. This is how the so what are we dealing with is an acinic cell carcinoma. Okay, this is the close-up of the view. Sometimes one may get to see some lymphocytes as well. Some may see macrophages. There could be some amount of cystic change. So the acinic cell carcinoma is one neoplasm of cells differentiated towards serous acinar cells. They are rich in zymogen-rich granules, and there could be some clear cells, but there is no grading system for this tumor. So unlike the mucoepidermoid, but it is known that they may go in for what is known as a high-grade transformation that has been described for these acinic cells. Now, the marker that has been used for the acinic cell, there, in this article which I was talking to you about is in Archives 2017, where they talk about new developments in salivary gland pathology, where they talk of the use of S100 and DOG1. So the S100 stains both nucleus and cytoplasm in the acinic cell carcinoma, as well as in DOG1. Here, you see that it is a membranous staining for these cells. So it is very, very classic of acinic cell carcinoma, where someone, this pattern of so-called tubular pattern in acinic could be confusing with other lesions. So that is why the DOG1 would prove that this is acinic cell carcinoma. This cellular aspirate with much mucoid background would prompt us worry. Yes, it looks quite cellular, but the background is very dirty. You see that bluish stained particles are of varying sizes and shapes. They look like nuclei, bare nuclei. They don't look normal. They look truly atypical. Going closer, yes, they have an abundant cytoplasm, but true nucleus is of varying sizes. Yes. And some overlapping. There's so much over it. But you also see that there is some pale staining cells in the background. Here again, This cell, maybe it's in mitosis. Yeah, here is your, yeah, something looking like a signet ring cell. Yeah, much abundant cytoplasm. Some look like like squames. Here is mucin, finely vacuolated cytoplasm, some of the large cells. Here, this looks like more epithelial-like, right? Abundant cytoplasm, centrally placed nucleus. More of it, there is a difference between this cell cluster and this. And here you have mucin or mucocyte, some people call this. Here it is. So what are we dealing with? So much of mucin in the background with those kind of cell clusters. Here it is, very cellular material with lot of pleomorphism. So it is nothing but we are dealing with a mucoepidermoid carcinoma. So was that so? But this was in a parasagittal sublingual space. So anything arising from the sublingual space, we said 50% chances that it could be malignant. So it was thought of a mucoepidermoid because it had so much of mucin component. Actinic cell carcinoma was thought because there were smaller cells in the background, and that whether the cyst, you could have large cystic spaces in the actinic, and that is why that material of so-called mucinous material. And in some areas, so much smaller cells and bare nuclei in the background, so that was a cellular basiloid. But on surgical excision, it was proved that it was a low-grade mucoepidermoid. So when it comes to mucoepidermoid, so we call that as epithelial proliferation neoplasms without myoepithelial component, and the conditions that one may look as differential. So if you keep this in mind, this makes it easier to think. If I have mucoepidermoid, what are the differentials? These are the way it goes about when it comes to without having myoepithelial stromal component. So it could be an adenocarcinoma or a salivary duct or a squamous cell carcinoma very remotely or sometimes metastatic. So the excised specimen showed very distinct mucocytes, yeah, and a nucleus which is pushed to the periphery. So that makes it all a low grade. This was a large cystic space in the tumor. So these varying patterns that one could see in these salivary gland tumors is very perplexing. CK5/6 on this proves that it has a small myoepithelial component which can be missed. It's P63 positive, so goes towards mucoepidermoid, and SOX10 negative, where the normal salivary gland showed nuclear positivity. So absent SOX10, this confirms it to be a mucoepidermoid. This is interesting. A 34-year-old man had this swelling over the cheek. Okay, it was in the parotid, and it was very tense. So a needle, while aspirating, the pain was so it was so much that this 34-year-old male just started screaming at the top of his voice in the outpatient. So we said, oh my God, what is wrong? What is this that we have gone? Quickly we came out with some material, and it took some time, nearly 2 hours, to get this man into normalcy and send him home. So we were wondering why it is so. And when we looked at it, we had this kind of cellular aspirate, which was spindle shaped. Okay, and they had some kind of vesicular nucleus, coma shaped, right? And cytoplasm is rather fibrillary, and that made us, this is the kind of material, streams of spindle shaped cells going So we said, yes, this has been a very robust FNA that is done, and no wonder that man must have screamed. But the thought came in, why this spindle-shaped cells? And there you have this fashion, the way they are arranged. Does it ring a bell? So this was thought of as a benign nerve sheath tumor. No wonder this person had such severe pain. And this was excised, and that turned out nothing but a schwannoma. So this was a schwannoma in the region of the parotid. So you could have soft tissue lesions also mimicking like a parotid, but may land up with this kind of scenarios. So this is a story where we thought it was thyroid. I'll tell you how it is. Do we have the time for it? Maybe 5 minutes, yes. It's a grade 2 goiter, and it was very hard in consistency. And this was in a 35-year-old female. So it was a nodular surface, and the lower border couldn't be made out, and it moved with deglutition. So it was a grade 2 goiter. It was quite significant, and it was hard in consistency. So anything thyroid, a goiter which is hard, is worrisome. You know, we are used to having it soft, you know, where the needle just goes in and comes out with ease. But here we had to push in a needle very hard and do an FNE. And this thyroid scan showed that there was enlarged thyroid gland, and there was submandibular lymphadenopathy, but in addition, there was a laryngeal stenosis. And this FN showed lymphoid cell clusters and some fibrin in the background. And these lymphocytes were of double population, and we had the Hürthl cells. Okay, so it fitted well. Yes, this is Hashimoto's, right? But that hard inconsistency, putting things together, we thought maybe it's a fibrosing variant of a Hashimoto's. So we had said suggestive adenomatous nodule because of some focal cellularity that we had. With atypia, with still, you know, sort of wanted to be little guarded because that hard inconsistency was baffling. So you know what happens? One like to sit at the edge, and called it Bethesda category 2 or 3. And hence, and this patient was rather dismal. So we knew that this patient would be taken up for surgery. And hence we advised, let's have frozen before they do any surgery. So the core, before they did the, for the frozen, they did before the frozen, they did a core biopsy. That's very interesting. And that showed Hashimoto's changes. So we were very thrilled. Yes, it goes in favor, it's a Hashimoto's. But we didn't see so much of fibrosis to give that feeling of hard consistency, which we noted when we palpated the thyroid. This is how it was. This was the core, and this were the thyroid gland, lymphoid aggregates, and that was Hashimoto's thyroiditis. Now this specimen came for frozen. So they excised it and sent it to us, that small little thing, and they couldn't go do a complete resection because it was tethered. So the margins were inked, and you know, smears were made. And these were the smears. I'm sure you know what I'm dealing with. This was nothing but adenoid cystic pattern. So the adenoid cystic pattern on the squash of the frozen made us, yes, wonder. And these were the frozen sections. You know, very classic that this was adenoid cystic. But they say, yes, what they have sent is a thyroid gland. So where were we? So what we did on FN was Hashimoto's. Now on frozen, what we are getting is an adenoid cystic tumor, carcinoma, sorry. So adenoid cystic carcinoma, query primary, query secondary, but we didn't see the Hashimoto's component in this tumor, in these frozen sections, because we couldn't take so many samples. Of course, we would take the most important, probably 2 were taken and done. So this proved, but the permanent sections came in. So this was a classical adenoid cystic. This is how it was. So classical, we had no other doubt. But here you see that there are nodules of the adenoid cystic carcinoma out. Here is the skeletal muscle. So the tumor has gone out. It is infiltrating. And so much so here we have some amount of fibrous tissue. And very interestingly, this was the part of thyroid. This was at one edge looking like the tail. So this was the only bit of thyroid. And we said, yes, the TrueCut had to go into this thyroid to make us diagnose Hashimoto's on core biopsy. How on earth did they miss this adenoid cystic on the core biopsy? So it tells us, this speaks volumes. It tells you that when you take core biopsies, you must take multiple. So at least you would hit different areas of the lesion. So, there are many lessons learned from this case. So the final diagnosis was, yes, adenoid cystic carcinoma now. Is it from thyroid? Is it primary or it's secondary? Interestingly, when after the resection, this is where the tumor was. This was the lumen. This is lined by the laryngeal epithelium. And this was the thyroid. So the tumor was arising. The primary was adenoid cystic in the wall of the larynx. And where could this arise from? It's one of the minor salivary glands. Again, so the minor salivary glands, they're so small, microscopic that we wouldn't see them otherwise. But when they when they come up with tumors like this, we are left high and dry wondering where they all arise from. This is also called as an iceberg tumor. So the tip will be seen, but it would be infiltrating all over. So the final diagnosis was adenoid cystic carcinoma larynx, and that was probably arising from one of the minor salivary glands, which are so multiple, seen all over from the palate downwards and infiltrating thyroid, and extrathyroidal soft tissue margins were involved, and it was associated with Hashimoto's thyroiditis. So the lesson learned are very, very obvious here. Yes, whatever the case be, clinical, radiological, cytology, and histopathology need to be correlated. To be a good cytologist, one has to be first a good histopathologist. So unless you know where the cells are coming from, for that you should know the histopathology very well. So kindly follow up all your cytology cases and look at the histopathology to see whether they match. If not, where are they from? So a lot of lessons learned from this. So it should be for every case that we diagnose routinely. But now when it comes to, I'll just tell you about the salithiasis. This is a left neck mass. It looks like hypoechoic. This is an aspirate cellular and it is non-neoplastic. One may see cyanogen granules. I'm telling you this because of the varied patterns one can see. And this was in a case of sialolithiasis. Now, this is again in pleomorphic adenoma. It looks hypoechoic. You have the classic stroma, and these are the myoepithelial cells. You have secretory carcinoma. You have hypoechoic lesion. You see that your ultrasound imaging is common whether you deal with a non-neoplastic lesion or a benign lesion as in pleomorphic or in malignant as in secretory carcinoma. So don't get carried away by what your radiologists tell you. You make your diagnosis on your smears first and then correlate with radiology and clinically, not the other way around. So the similar US imaging yet represent three very different diagnoses. This is something very, very interesting. It's from one of the articles that was published. So the recent advances that even FISH has been of helpful to differentiate between in situations where we have a problem between adenoid cystic mucoepidermoid secretory carcinoma. I wish all stick to their patterns, but they don't. They wear different masks and faces. So one can be anything at any time. And this is the IHC panel. I'm sure Dr. Rajendran is going to talk a lot more on this. And on cytology, we are still in babies level. So that is from me. But remember that when you have situations like this, one has to be very, very careful of what you look at, how is the patient, etc. For me, this pattern assessment is very, very helpful. And if you, any of you, I advise that you all go through the Pathcast video by Dr. Zarkaf of Mayo Clinic. It's very interesting and helps you learn the cytology much, much better. So thank you very much. Much without a do, and lot of from me and from my department. Thanks a ton for being with you.
Thank you, madam, for such a wonderful talk on a very difficult topic. I think Sandhya madam was the chairperson. Madam had to leave for another meeting in Ramchandra. So Chandra ma'am, Chandralumali ma'am will take over the chairperson.
Yes, I'm honored and privileged, ma'am, to have listened to your lecture. And I told you in the morning itself that it is really going to be a treat. So indeed it was. And it was an elaborate presentation with the emphasis on the right features and how we are supposed to go in a step-by-step manner to arrive at a diagnosis cytology-wise. So cytology is always a difficult topic when compared to histopathology. I feel, it's my personal opinion. Yes. And I think you have made it much easier in the, like in future, whenever I happen to look at any salivary gland cytology slide, I will have a more like stepwise approach and will be able to give a proper or an appropriate diagnosis. Ma'am, a few questions are there in the chat box. Can I ask them, Dr. Anand?
Yes, madam, please.
Yeah, so ma'am, one of the candidates have asked, is S100 positive in actinic cell carcinoma?
Yeah, actinic, yes, it is.
Okay, so differential diagnosis, cytology wise for actinic cell carcinoma, ma'am, what are they?
In differential diagnosis, one is, when there is a lot of proliferation is, yes, people will mistake it for ciliadenosis.
Yes.
Yes, that is when you get a lot of acinous cells and the actinic cell carcinoma, if your aspirate is not much, that is when one would think the other way. But the way to differentiate why, when you have proliferating ductoacinar unit in ciliadenosis versus proliferating acinar cells in actinic cell carcinoma, the differential is the fat content. I stressed on that, but I didn't talk about in actinic. In actinic, when you get whatever be the pattern, they're all small cells and nuclei are very small and you get no adipose tissue in the background. Whereas how to differentiate why is it not a normal is where you get adipose tissue definitely when it is of, say, for example, in the parotid, it is much more. The fat content in the parotid gland is much, much more.
Okay, ma'am. Thank you so much. And I have a question to ask you, ma'am. You were talking about the branchial cleft cysts in the beginning of your lecture.
Yes.
So suppose you spoke about the squamous metaplasia and the squamous epithelial cells, which will be seen on an aspirate in such cases. So in a known case of squamous cell carcinoma tongue, like we frequently happen to see such aspirates, like a known case of CA tongue, known case of CA larynx, cervical lymph node aspirate. If it contains cystic fluid and squamous epithelial cells with minimal atypia, how do we report?
I know it is very tricky. That is when you will call it malignant anyway, but you will give your possibilities.
Yes, so the differential is being offered, like it could still be a branchial cyst or it could be a metastatic malignancy, and ask for a biopsy, ma'am, or how do you go about it?
It has to be biopsy because branchial cleft cyst anyway it needs surgery. Your malignancy, yes, confirmation needs surgery because it's doubtful. And it is known that branchial cleft cyst in long run could be associated with squamous cell carcinoma. There are reports that have come up. So it could very well be.
Ma'am, what is your experience on immunocytochemistry? All of us have the habit of practicing immunohistochemistry, but do you
I suppose one could do very well if you have a good cell block. So I think we should have a good cell block and know how to make a good one and apply it for our FNAs. I think that's the only solution. If that is standardized, it can be very well done. But I think we should be good at reading the IHCs in the histopaths before we add it on to cyto. I think cyto and histo, it is a dual run. You know, we can't say, I'm going to be a pure cytologist. It's humanly impossible. So neither the histopath, because they will have to look at cytology sometime or the other. Sometimes cytology gives the answer, whereas histopath haven't. There are instances where a diagnosis has been based on cytology alone. That's very tricky again. So these are the issues. I think one has to be good in all the fields, try best and learn one from the other. But making a good cell block is an art, and that is where our technicians need to be trained. And we need to aspirate enough and try to save the material, if we can get for a cell block, not make enough and more smears, 10 smears, not necessary. What we need is 4 smears. The rest can always be placed for a cell block.
No.
I think cell block plays a very important role in FNA of any organ for that matter.
So when an aspirate doing immunocytochemistry, ma'am, what is your suggestion on that? Would you prefer only a cell block? Or if the aspirate smears are the only things which are available, would you go for immunocytochemistry?
I would prefer making a cell block. You know what, if you make the smears and you try to stain, see, the thing is adherence of the cell, chances of they getting washed off is very high.
Yes.
So unless you have standardized, validated, it is not going to be a smooth go. I feel whereas cell block can be treated as a section. So anyway, you do IHC for your histopath section. So in preparing a cell block, you would at the most require 2 to 3 hours. So the next day you could run them. So the cytopathology is, it gives one a kick. It gives a thrill. It's very challenging because we do not know the histopath, and you make your diagnosis from the top of your head or from your experience and say, this is it, you stick your neck out, as people call it. Whereas and that you do in such limited period of time. You have just a day, otherwise you'll have calls coming in. What happened to the FNAC? Because they expect the report to come, especially if you follow the principle of rows, rapid on-site. It is still worse, where you will have to give a report in half an hour, like the frozens. It's very stressful, but I think it's challenging. It gives a thrill. And especially when it matches your histopath, nothing like it. You feel on top of the world. Yes. Whereas with histopath, you don't have that thrill. I think only when you make a diagnosis on frozen maybe, but not otherwise.
Okay, so Anand, there are 3 or 4 more questions. If you would allow.
Yes, ma'am, please go ahead, ma'am.
Okay.
Yeah.
So, ma'am, another attendee has asked, I found difficult at times to differentiate between a pleomorphic adenoma and an adenoid cystic carcinoma. Your take on that, ma'am?
In adenoid cystic, you usually do not have, well differentiated cells. Whereas in, what happens in very classically, adenoid cystic will have those globules. If you do not see the globules, I'm sure you will be at a loss. You will also think, why not pleomorphic adenoma? But if you get a history from the patient that he has some kind of, very often, if it's been of a little long-standing paresthesia and all that, because adenoid cystic is well known to quickly find its nerve invasion. So those small things will help history. Otherwise, on a clear-cut case, it's very frank, adenoid can be differential pleomorphic, but sometimes one could have, but suppose if you, the cells in adenoid cystic are usually very, very basaloid. They show no differentiation at all. Whereas the stroma in pleomorphic adenoma is fibrillary and it is not in the form of a globule. So it is more into a masses, it's it is like a branching pattern. It just, one would see. But I think one would always say pleomorphic adenoma. That is when you would probably use the word sump, and we is probably say pleomorphic adenoma with probably atypical features and probably also add adenoid. Anyway, both need surgery, so they need to be excised.
And another participant has congratulated you on your presentation and also has asked, is reporting under Millen system to be considered for FNAC of salivary gland lesions? Will surgeons want it?
Unless you have sat with them and told them this is how we are going to report on it. I suppose, yes, before we implement it, you will have to have a detailed discussion and probably a session with them. Otherwise, they wouldn't be able to appreciate what you're talking about. Same thing happened with thyroid, Bethesda category. But unless they know the percentage that is risk of malignancy, they wouldn't be able to appreciate your classic Millen system or Bethesda grading. So I feel before you apply that, first, I think you will have to apply your pattern-based approach to a diagnosis, and then come to a certain level of deciding as what would be your number one diagnosis, how would you rule out the others, and then apply your Millen system. But all this, whatever you apply, it has to be done in conjunction or with understanding and teaching with the surgeons. Otherwise, it wouldn't be effective. See, when you give, there should be a taker as well. So I feel surgeons also should understand what you're speaking. If they don't, then whatever you apply is a waste.
Okay, ma'am. So how do we differentiate the hyaline globules of adenoid cystic carcinoma from a basal cell adenoma? Is it significant?
They're very close. They are very, very close. That is when they come together. Cellular basal adenoma and that of an adenoid cystic. Very difficult to differentiate at times. That is when, this is the one area where, surgeons make fun of us really. They say, you can't say when it is benign and when it is malignant. You say this can be malignant also. And at one time you say this can be benign also. These are the situations because the tumors don't read our books and come, right? So we have to, with our experience, we have to burn our fingers at times, get to learn, make mistakes and learn. But best is to say why you're holding back the diagnosis of total, complete malignancy. Yes, I would say give the possibilities and then think of the possibilities and then see where it can fit into your Millen system of grading, of staging, of reporting. Sorry.
So that is all, ma'am. Thank you for your patient answering of all the queries of the participants. And for the excellent presentation and clarification of whatever doubts we happen to have on cytology.
Ma'am, if there's, hello, good afternoon, ma'am. At this time, can I ask one rapid question, Dr. John?
Yes, sir.
Ma'am, I would be very interested to know about this category AUS. It's a largely unknown category. Where does it go?
Sorry, I didn't get it.
AUS, madam. It's a largely unknown category. What do these lesions land up as? Are they largely benign or they turn out to be malignant? What's your experience with the AUS category, atypia of unknown significance?
Atypical, this is the one which you don't know what you're seeing. You don't know in which category to put it. It is sitting on the fence. It could be this or that. And I think it's a waste paper basket if you ask. And it shows that the slide, it's best that it is looked at by many other people so that you come to a consensus and make a diagnosis. I think it's the same problem even in thyroid. It's the same problem even in cervical cytology. They have said, yes, the so-called SEAs should not be, used very, what is it called? very easily. You know, there should be a way to get over it. But at times I wonder why we have that entity, because many things can fall in, but at the same time, surgeon wouldn't know what to do. I wouldn't be happy using that term. I would go by the pattern-based approach, make a diagnosis, and make sure, first of all, at all times, that I have adequate material on my sleeves. If there is no adequacy, I will never make an attempt to make a diagnosis. I may be going wrong. And I would rather go a second time and aspirate to get a cellular material than report on a scanty material. So when you have very few cells and you don't know what they are, that is when I think probably this vague terminologies will be used, but I don't know why we have. I'm sorry, I do not know more on that, Dr. John.
Ma'am, S100, is it used to differentiate the actinic cell carcinoma from secretory carcinoma? Is another question from one of the participants.
I think this will be highlighted. I didn't want to put that up here in cytology because none of us really practice so much on it, because secretory carcinoma is the mammary analog one. And I think it's best, you know, talked about in histopathology and, you know, and the whole pattern, the entire gamut. I had slides, I removed them because in the FN, first of all, to make your initial diagnosis is so tough rather than go to specialized entities. So I would keep it that for Dr. Rajendra.
Yes, thank you so much.
I have one question regarding diagnosis of a high-grade adenoid cystic carcinoma. When you're going to have more of solid areas, and if the aspirate is from that area, predominantly it's solid areas, and what would your differentials be, because it's not going to be having much of atypia also. So
much of atypia may not have much of stroma as well, which are so clear.
Yes.
Oh, yes, that would be a problem. So it would be, it all depends how much of that stromal component would you have in this. So it all depends. Unless you have a case, I think it may be difficult to talk.
Okay.
I'm sorry.
So, Chandra ma'am, if there are no questions, we'll conclude the session.
Nothing more elaborate.
Okay.
Questions. So
Yes, ma'am. So thank you so much, Ushakini ma'am, for such an effort for us to spend so much time for us, and Chandra ma'am for chairing the session. This is your certificate for speaker, for recognizing your efforts as a speaker, and we'll send it to you by email and hard copy, ma'am. Tandk you.
Thank you so much.
This is for Sandhya,
it's wonderful being with you. And thanks to Dr. Chandra as well as Dr. Sandhya. I knew she was busy today and yes, I crossed by 5 minutes. I'm sorry.
No problem, madam. No problem. It was our pleasure. It was our luck to hear more from you. Thank you. Thanks a lot.
Thanks a lot.
Okay. So,
if there are any questions, let me try to relook for my answers for some of the questions where you know, things could be made easier, and maybe I'll get back to you. Maybe you could, you know,
sure, ma'am. We'll communicate to the participants.
Yes, sure, please.
Thank you.
Thank you.
Thank you.
Thank you. So I think our next session by Rajendran sir on recent advances. We were going to have a 10-minute break after this session. So I think the time is around 3:20. So 3:25. So maybe after 10 minutes on 3:35, we can start Rajendran sir's talk. So we'll have a 10-minute break for all the attendees and we'll resume after that. Thank you. We're going to pause the session for about 10 minutes. Thank you.
Thank you.
So shall I log off?
Yes, ma'am, for about 10 minutes.
Yes, sure.
நீங்களும் போய் பிரேக் எடுத்துட்டு வாங்க.
சார் நான் கையில காஃபியோட இருக்கேன் சார். தெம்பா இருக்கேன். நீங்க வரணும்.
மேடம் பார்த்தேன், போட்டோல பார்த்தேன், பின்னாடி உங்களுக்கு காபி வந்துச்சு. இதெல்லாம் அநியாயம் அதெல்லாம்.
சார் வெயிட் பண்ணலாம்னு பார்த்தேன். ஆறிடுச்சுன்னா என்ன செய்யற சார்? which is more important I thought. So I
காபி தான் மேடம் முக்கியம். காபி முக்கியம் பிகிலு. காபி முக்கியம்.
அப்பதான் I have to freshly listen to you இல்ல சார். நீங்க ஃப்ரெஷ்ஷா அப்பதான் ஏன்ச்சிருக்கீங்க. So gearing up for your session.
ஃப்ரெஷ்ஷா எழுந்திரிச்சிருக்கேனா ட்ரீம்ல உட்காந்துருக்கேனான்னு எனக்கு தெரியல, பாப்போம்.
4 AM சார்? அங்க என்ன சார் டைம்?
இங்க 4:55. 4 o'clock எழுந்திரிச்சு 4:30க்கு வந்தேன். 4:55. உஷா மேடம் டாக் கொஞ்சம் கேட்டேன். இட் வாஸ் வெரி நைஸ். ஸோ மேடம், யூ கோ அண்ட் ரிலாக்ஸ் மேடம். ஐ வில் ஆல்சோ switch off. And Anand, you also go and relax and come back.
Yes, sir. Yes, sir.
And tell them
Okay,
I may
sir.
take instead of I think I'm supposed to finish at 5 o'clock. It may take more because I am starting it late.
Means அது நீங்களே சொல்லிடுங்க சார்.
நானே சொல்றேன்.
No problem, sir. No problem. We are lucky to have.
இல்ல, குரூப்ல ஒரு மெசேஜ் போட்டுருங்க எல்லாருக்கும் வாட்ஸ்அப்ல. Bring come with coffee. Coffee with Chandra. Coffee with Chandra மேடம் அப்படின்னு போட்டு. சூப்பர்.
ஓகே சார்.
நான் சும்மா ஆன்லைன்ல இருக்கேன். நீங்க எல்லாம் கிளம்புங்க.
சரிங்க சார். வந்துறேன். ஜஸ்ட்
ஷூர். ஒரு பயோ பிரேக்.
எஸ் சார். So 220 students, 220 participants are there now.
Super.
Online.
500 register பண்ணிருந்தாங்க போல இருக்கு. வரதுக்கு முன்னாடியே பாதி பேர் போயிட்டாங்க. நீங்க மியூட் பண்ணிருக்கீங்கன்னு நினைக்கிறேன். நீங்க பேசுறீங்க ஆனா காதுல.
ஆமா ஆமா. இல்ல மாறி மாறி வந்தாங்க. சர்ஜன்ஸ் கொஞ்சம் காலையில மேல வந்தாங்க. தென் இப்போ கொஞ்சம் வந்தது இப்போ யூடியூப்லயும் போட்டுருக்கோம் சார். அதுல ஃபாலோ பண்ண.
சூப்பர் சூப்பர். போஸ் சார் டாக் சூப்பரா போச்சா?
சூப்பரா போச்சு சார். ஆமா, எல்லாமே சொன்னாங்க.
வெரி குட். சரி ஆனந்த், நீங்க போயிட்டு வாங்க.
Hello, Chandra ma'am, are you there? Sir, we'll just wait 1 minute, sir, madam.
Sure. No problem. Hey, Shivashankar, எப்படி இருக்கீங்க?
It's there in the HOD.
இன்னும் டெலிகேட்ஸ்க்கு ஓப்பன் பண்ணல, ஓப்பன் பண்ணிட்டீங்களா?
ஓப்பன் தான் சார்.
டெலிகேட்ஸ்க்கும் ஓப்பன் ஆயிடுச்சா? சூப்பர்.
Open தான் சார்.
So I have to be careful. Hi delegates, I hope you are all enjoying. Have some coffee, have a bio break. I will try to finish it as early as possible. Is my video all right, Anand, or is the back?
Yes, sir. Video is fine, sir.
Light, just 1 minute. I will switch off that light in the background. And then come back.
Madam, Vandali.
It's better now, isn't it? That background light I switched off. (2:32) I can see. Whenever you have questions, delegates, please put it in the chat box. And
so,
like every 20 minutes or 30 minutes, I will ask Chandra madam, just to break the monotony of my talk. We'll have few questions answered in between. I hope, Anand, you don't mind the interaction.
No problem, sir. No problem, sir. You go ahead. So we'll come to the next session. That is by Professor Rajendran, sir, on recent advances in salivary gland tumor pathology, followed by a slide seminar. Sir has already sent you the slides, and we have shared with you. And this session will be chaired by Dr. Chandramoulishwari, ma'am, who's also a secretary of Tamil Nadu chapter of IAPM, and Professor Shivshekhar, sir, professor of pathology, will be introducing Chandra madam. Sir, over to you, sir.
Thank you, Anand, for the chance once again. And before introducing, I would like to congratulate Dr. Chandramoulishwari for the vibrant interaction she had in the previous session. Obviously, participants, you feel that no introduction is required. Having finished her MBBS in Kilpak Medical College, MD at Chennai Medical College, she has had a postdoctoral fellowship in nephrology and also went on to complete FRCP in 2021. Areas of expertise are a few to be mentioned for want of space on the screen: oncopathology, nephropathology, hematology, clinical pathology, and flow cytometry. A lot of publications and the Best Doctor Award for her sincere efforts during many a crisis. In fact, Dr. Chandramoulishwari, we know as an examiner, as an external expert, and also a very novel person in conducting many a conference. Dr. Rajendran, on the other hand, I would like to just recollect that he is a colleague of mine for more than 30 years. I welcome both of you and I hand over to Dr. Chandramoulishwari.
Thank you, sir, for the very kind introduction. And of course, I'm honored and privileged to introduce a person who needs no introduction. Before introducing Rajendran, sir, I would like to answer a question which he posed to me yesterday evening when we had the dry run. Sir actually wanted me to say, like, what was the picture about and where was I standing? So this is actually a specially taken picture for you, sir, because you're a person known across seas and internationally famous figure. So I made myself stand in front of the Arabian Sea and had a picture caught so that I could post it here for a inaugural session. So, sir, of course, Dr. Rajendran, sir, completed his MBBS in the University of Madras, MD Pathology also from the University of Madras in 1990, Diploma in RC Path in 1995. And I would like to tell you that this is an abridged, concise version of the abridged CV, which sir actually had in pages. So we had to shorten it for want of time. So American Board of Pathology USA has acknowledged him. American Board of Pathology USA Cytopathology, Anatomic and Clinical Pathology has acknowledged him. He has delivered more than 228 lectures, and which runs in pages in his CV, 56 publications in national and international journals. And then he has been awarded the Anatomic Pathology Teacher of the Year 2003 by Pittsburgh University, Pittsburgh Medical Center. He is an awardee of the Dr. S.J. Nagalothimath Memorial Excellence in Teaching Award in the year 2016, and Dr. M.R. Parthasarathi and Dr. A.V. Ramaprasad Silver Clock Oration Award Pathology, to tell a very few of his accomplishments. I welcome you on board, sir, and it's a privilege indeed to hand over the mic to you for your session. To start.
Thank you very much, Chandra madam, and congratulations for the FRC path. I never know that, and it's a very tough one, and great. I hope all of you can see my screen. I will start sharing my screen. And I request all, I will switch off my video because I have some beautiful images. I want all of you to enjoy the images rather than seeing my picture. I will stop my video and I will stop this floating. Super. And then I will go for my presentation. And madam, is everything all right? Can you see my full screen?
Perfect, sir. Perfect.
And can you see my arrow, the
Yes,
black one?
Yeah, yeah.
Super. And thank you very much for giving this opportunity to SRM Pathology, John sir, Anand, Shivashekhar. Shivashekhar told he knows me for 30 years. I think it should be more than that, because we are doing contemporaries at A.L. Modelier Institute of Basic Medical Sciences in Germany. I think we started in 1987. If we have bought 1 or 2 grounds at that time at Velachery, there is no need for us to sit with you now. Unfortunately, we never did that. So thank you very much, Shivashekhar sir. And thank you, Chandra madam, for your sweet and I think it's relatively on the overside of my introduction. And I want to start my talk, and I request all the delegates just to relax and enjoy. And I think it's what time is here? It's 5:15 a.m. here, and my wife is sleeping. So I kindly request all the people who are seeing this video to be my Valentine on this Valentine's Day. I know it's 1 day late, but later on the latest. So a lot of things are happening in salivary gland tumors, and it's like a big fire in salivary gland. Okay, a lot of molecular changes are happening that affects the diagnosis or helps us to know the diagnosis, prognosis, and precision medicine, which is targeted therapy. And salivary gland tumors are having a lot of those things. And I thought I will just highlight the recent advances in salivary gland tumors. So I just divided my talk for the first 45 minutes into 6 compartments. Let us start with the clinical and radiological features and applied histology. Histology is very, very important. You will be seeing why it is important. Let us visit the WHO classification of salivary gland tumors. And the latest WHO is, even though I am saying latest, it is 2017, 4th edition. So 5th edition should be out within a couple of months. And let us see what are all the updates from the previous WHO. And I want to take major part of my discussion on pattern analysis of salivary gland tumors. And we have to do the pattern analysis by architecture and cell type. Let us also see the molecular changes where the recent advances are happening. And what are the surrogate IHC markers? This is very essential because all of us, we can read the molecular changes, but the cost is slightly on our higher side. Unfortunately, our patients, they are not having that much of money. And people may ask, why don't they have insurance? Luckily, people with insurance are not getting the disease. And unfortunately, people without insurance get all the diseases. So money plays a very big role in our society. And it's very strange. Sometimes the investigations cost more than treatment. So for example, vitamin D, not connected with salivary gland, vitamin D estimation, I think it's like 3,000 or 4,000. Whereas vitamin D tablet is like 5 rupees. You can take one tablet a week for 4 months rather than testing for vitamin D. So I want all the delegates to keep it in mind. Unfortunately, our fellow Indians are not very affordable for all the investigations. So we have to keep that in mind. That's why IHC markers are helpful, because IHC markers now, they run in hundreds, whereas the molecular test runs in thousands. So we had surrogate IHC markers of the molecular changes. Let us see them in the fourth portion of this talk. And more importantly, I used to tell, we are trying to help the surgeons and the oncologists, medical and surgical oncologists, to treat the diseases. And we should know what they're expecting. And we should follow some guidelines like NCCN guidelines. I know how many of you may be using it, but I want to stress the application of pathology in the practical aspect in the treatment of the patient. And finally, let us finish with take-home messages and references. Is my voice clear, Madam? Chandra, Madam? Hello?
Yes, sir, you're clear, sir.
Yes, sir. Yes, sir. Very clear. Very clear.
Okay. Is the slide movements all right? I just want to make sure everything is working nice.
Everything is fine.
And Madam, in between, I will request you to read if there are any questions. Delegates, whenever you are feeling any questions, you can type it in the chat box.
Yes.
Just to make sure you are all not sleeping, I will ask in between Madam to read the questions. And Madam, if there is any break in the technology, you please WhatsApp me, or Anand, you WhatsApp me, because I switched off my phone. So WhatsApp is available.
Yes.
Okay.
Super. And a little bit of advertisement for me. I have my own YouTube channel. If you put Dr. S. Rajendran, you can see that. And I am in Twitter, RD Pathology, RD Patho. And Twitter is a great area to know pathology in an interesting way. And some of the factors I copied it from Twitter. So I kindly request you to use Twitter for more pathology education. And I'm in the Facebook also, Swaminathan Rajendran. Why I am saying these things, if you have any questions after the conference, you can contact me in the Twitter or in the Facebook. YouTube, I have a good number of videos, and probably this salivary gland talk will also be pushed after getting it from the SRM Medical College. Great. So let us start with, I told you 1, 2, 3, 4, 5, 6, but I thought references are very important. When you say it at the end of the presentation, many people, they just leave. How many delegates are there, Anand, now? Can you see the number? Because I switched
261, sir. 261.
261. And let us see how many of them will stay until the end. That's why I thought the references, we have to give it in the first portion of the presentation, so that people can have a look at it. So let us start with the references. And these are the 6 references I want to give. Number 1 by Lester D.R. Thompson. See, we used to have a mentor in pathology, but single mentor is not enough now, because pathology is growing and every system you have to keep yourself updated. So I used to have mentors for each system. And for the head and neck pathology, my mentor is Lester D.R. Thompson. I know him very well. Unfortunately, he don't know me. but it is his problem. It is not my problem. And probably after seeing this in the YouTube, he may message me. But I want to thank Dr. Thompson for his sense of humor is great. And in the Pathcast, he has a video on, is it a question? If you put the question mark, it's like a question. Who keeps changing the names of salivary gland tumors? Okay. But when you put it as an exclamatory mark, it is the answer. WHO keeps changing the names of the salivary gland tumors. It's a beautiful talk. I kindly request all of you to go and listen to Lester Dior Thompson. And I take again this opportunity to thank him for keeping me updated in salivary gland tumors. The second reference is salivary gland tumors. Again, update on the latest WHO classification from Diagnostic Histopathology 26.4. Third is practical immunohistochemistry in the classification of salivary gland tumors. This is the latest one from Seminars in Diagnostic Pathology, and I think it's in February issue this month. And fourth one is the NCCN guidelines. Remember the head and neck version 2.2020. It's like Endiran.2 version 2. Okay, it's again in July 2020. And the fifth reference is molecular pathology of salivary gland neoplasms, diagnostic, prognostic, and the predictive perspective. This is very essential. Whenever you know a lot of molecular changes are happening, but in which field it will help in pathology? Is it for diagnosis? Is it for prognosis? Or is it for predictive targeted therapy? That is very important. Understanding of that is very important. And this is from March 2021, Advances in Anatomic Pathology. And lastly, but not leastly, I kept the WHO 4th edition 2017 as the background to get the details from that, and then updated with all these references. So these are the 6 references. And I thought I have to put some stickers for you to take snapshots. Okay, I know some of you may be recording it, and my request is don't record it. You are not going to see it again. Okay, it's like our marriage video. Who sees the marriage video after the marriage? None of us see. And I'm talking so bravely because my wife is sleeping still. So this, whenever you see this spiky person, that means you take a snapshot of that screen. It will help you in future for you to, if you are interested, you can visit these areas. Great. Let us go to part 1, clinical radiological and applied histology. As you all know, salivary glands, we have 3 pairs of major salivary glands and other minor salivary glands. And the function of the salivary gland, you just start spitting the saliva out, don't swallow it, then you will know the importance of the saliva. Another philosophical note, whenever we are having something we don't respect, we take it granted. But when it is not there, then only you will know the importance of it. And many of you might have felt before going for your oral exams in MBBS or in your career for probably NEET exam, at that time your mouth becomes very dry and you will be trying to produce some saliva, drink some water and all. So it is very important in moisturizing and dissolving the food, the digestion of the starch, and more importantly in controlling the bacterial content of the oral cavity. This clinical information gives you a lot of information. In the major and minor salivary glands, 70% of the neoplasm happens in the parotid, and only 30% happens in the other glands. That's point number 1. Point number 2, in the parotid, 70% of the time we get pleomorphic adenoma. Okay, only 30% of the time we get other tumors. So parotid is the number 1 gland with most of the tumor, and pleomorphic adenoma is the most common. But when you take the minor salivary glands, 40% of them are only pleomorphic adenoma. From 70 in parotid, it's only 40 in minor salivary gland. All the other malignancies, for example, mucoepidermoid carcinoma takes 20%, adenoid cystic another 20%, polymorphous adenocarcinoma takes 10%, and the other malignancies take 10%. So the take-home message here is smaller the gland, more the malignancy. The incidence of salivary gland, malignant salivary gland is more in minor salivary glands rather than in major salivary glands. That you have to remember. And I think we have to take a snapshot of this. I will just give you 2 seconds. I think it will be more than enough to take the snapshot. Location. Again, major and minor salivary glands. Some tumors, see, anything can happen anywhere, but some things are more common. For example, canalicular adenoma always happens in the upper lip. I know we should not say always and never, but for teaching purpose, I want to see, never try to diagnose canalicular adenoma in the major salivary glands. It may happen, but most commonly in the minor salivary gland. Ductal papilloma, cystadenoma, cystadenocarcinomas, polymorphous adenocarcinoma, classic, now known as polymorphic adenocarcinoma, or cribriform low-grade adenocarcinoma of minor salivary glands. Okay, these are all the new terminologies we will be explaining more in the WHO classification. They happens in the minor salivary gland. So location is very, very important. You take the snap of this, because you keep this when you are coming for differential diagnosis, see whether it is in major salivary gland and minor salivary gland, and then go through this list. Benign or malignant? That is the very important question we have to answer. To help us to answer that question, we have to see what is the duration of the tumor. Longer the duration, more benign. Rate of growth, rapid degrowth, it's malignant. Border, and this picture tells you about the border. The border is very smooth or bosselated, nodular. You may see some non-invasive nodules outside a well-circumscribed lesion. These are all characteristic of benign. Whereas in malignancy, the border will become irregular. Okay, so I used to see, take your hand, close your fingers, you see the fist, it is benign. But you extend the fingers, you see the fingers, it is infiltrating. Okay, so they are all infiltrating, and I hope this picture worth more money, because this tells you the main difference between the benign and malignant salivary gland tumors in the borders. And then cytological atypia, but cytological atypia is a very big question mark helpful in salivary gland. And I am lucky to hear the last portion of Usha madam's lecture. And thank you, madam, for the fabulous lecture. And madam is telling in cytology, pleomorphic adenoma, basal cell adenoma, adenoid cystic carcinoma will look alike. They fall under small blue cell tumors. Adenoid cystic carcinoma, if it shows more atypia and malignant looking pleomorphism, it will be very helpful for us to diagnose, especially in cytology. But unfortunately, cytological atypia doesn't play a major role in salivary gland. It does have a role. For example, salivary duct carcinoma, it will be more pleomorphic. Poorly differentiated mucoepidermoid carcinoma, it's pleomorphic. But when it comes to small blue cell tumors, atypia and mitosis, they are not very helpful in salivary gland tumors. Specimens in radiology. What are all the specimens you get in pathology? One, FNAC. Second one, core biopsy or incisional biopsy or excision or radical surgery with the lymph node. These are all the 5 specimens we get in our department. And FNAC and core biopsy may be radiologically guided or non-guided. And whenever it is guided, madam mentioned it, we have to do a ROSE. ROSE is nothing but rapid on-site evaluation, where the pathologists go to the radiology suite and then stand next to the radiologist and get the material and put it on the slide. And the main role of ROSE is to see adequacy. They have done a core biopsy or FNAC. You put it on the slide, see, do a rapid staining and see under the microscope and see whether we have adequate material for diagnosis. It is not necessary to tell the diagnosis at that point, but I know the patients and radiologists will be pushing you. Is it benign or malignant? If it is 100% malignant, you commit yourself. Otherwise, you just tell them, I have adequate material for diagnosis. Let us wait for 12 minutes or 12 hours. So, and then triage. Triage is also very important. For example, it is a lymphoid-rich lesion. You are thinking of lymphoma. You have to send it for flow cytometry. If you think there are a lot of neutrophils and it look like abscess, then send it for microbiology. So adequacy and triage is the main main help by doing the rows. Radiology, I want to stress more and more, and I want to give us an example of this case where radiology will be helpful. It's a 42-year-old female with a right parotid lesion. They did a core biopsy. And by the way, salivary gland tumors are very common in females, and the only very few tumors are very common in males, and Warthin tumor is one of the tumors that is common in male. So this core biopsy showed this, okay, only fibrous tissue, some lymphocytes, some minor portion of the salivary gland I can see. I don't see any tumor. So I called the clinicians and I told there is no tumor. And then clinician asked me to come and check the radiology and see this, how destructive. And I'm ashamed to call this as tumor because this is a very big, even it is invading the eyeball. Okay, destroying the sinuses, extending in all the directions wherever it can extend. So after seeing this radiology, no way this may be tumor. And whenever there is a radiological and histological discordance, you have to think of sampling error and interpretation error. Sampling error, probably they might have done biopsy from the peripheral, but with this big tumor, it is very unlikely. So the best thing for histology is go for deepers, and I did some deepers, get some more salivary glands, some more lymphoid tissue, and another deeper. You can very nicely see the core biopsy, adenoid cystic carcinoma. Okay, so in real life, it's very, very important to correlate with radiology. Okay, and just don't see the radiology report. Any problem cases, you take the clinician, go to the radiology department, sit there, pull the radiology, and then check. People used to say, especially in bone and soft tissue, you must know the radiological features, but I slightly disagree with those people because radiology is another expanding area. It's very difficult to keep updated. I find it even in pathology, so many things are going up in so many organs. It's very difficult, and I can't update my radiology knowledge. So what I do, I select my cases and go to radiology, sit with them. Okay, and please believe me, the minute I sit with the clinicians and radiologists, life is adventurous and fun, and they love it, clinicians. And you have to remember another philosophical thought: patient is our boss. Okay, so you have to keep your boss happy, and no egos. You should have a very close relationship with radiologists and clinicians. So radiology is part of pathology. It is gross pathology. Okay, so that you have to remember. Without radiology, never sign out any difficult cases. All the cases, especially the difficult cases, you have to take radiology for the diagnosis. And please remember, radiology is part of gross pathology. And in radiology, we have a lot of technologies, ultrasound, CT, MRI, and the new kit in the block is PET, positive emission tomography. And I love this PET because it shows activity. And in difficult cases where they fail to get material in the first or second attempt, I ask them to do PET. And I ask them to guide the biopsy from the PET guided, PET positive area. And people are telling it is not in the literature, but remember, PET is a new baby. It will come up in the literature. So whenever you fail in the initial FNAC 1 or 2 times, don't do that more than 2 times. Okay, third time, go for a PET and take the PET positive area in the biopsy. And Usha madam, don't mistake me. Whenever possible, go for core biopsy, because FNAC is very good, but it has its own advantage and disadvantage. And the whole world is moving towards core biopsy. And when you have the core biopsy, you have to individually take the core and put it in the paraffin block. When you get a lot of material like this, you select the core, okay, take the major cores and separate them in the core biopsies. Remember, these are all needle biopsies, and when you put everything together, they become a noodle biopsy. And you may miss the tumors when you put everything together. And this shows you what are all the possibilities where you can miss the tumor. For example, the light gray one is the core biopsy and black is the tumor. If you put a single core and if you embed it, embedding is very, very important in core biopsies again. And when you embed it very nicely in a single plane, then your chances of getting tumor is very high. Okay, but when you embed very irregularly and sometimes in the superficial trimming, you may lose the tumor. Or if you embedded the tumor in the paraffin block, you may not cut it in the initial sections. This is what happened in the example case which I showed. Initially, there's only non-tumors, but after radiology, we went to deeper and we got the tumors. And the problem in putting multiple cores in one block, they all curl up, okay, and that I love this terminology, noodle biopsy, okay. You take one spaghetti and put it in the needle. The residents, you can try it, pathology PGs, you can try it. Take one spaghetti and cut it, and take 5 or 6 spaghettis and put together and cut it. You can see the differences. The chances of missing the tumor is very high when you put multiple cores in one block. That's about the clinical features. We will go to histology. Salivary gland histology is very important to understand the tumors of salivary gland. And here you can see the salivary gland tissue, and these are all the functioning lobules. The functioning lobules are arranged in a zigzag pattern, okay, and it will have connective tissue in between the lobules. The lobules are predominantly made up of acini. You will see it in high power. And the acini gets drained by the ducts, and the major ducts are situated in the connective tissue. So remember that lobular zigzag pattern and ducts and blood vessels. The major ducts are always accompanied by the artery and vein and lymphatics. Okay, so please remember the neurovascular bundle along with the ducts. And when you go to the high power, imagine it's like a cluster of grapes, okay? And each grape is the acini and the stem is the ducts, okay? And the acini are divided into serous, mucinous, or mixed acini. The serous acini, the best example is parotid gland. It will be more pyramidal shaped cells with zymogen granules, basophilic granules there. It's very difficult to see the lumen. They will be occluding the lumen because the cells are so big, and they will be occluding the lumen. From the acini, the ducts comes out, and the ducts are divided into intercalated ducts, striated ducts, and excretory ducts. And the intercalated ducts are nothing but intercalated. The word intercalated means in between. It is in between the acini and the striated duct. And the intercalated and striated duct are lined by single layer of cells. That's very, very important. From excretory duct, it gets stratifications. Okay, so the intercalated duct is more like a cuboidal cells, and all these ducts are have two lining. I told you it is not stratified. The luminal cells or single layer of cells, and the abluminal cells, they have myoepithelial cells, even in the acini as well as in the ducts. Remember, these are all secreting, and these secretions has to be pushed to come out, and that's the function of the myoepithelial cell. We will see about myoepithelial cell in a minute. So this is the example of parotid gland, pure serous gland, and this is an example of mucinous gland. Okay, you can see like a single layer of mucinous cells, and the lumen is more better appreciated in mucinous glands. And many of the sublingual glands and minor salivary glands are more mucinous. Whereas we have a mixed gland where the mucinous cells are accompanied in the periphery in a lunar pattern. That's why it is known as lunar cells, and these are all the serous cells. Okay, so the mucinous cells along with the serous cells. And submandibular gland is the best example of mixed glands, both mucinous and serous. Okay, so the acini We divide them into serous, mucinous, and mixed. Without history, you can say whether it is from the parotid or from the minor salivary glands or from the submandibular. And the ducts are again 3 types: intercalated duct, the striated ducts, and the excretory ducts. Excretory ducts gets more stratified. Sometimes it may be columnar cells, sometimes it may be cuboidal cells. And all the acinar and ductolobular units are covered by myoepithelial cells in the periphery. Okay. And in addition to that, they will have plasma cells in the connective tissue stroma. I just want to ask the residents or delegates, you just put it in the chat box, why plasma cells are there. Can we call it chronic sialadenitis? Because of the plasma cells. Chandra madam, any answer in the chat box, madam? Or Anand?
Looking, sir, looking.
Not yet, sir, not yet.
Not yet.
Just type in few things. Why plasma cells? What is the role of plasma cells in the salivary gland? We will give 10 seconds, madam. If there is no answer, I know our residents are very shy. Individually, they will answer, but in group, they won't answer. Only in Tirupati, you get the answer from the group. Govinda. Whereas individually, they won't answer. Anything, madam? Any luck?
No. One has come. I'll just look into it. To produce antibodies. Ramya has.
Super. Very good. IgA.
Yes,
We all talk about IgA in secretions. And where does the IgA comes? It comes from the plasma cells. So plasma cells are very scattered. But when you see more than 5 plasma cells in one focus, here they are more distributed. Okay. But if they're having a party, 5 plasma cells sitting together, for example, in this area, then it will be the criteria for chronic sialadenitis. Okay. So these are nothing but IgA secreting plasma cells, normal. You cannot call it inflammatory cells. They are plasma cells. Okay. And as I told you, we have luminal ductal epithelial cells and abluminal myoepithelial cells, and we have good markers to identify luminal cells and ductal epithelial cells. Why we have to know that? Because some tumors are arising from the ductal epithelial cells, some tumors are arising from the myoepithelial cells, and many tumors are arising from mixed ductal and myoepithelial cells. That's why we have to identify them. And the pankeratin, AU1, AE3 are low molecular weight keratin is strongly positive in luminal cells, whereas P63 or P40 now, that is positive in myoepithelial cells. And you can see the myoepithelial cell and basal cell, whenever the cell is having a function of expressing the secretion, they have the smooth muscle character in them. That's why it is become myoepithelial. Whereas when you comes to excretory duct and other portions, they are called basal cells because they don't have that much of contractile property. So superficially, they can be exchanged or they can be replacing each. But when you deep think, they are different. Myoepithelial cells have more muscle property, whereas basal cells will have less of muscle property. And even though I put S100 and muscle markers as markers for myoepithelial cells, P63 and P40, okay, low molecular weight cytokeratin, and P53 or P40 are the 2 markers you use to differentiate ductal cells and the myoepithelial cells. As I told you, this is the acini, intercalated duct, striated duct, and I forgot to show the striated ducts. They have the basal striations. Remember, you see it in the proximal tubules of the kidney, proximal convoluted tubules. Like that, they will have striations in the base. That's why it is known as striated cells. Okay, striated ducts. And then interlobular duct or excretory ducts. This is the anatomy. And they will have lymph nodes within the parotid gland or parotid gland mainly, and they can have some sebaceous cell clusters. So this is the normal histology, and you can see the myoepithelial cells. They are lining the acini, and the ductular system, and it gets attenuated the more the periphery you go, because there is no need to compress the ducts to excrete the secretions. And why we heard this picture is very, very essential. Okay, because from the acinas, we get the acinar cell carcinoma and secretory carcinoma. And most of the salivary gland tumors are arising from the interconnected ducts. For example, basal cell adenoma, pleomorphic adenoma, adenoid cystic carcinoma, polymorphic adenocarcinoma, epithelial myoepithelial carcinoma. They all arise from the interconnected ducts. And striated ducts, as I told you, they will have abundant eosinophilic cytoplasm with basal striations, and they give rise to the oncocytic neoplasms as well as the Warthin's tumor, which are nothing but oncocytic cells with a lymphoid infiltrate, lymphoplasmacytic infiltrate. And the major ducts gives rise to all papillomas, epidermoid carcinoma, squamous cell carcinoma, mucoepidermoid carcinoma, and salivary duct carcinoma. And the myoepithelial cells give rise to myoepithelial tumors. And sebaceous cells, you have to know, because sebaceous tumors can arise within the lymph node from the normal sebaceous compartment of the parotid gland. Parotid gland. And then I told you lymph nodes can be there within the major salivary gland, especially parotid gland. And within that lymph node, you may get some benign or malignant cells. And that's why it is called lymphadenoma when you see benign, and lymphadenocarcinoma when they turned out to be malignant. So this concept is very, very important. And this is the applied histology I want all of you to know, and take a snap of this. Super. So there is another molecular approach to salivary gland tumors based on histology. They think most of the tumors are arising, as I told you, from intercalated duct. So they are all arising from the reserve cells or stem cells situated in the distal intercalated ducts. And the other tumors which are arising from the excretory duct, they are also arising from the reserve cells or stem cells. You know the stem cell theory now in all the organs. They think the stem cells from that portion of the organ gives rise to the tumors. For example, in breast, it is the stem cells in terminal ductolobular unit rather than lobular cells or ductal cells giving rise to tumor. So like that, it is either distal stem cells or more proximal excretory stem cells in salivary gland. And these are all the tumors I already showed you in the previous picture. And when they looked into it very carefully, you may be wondering why I put the picture of socks and I put here socks 10. Okay, there are 10 socks, and the tumors arising from the distal stem cells are positive for socks 10, whereas the tumors arising proximally are socks 10 negative. Okay, so this is the molecular wise they come to know. So you have to remember, and you have to mainly divide the tumors SOX 10 positive and SOX 10 negative in the salivary gland. So in the differential diagnosis, if acinar cell carcinoma and oncocytic carcinoma is in the differential, you use the SOX 10 to differentiate. Okay, but don't do SOX 10 to differentiate acinar cell carcinoma from adenoid cystic carcinoma, because both will be SOX 10 positive. So this is another selfie you have to take. Okay, so with that, we are done with the clinical history and applied histology. I just want to check with Madam. Madam, any questions, Madam, so far?
Nothing, sir. Nothing so far, sir.
Super. So you start putting some questions, okay, so that I will know that you are all listening. So we are going to part 2, which is nothing but WHO classification and updates from previous WHO. You all know the current WHO is 4th 2017. So we will be expecting. And another thing, the whole literature area, they are telling rather than putting edition, let us start with the versions. Okay, they started with the CNS. You may be seeing so many updated articles. Why to wait for 5 years to get a edition? We will put versions so that every 6 months or every 1 year we can keep changing things. And you know, philosophically, change is the only thing that won't change. And you have to change yourself. After changing yourself, you have to bring the change. People who bring the change, they lead the change. Or people who follow the change, they are good followers of the change. People who are not changing themselves with the changes, they will be left behind. Okay, You follow the changes and then you bring the changes. This is more like a motivational presentation from me to all the young delegates. And Anand, how many people are there now, Anand? I think 261 should be 200 now.
No, sir, 257.
57. Yeah.
Wow, only
Score
4
is good,
people
sir.
left. 4 people left. Super. So this, see, we see one single picture, but there are a lot of people involved in bringing. This is the picture taken in Lyon. You all know the WHO headquarters is in Lyon, Switzerland. I think France. So in January 2016, they had meeting, and this is my mentor, Dr. Lester Thompson. Okay, I love him. So I wanted to show his face to all of you. So all these people, they come up with the 4th edition. And there are totally 45 tumors they identified or they named in the 4th edition. Let us see what they are. Any tumor, first thing you have to see is whether they are primary or secondary. We are going to deal mainly with the primary. So the primary tumors should be divided into epithelial tumors, soft tissue tumors, and hematolymphoid tumors. These are all the 3 major divisions. All WHOs, I remember we used to do this along with Sivashekhar sir. Sivashekhar sir, do you remember? We used to write all WHO classification like this. You don't just follow whatever they have given. You divide them the way you can remember them. Okay, don't memorize. You identify a way where you can remember them. Okay, so I'm trying to put what we used to do like 30 years before. We used to, Sivashekhar and myself, we used to sit and we divide all WHOs like these algorithms. Okay, epithelial tumors, soft tissue tumors, and hematolymphoid tumors. In the epithelial tumors, benign, borderline, malignant, poorly differentiated, and tumor-like lesions. So this is the skeleton of the salivary gland, WHO. The benign tumors, we have good number. I'm not going to read all these things, and please wait. Don't take a snapshot now. I will tell you when to take the shot. So these are all the tumors in the benign. Borderline, we have only xyloblastoma. Malignant, we have a big list of tumors. Poorly differentiated carcinoma, we have a good number. The neuroendocrine and non-neuroendocrine, like a small cell carcinoma, comes in the poorly differentiated carcinoma. Tumor-like lesions, they included now 4 conditions. Okay, we will be seeing these tumors again and again, these names. So, and in the soft tissue tumors that are specific, anything can happen, but specifically high incidence of hemangioma, lipoma, nodular fasciitis, and hematolymphoid tumors, you know, maltomas can happen in the salivary gland tumor. And this is the selfie time. Okay, take a snap of this slide. So if you count, if you don't have anything else to do, and if you count these tumors, you should get 45. So what are all the updates? The new entities, secretory carcinoma and sclerosing polycystic adenosis. The secretory carcinoma, previously it is called as mammary analog secretory carcinoma. But now they think another beautiful expression I got in one of the lectures is the salivary glands or breasts on the face. Okay, so that's why many tumors or many lesions that happen in the breast can happen in the salivary gland. And secretory carcinoma, they don't want to tell it is mammary analog. It is more common in salivary gland tumors. And so they got the new terminology, secretory carcinoma. Sclerosing polycystic adenosis, it is nothing but fibrocystic changes of the breast. Okay, rather than calling fibrocystic change of the salivary gland, they are calling it as sclerosing polycystic adenosis. But I have my own reservation. Why can't you just call fibrocystic disease of salivary gland? That holds good. I will show you the pictures, then you can agree with me why they can be called as fibrocystic changes. The new names are polymorphous adenocarcinoma. Remember, previously we used to say polymorphous low-grade adenocarcinoma. But this polymorphous adenocarcinoma, some of the patients are doing very bad, and when they looked into it, they are all not that much low-grade. It can be high-grade also. So they put the new name polymorphous adenocarcinoma, and they removed the low-grade from that. And again, this polymorphous adenocarcinoma can be divided into low-grade and high-grade. Then intraductal carcinoma. This is the new entity. Okay, it is formerly known as low-grade cribriform cystadenocarcinoma. They thought they are all cystadenocarcinomas, but when they go for pathogenesis and histogenesis, they are all within the duct, and it's like a DCIS. What we call in breast DCIS, it's a intraductal carcinoma. Okay, or ductal carcinoma in situ. Again, DCIS can be used here. Many things you just to follow what they are calling it in the textbook. Okay, especially in the exam, you don't tell it is a DCIS of the salivary gland. After the exam, you can tell anything, but in the exam, what is the main motto? Passing the exam. If the examiner tells you are a fool, pleasantly accept it, get the result, pass the exam, clear the exam. Then we will learn more after that. And please believe me, the real learning starts only after the exam. And then poorly differentiated carcinoma. Okay, so they put everything like small cell neuroendocrine, large cell neuroendocrine, undifferentiated carcinoma into poorly differentiated carcinoma, or highly undifferentiated carcinomas, or highly transformed carcinomas. Take a selfie of this. And then clarifications or changes, adenocarcinoma, NOS. This is another major thing. The mucinous carcinomas and signet cell carcinomas and cystadenocarcinomas, now they are all included in adenocarcinoma, NOS. Cystadenocarcinoma is removed as a separate entity, and mucinous adenocarcinoma is also removed as a separate entity. They are all put under NOS. And signet cell, please include signet cell carcinoma here. They are also called now as adenocarcinoma, NOS. And then metastasizing pleomorphic adenoma, previously it was put in the malignant category because it has metastasized, but it is a pleomorphic adenoma. Previously we used to tell metastasis is the criteria for malignancy. Now it is not. Leiomyoma can metastasize, pleomorphic adenoma can metastasize. So it's again brought under the benign category. Carcinoma X pleomorphic adenoma, there is a clarification in the terminology. And in whenever previously we used to say carcinoma X pleomorphic adenoma as a diagnosis, now you have to say after that, what is the carcinoma component? Is it myoepithelial carcinoma? Is it adenoid cystic carcinoma? Is it acinic cell carcinoma? Is it salivary duct carcinoma? So you have to specifically state the histological type of the carcinoma. Okay, and how much is the percentage of the component, malignant component. And minimally invasive, previously they thought 1.5 millimeter, but now they are trying to increase 4 to 6 millimeters. I will come back again when we see carcinoma X pleomorphic adenoma. And sialadenoma papilliferum is included in the ductal papilloma. Okay, and two other things, intraductal papilloma and inverted ductal papilloma, they are all included in ductal papilloma. So ductal papilloma now have three members: sialadenoma papilliferum, inverted ductal papilloma, and intraductal papilloma. And lastly, lymphadenoma. Previously, we used to divide them into sebaceous and non-sebaceous. We used to say sebaceous lymphadenoma and non-sebaceous lymphadenoma. Now they behave like the same. So they want to put it as lymphadenoma hyphen sebaceous type or lymphadenoma hyphen non-sebaceous type. And they included the non-neoplastic epithelial lesions, sclerosing polycystic adenosis, nodular oncocytic hyperplasia, lymphoepithelial sialadenitis, and the intercalated duct hyperplasia. These are all the 4 additional non-neoplastic epithelial lesions. I think this is a selfie time. I should not call it selfie. I think I should call it a screenshot time. Next time I will see. But if you want to take a selfie with the screen behind or your face behind, you can do that too. Super. So that brings the end of the WHO classification and updates. Madam, any questions, madam?
No, sir.
Super.
Not it. Not it.
I hope they are all listening. So, or they are all mesmerized probably. We will think positively.
Yes.
So we are going to third portion where we will be spending most of our time. Okay, pattern analysis. We have to remember architecture and the cell type. Okay. So in the pattern analysis, and we are dealing only with epithelial tumors. Okay, epithelial tumors can be divided into 4 parts: pure epithelial, pure myoepithelial, mixed epithelial and myoepithelial, and epithelial with lymphoid cells. Okay, let us start with the simplest one. Epithelial with the lymphoid cells. The non-neoplastic is lymphoepithelial sialadenitis, and the neoplastic you have Warthin tumor, lymphadenoma, both sebaceous and non-sebaceous, sebaceous lymphadenocarcinoma and lymphoepithelial carcinoma. Take a snapshot. Now, this is a
Sir,
picture
1 minute, sir.
where, yes.
Sir, somebody has mentioned, sir, we are listening, sir, and they put a smiley. So they are listening, it seems.
Super. See,
Listening
many
part.
online lectures, they switch off the camera. Okay, that's why this is 250 people. I cannot. And I have one request. All of you put a small makeup. Okay, don't put a heavy makeup like pah. Okay, put a small makeup. At the end of the conference, you can all, I will request on, and you can all come online and with your camera on, and we will take a snapshot. Okay, this is like a virtual group photo, so that we will know who are all there, and we will keep it to perish our nostalgia. Okay, Anand, keep it as a final thing.
Sure, sir. Sure.
Okay, one
sure, sir.
snapshot of all the delegates. Okay.
Yes, sir.
So, and thank you for the comment. May I know the name of the person, Anand? Since one person is responding, let us
1 second, sir. Dr. Doc R. Doc R.
Dog or I don't. I think it is not the dog one. We use it for gist. Super. Thank you, Doc Org.
Sir, one more person, sir. Adila Naz. Yes.
Wow, Adila Nas is my very close friend.
Very presentation, sir. We are seriously listening, sir.
Yeah, and she is from Riyadh, Saudi Arabia.
Okay.
So she did her PG in Tanjore Medical College, and great people come from Tanjore, including me. And Adila is from Tanjore. Since we are reading the name, many people may put in, but we will stop with the top 3. Let us have competition.
Okay.
Top 3.
Yes.
Okay, super. So this is the picture where you can, it's very difficult to say it is salivary gland, but you can see the small nest of arsenic and the extensive lymphoplasmacytic infiltrate. And when you do cytokeratin 7, you can pick up all the arsenal and ductal component. They are probably like 5% or 10% of the 10% component of this picture, but you can see a nice germinal center and more lymphoid cells. So whenever you see this, you think of lymphoepithelial sialadenitis. Okay, and whenever you see lymphoepithelial sialadenitis, look for fibrosis. Here in this picture, I don't see that much of fibrosis, but whenever you see lamellar fibrosis, lot of plasma cells, look into the major ducts, identify the veins there, and you can see inflammation of the veins, which is known as phlebitis. These are all the 3 main criteria for IgG4 disease. They think IgG4 disease is rare, but I think whenever you say some tumor is rare, awareness is not there. When people are aware, the diagnosis will keep coming up. Okay. See, possibly in the next 3 or 4 months, the IgG4 disease will be more because you are hearing from me. After 4 months, you will forget again, the incidence will come down. Okay. So whenever you see any lesion where the incidence is less, make sure you are not missing it, you are aware of it, and you are making the diagnosis. And please believe me, IgG4 disease is a lot of the time missed in India because we don't follow the criteria and we don't do serum IgG4 level. Super. This is a classic Warthin's tumor. See, some tumors, if you see once, you won't forget. Okay. Dense lymphoplasmacytic background, 2 types of cells. Okay. Large, abundant luminal oncocytic cells and the peripherally compressed cells, abluminal cells. Okay. This is nothing but Warthin's tumor. And when these, and they are all arising from striated ducts. Okay. And these striated ducts, I told you the striations, and they will have a lot of mitochondria in them. And when you do anti-mitochondrial antibody, that will be positive in all the oncocytic cells. Okay. This Warthin's tumor. I will be going slowly faster because I introduced the concept, and these are all the pictures. I will highlight what are all the things to see. I may not be telling all the intricate points because of the time. So this is lymphadenoma. This is a lymph node. You can see the normal salivary gland, nice circumscribed capsulated lymph node. You can see the lymphoid cells, and you can see some other pink cells. You can see some other glandular cells. And when you go to high power, you see the sebaceous cells. So this is lymphadenoma, sebaceous type, and this is all epithelioid cells. Okay, but they are all morphologically very blank. So this is non-sebaceous lymphadenoma. And awareness of this is very, very important, because in frozen sections, okay, in frozen sections, if you are not aware of this, you may think these are all metastases, okay. But please look into the cytology. If they are bland, they are benign inclusions, sebaceous and non-sebaceous lymphadenoma. But you can get sebaceous carcinoma also there, okay. And oops, I'll just go back. Just 1 minute. Hide this plot. Is the full screen visible, Madam Chandra, Madam, now?
Sir, very much. Yes.
Yeah.
And there are two questions. If you would like to answer them
yes.
now, I will,
yes, Madam. Yes, Madam.
Cutoff for plasma cells, IgG4 related salivary gland disease.
40% IgG4 positive plasma cells. Okay, the cutoff is keep changing and it depends upon organ to organ. But you see the number of plasma cells and then do IgG4 and then see how many of them are IgG4 positive, not immunoglobulin. It is immunoglobulin G4. When they are more than 40%, then it is more diagnostic of IgG4 disease. But that lamellar fibrosis and phlebitis, they are more characteristic. Okay, again in India it's very difficult to do IgG4 IHC, so I asked the people to do serum IgG4. But another caveat here, our people, without knowingly what is the diagnosis, they put steroids, and the steroids melt down the plasma cells, so serum IgG4 level may go down. So when you see morphological changes, this is the triad I told you: lamellar fibrosis, increased plasma cells, more than 40% is the criteria of various organs. I kindly request you to refer Google, because it may change yesterday. I don't know. I have not checked it yesterday. So, and then phlebitis. These are all the triad and serum IgG4 level. I directly, whenever I see histological pictures, I call my clinicians and tell them, do a serum IgG4 level. And look into the other organs. Okay, thyroid, what we used to call a Riddle's thyroiditis is IgG4 disease. Sclerosing mediastinitis is IgG4 disease. Sclerosing peritonitis, retroperitoneal fibrosis is IgG4 disease. And sclerosing pancreatitis is IgG4 disease. So whenever you see sclerosis, lymphoplasmacytic cells, it is IgG4 disease. Super, madam.
Yes, sir. One more is there. If lymphoid component is absent in the section, but bilayered oncocytic epithelium is present, can be diagnosed as Borden's tumor?
No, when you don't see lymphoid cells, it may be oncocytic hyperplasia. I will be talking about it later.
Yes, that's all, sir. Thank you.
Super. Madam, we will keep 5 as a criteria for us number
sure.
for our answering. Madam, when you get 5 questions, you stop me. We will answer them. We will go 5 by 5.
Yes, sir, definitely.
Sorry, here this picture is not supposed to be here. The series. No, I want to compare it with. Anand, you mute your mic. So here it is more benign.
John, sir, please mute your mic, sir.
So John, sir, sorry. So this is a benign sebaceous cells, whereas here it is malignant. Okay. So this is sebaceous carcinoma. And for the exam going postgraduate, so one good news, the exam is not going, exam is coming. So the exam coming PG is the sebaceous carcinoma is very common in the eyelid. Okay. Any tumor in the eyelid, if you don't know, just write a description and sebaceous carcinoma. And if you look carefully, you can see the sebaceous cells, more like a microvesicular steatosis in the liver. That's how the sebaceous cells will look. Okay. There's 2 markers, adipophilin and EMA. EMA is very good. Sorry, this picture is hiding the adipophilin and the EMA. EMA is the most commonly used for sebaceous carcinoma or sebaceous cells. And you have to remember one thing, these immunohistochemical stains, they tell the cell of origin. They are not telling benign or malignant. For example, normal sebaceous cell lymphadenoma, sebaceous cell carcinoma, all are positive for EMA. That you have to keep it in mind. Another mixed tumor is a lymphoepithelial carcinoma. You can see a lot of atypia, a lot of mitosis, very atypical mitosis and lymphoid background. When you do cytokeratin, you can highlight the epithelial cells in a lymphoid background. And when you do EBER, this is more diagnostic of lymphoepithelial carcinoma. This comes under poorly differentiated carcinoma now in the new WHO system. Now we are moving to mixed tumors, pleomorphic adenoma, metastasizing pleomorphic adenoma, carcinoma X pleomorphic adenoma, epithelial myoepithelial carcinoma, and carcinosarcoma. They are the main components of mixed tumors. And carcinoma X pleomorphic adenoma, there are 4 components, okay, in situ, intracapsular, minimally invasive. Most of the people follow less than 1.5 millimeters, but now the new WHO, probably you might have caught it in that slide, it is telling 4 to 6 millimeters. Okay, keep that in mind. And then widely invasive carcinoma. And how to differentiate these 4 types, we will see it in a minute. Take a selfie of this for tumors in the mixed category, mixed epithelial category. So pleomorphic adenoma, as I told you, 80% of the time it is pleomorphic adenoma in parotid, and accordingly I should talk more about pleomorphic adenoma. But in the conferences, I think they talk more rare cases rather than common cases. So I am going to follow the same thing. Pleomorphic adenoma, I will be talking only for 2 minutes. So gross section, very well circumscribed lesion, and see that chondroid appearance. Okay, in Tamil, remember nongu. I think in English it is apple eye, eyes of apple, madam. Madam, what is for nongu, madam? Apple eye, I think. Eyes of apple or apple eye, I don't know. So palm tree, okay, palm fruit. Let us be very local. So it will have that chondroid. Whenever there is a chondroid or a myxoid appearance, think of pleomorphic adenoma. It is predominantly because of the pseudocartilaginous appearance in the background. So they will have pleomorphic adenoma. Again, the name, it has to be polymorphic adenoma. It is not pleomorphic. There is no pleomorphism. It is multiple forms. So it has to be more polymorphic. So, and a lot of stroma in the background. Okay. And this is a cellular pleomorphic adenoma where you don't see that much of stroma. And this is a pleomorphic adenoma arising from a minor salivary gland. You can see the squamous epithelium. In the parotid tumor, for pleomorphic adenoma, they won't remove the skin. Okay. And these are all again exam question and exam slide. Tyrosine crystals, and madam might have showed you in the cytology. When you see tyrosine crystals in the FNAC, you have to think of pleomorphic adenoma. Pleomorphic adenoma can show extensive squamous metaplasia, oncocytic changes, adipocytic metaplasia, and they may show nodularity. You remember that picture, but these nodules are very well circumscribed. They are not infiltrative nodules, and they may show a lot of bone and lot of myxoid degeneration, and this makes the FNAC very difficult. Okay, when you see the squamoid cells and the myxoid degeneration, mucinous background, we call it mucoepidermoid carcinoma. Okay, so when you see a lot of oncocytic changes, we call oncocytic neoplasm. But again, remember, pleomorphic adenoma is 80% in the major salivary gland. We have a lot of markers now. But the main marker we use is PLAG1. Why I love this? This is nothing but pleomorphic adenoma gene 1. And I kindly request, many of you will become scientists. I wish you all to get Nobel Prize. But when you are identifying something, you just name it on the condition. For example, I love dog, diagnostic on GIST. You don't have to memorize anything. Okay, so this is pleomorphic adenoma gene 1. We have IHC for that, and that is more specific. Okay, so and HMGA2 is also coming up, but this is not very specific, whereas PLAG1 is more specific. And other IHCs, WT1, P63, GFAP, I just put it for completion. If you want to do only one marker, go for PLAG1, especially in cytology, because histology, you don't need markers for pleomorphic adenoma most of the time. Whereas in cell block, as madam told you, try to do IHC only in the cell block, because in the smears, as madam told, the cells may go off, or you may not get a good quality control. Okay, you cannot run paraffin control for a cytology smear. This is the picture. I did few things on my own, and this is one of my own drawings. I have not copied it. I am very good in copy paste from the Google. I give the best material. I want to give the best material to the listeners. That's why I என்ன சொல்றது வெக்கமே இல்லாம without shy I cut copy from the best things in the literature. And this is the one, very proudly say this is one of my own. And this is a salivary gland, normal salivary gland. This is the pleomorphic adenoma. Okay, well circumscribed. In the pleomorphic adenoma, for example, let us take this gland. Within a gland, you can see malignant cells. Okay, so this is pleomorphic adenoma with the insight to malignancy within the basement membrane of pleomorphic adenoma and within the capsule. In this scenario B, you get the malignant cells within the basement membrane and they are spilling out, but they are not spilling out of the capsule of the pleomorphic adenoma. So this is known as intracapsular carcinoma. Remember the 4 terminologies we use in carcinoma X pleomorphic adenoma. This is in situ carcinoma X pleomorphic adenoma. This is intracapsular carcinoma X pleomorphic adenoma because it has gone beyond the basement membrane, but within the capsule of the pleomorphic adenoma. And when they extend outside, okay, I put here 1.5, but remember the new criteria 4 to 6 millimeters. They are not very sure this since it's arbitrary. But my thing is, when you keep it more than 1.5 millimeter, it will cover 4 to 6 millimeter also. So this is minimally invasive. When do you call it? They are spilled out of the basement membrane. They are spilled out of the capsule. They are coming into the parenchyma, but the distance in the parenchyma is less than 1.5 millimeter or 4 to 6 millimeter in the new criteria. And when they then you call it minimally invasive. Okay, and when it comes out and they extend more than 1.5 millimeter or 4 to 6 millimeter, then it is widely invasive. Okay, very simple if you understand this picture. But many times they come with widely invasive. These are all like incidental findings. In situ, intracapsular, or minimally invasive. Okay, most of the time what we see is widely invasive carcinoma, but this is a theoretical explanation for the 4 terminologies. Take a snapshot of this. Okay, so these are all the pictures. Carcinoma X pleomorphic adenoma, you can see the malignant cells and they are within the capsule. Okay, so this is intracapsular. Here it is minimally invasive. They are coming out like in thyroid follicular carcinoma, mushrooming. Okay, so this is distance is less than 1.5 or 4 to 6 millimeters. So this is minimally invasive. And here it has come out. This is the border of the pleomorphic adenoma. Carcinoma has come out into the adipose tissue. So this is widely invasive. And whenever you find some atypical cells, you are not sure whether it is invasive carcinoma or not, you do the basal cell markers. Okay, and this is a double staining where they see the smooth muscle marker and P63. P63 will take up the nucleus. Okay, so here there are the atypical glands without P63 or malignant. So these are pleomorphic adenoma, whereas here it is carcinoma arising in pleomorphic adenoma. Okay, and P653 is also very helpful in identifying carcinoma X pleomorphic adenoma, because in pleomorphic adenoma type, P53 should be negative, whereas in carcinoma component of pleomorphic adenoma, it will be positive for P53, and you can couple it with Ki67. Okay, don't do only P53. Even though this picture is very good looking, you may not get these nice pictures in real life. So always combine with P53 and Ki67. If both are positive, then the chances are more on the malignant side. So this is a salivary duct carcinoma arising in pleomorphic adenoma. Remember, you cannot diagnose carcinoma X pleomorphic adenoma. After that, you have to qualify. salivary duct componoma, salivary duct carcinoma, 40%, acinar cell carcinoma, 80%, or adenocarcinoma arising in pleomorphic adenoma, 30%. Like that, component of the carcinoma and what is the percentage you have to mention. This is another biphasic tumor, very nice picture. These are all, again, if you see once, you won't forget. You can see nicely two types of cells, luminal cells and abluminal cells. So these are epithelial cells. These are myoepithelial cells. It's invading into the parenchyma. So this is nothing but epithelial myoepithelial tumor. I told you the cytokeratin, low molecular weight cytokeratin will be positive for epithelium. Even CD117 will be positive in the epithelium. Whereas P63 is positive in the abluminal cells. Okay, so when you do epithelial and myoepithelial marker, you can confirm the epithelial myoepithelial carcinoma. But please believe me, it is a HNE diagnosis. And please remember, HNE is the queen. I used to say HNE is the king, but after playing chess with my son, I decided I should say more powerful person is queen. Okay, so HNE is the queen, IHC is the king, very restricted. Okay, don't base your diagnosis only on IHC. Always go back and correlate with HNE. So this is epithelial myoepithelial carcinoma. Carcinosarcoma is the last one. This comes under polydifferentiated carcinoma or high-grade carcinomas. You can see the epithelial component and you can see the background malignant stromal component. In the high power, you can see better malignant epithelium and malignant stroma. So in the breast, they call it metaplastic carcinoma, but in other organs, they call it carcinosarcoma. And another kind request, I'm sure you all will be sitting in the panels in future. Please come up with one terminology for all organs. Okay, why you call metaplastic carcinoma in the breast and carcinosarcoma in the salivary gland? I don't know. So now we are going to myoepithelial. Myoepithelioma and myoepithelial carcinoma. Okay, and you see there are 5 types of myoepithelial pattern. Okay, they can take a stellate cell, star-shaped spindle cell, epithelioid cell, plasmacytoid cell, or clear cell. This is another university question. Okay, myoepithelial cells or myoepithelial lesions in salivary gland. Okay, please mention all these 5 and take a selfie of this. And here I am putting more plasmacytoid myoepithelioma, and here P63 is the marker. Here you can see more spindled out cells. Okay, so remember 5 types of cells in myoepithelioma. And when this myoepithelium is well circumscribed, it is myoepithelioma. When it is infiltrating, then it is myoepithelial carcinoma. Please remember that. No other criteria. Atypia mitosis won't be helpful in salivary gland to differentiate benign from malignant. Infiltration, speed of growth. Now we are coming to epithelial, and epithelial you have to see the pattern and cells. There are 7 patterns you have to remember in the pure epithelial tumors of salivary gland, and 5 cell types you have to see. Take a selfie of this and I will take a small break. Madam, any questions, madam?
Yes, sir. 2 questions are there. I'll read them for you. 1 minute. 3
yes, madam.
questions. Okay, sir.
We,
Sir,
need 2 more questions. Please type in 2 more questions. Okay, madam.
So how do we differentiate between in situ and intracapsular? That came when you were discussing about the pleomorphic adenoma.
Yeah, in situ means within the basement membrane, not coming out of the basement membrane. Intracapsular, coming out of the basement membrane of that particular component, but within the capsule. You remember that picture. It's more self-explanatory.
Okay, sir.
Super, madam.
Then referred many articles. The cutoff for plasma cells and IgG4 related diseases 40%. One of the article quotes, some researchers have suggested an IgG4 plus IgG plus plasma cell ratio of more than 40% as a comprehensive cutoff value in any organ.
Yeah, in that you have to do IgG first and then do IgG4. You count the number of IgG positive plasma cells and then count the number of IgG4 positive plasma cells and come up with the ratio. These are not practical. It's very good for academic institutes and I love academic work. But in real life, you please remember the triad: lamellar fibrosis, increased number of plasma cells, and phlebitis. If they come up with the numbers 40, if it is 39, how sure you are counting 39, not 40? And when you are counting 41, how are you sure between 39 and 41? So these are very arbitrary. Probably artificial intelligence will help us, but I cannot count 39 and 41 with 100% surety. What do you think, madam? You can count 39 and 41?
No, definitely not.
Yeah.
And the third question is, in myoepithelial cell immunohistochemistry, always a panel is done instead of a single marker. Markers which are positive in one case may be negative in another case. Why and what is the most appropriate panel?
Yeah, but again, it depends upon what is the differential diagnosis. Okay. So for myoepithelial cell, H&E, you see the pattern. For example, if it is a plasmacytoid, no other tumor in the salivary gland will have plasmacytoid cells like that. No need to do marker. When it is oncocytic or clear cell, definitely you have to do marker. Okay, the differential diagnosis are oncocytic and myoepithelial. Okay, and oncocytic, I told you, anti-mitochondrial antibodies, and for plasma, for myoepithelial cell, P63 or P40.
I think
P40 is very specific and sensitive. That's why I was telling P63 or P40, because SMA, S100, calponin, high molecular weight cytokeratin, these are all the other markers, but the specificity and sensitivity are less. Again, in our country, you have to restrict the number of markers. I agree, we have to do panel, but panel should be 5 or 6, not 40 or 50. So in oncocytic lesions, I will do mucoepidermoid carcinoma, acinar cell carcinoma. I will be talking about oncocytic cells. I will highlight the markers at that time. And I will answer the markers as we move on.
Yes, and I think you've answered also. Okay, that is the sensitive and most sensitive and specific marker was a question, and I think you said the answer as P40. And
yeah, but you have to keep on checking the literature. Today it is P40, tomorrow it is P39. I don't know. Okay, super.
Sir, and where do Sjogren's syndrome fit under this? Is the last question.
Sjogren's is lymphocytidinitis. What is that? Lymphoplasmacytic cytidinitis.
Yes.
Okay, but many Sjogren's syndrome may turn out to be IgG4 disease. Again, morphologically look for fibrosis. I am stressing this criteria again and again because I love IgG4 disease. When you go back to Ramachandra, all IgG4 disease, I may be overcalling, but whenever I see fibrosis, plasma cell, and phlebitis, I call it IgG4. Okay, so Sjogren's may come into IgG4, and treatment is steroids. That's I don't know how that fibrosis will respond to steroid. We think fibrosis is the unreversible end stage, isn't it? But in IgG4 disease, even that fibrosis goes off. I don't know how. So Sjogren's, right now it is an autoimmune disease. Probably tomorrow it may be a spectrum of IgG4 disease.
That is also questions. That is all we have completed then.
Super. We will go to this pattern and cells. I think you all might have taken a snapshot of this. So canalicular pattern. Whenever you see canalicular pattern, there is only one condition: canalicular adenoma. When you see glandular pattern, these are the differential diagnoses. I'm not going to read about individual conditions because we will be seeing the pictures of them. When you see cribriform, very, very important. These are all the DDs. Cystic lesion, differential diagnosis. Mucinous lesions, differential diagnosis. Papillary lesions, differential diagnosis. And diverse pattern, differential diagnosis. Okay, snap time, screenshot time. So these are all the various patterns and various tumors in the salivary gland. Coming to the cells, there are 5 types of cells. We have a good number of cases for squamous, few in sebaceous, many in oncocytic, many in small blue cells, and some in clear cells. So sorry, not some in clear cells, many in clear cells. But whenever you see clear cells, first think of metastasis. We usually think of RCC, but please remember there is a clear cell melanoma and there is a clear cell follicular carcinoma. Okay, please remember that too. And when it is a primary clear cell carcinoma, see whether they are benign or malignant. When it is benign, think of pleomorphic adenoma, myoepithelioma, and oncocytoma. When it is malignant, whether it is pure clear cells or predominantly clear cells. When it is pure clear cells, is it dimorphic or monomorphic? When it is monomorphic, it is clear cell carcinoma, myoepithelial carcinoma, and sebaceous carcinoma. When it is dimorphic, we already saw it, epithelial myoepithelial carcinoma. When it is predominantly clear cell, it is mucoepidermoid and actinic cell carcinoma. I think it's a snap time, screenshot time, because clear cell carcinoma of salivary gland is one of the university questions. Do you know when I use the university question? When I think people are sleeping, I will say, this is very important in the university question. Everybody will wake up, especially in the offline classes, and they will start writing it down. So when you become teachers, you can use that. Okay, when people are not listening, you tell them, this is what they ask in the exam. Everybody will stop talking and they will listen to you. Canalicular adenoma. Canalicular is nothing but tubular cells which are communicated. Okay, all tubules communicated and they will form epithelial knots. And S100 and cytokeratin 7 is a very classic marker for canalicular adenoma. When you have glandular cells, first you have to see whether it is neoplasm or hyperplasia. Okay, here I want to bring the concept of hyperplasia, adenoma, carcinoma. When you talk about hyperplasia, any hyperplasia, they don't have capsule and they will be freely talking along with the adjacent parenchyma. That is hyperplasia. But when they have a well-defined capsule, the same thing will become adenoma. And when they are infiltrating the capsule, they will become carcinoma. Okay, so that's the sequence you have to remember: hyperplasia, adenoma, and carcinoma. And this is one of the best example of this hyperplasia. Okay, intercalated duct hyperplasia. This is not under this heading. Intercalated duct hyperplasia or adenoma is one of the component, one of the tumor or lesion where they can form glands. All the malignants, sorry, I should have typed it only secretory carcinoma. I put mammary analog. I have to remove it. Okay, so old terms never dies that quickly. So this is a salivary gland. You can see well differentiated. You can see glands as well as a lot of adipose tissue. So this is adenoma. Okay, see the difference between hyperplasia and adenoma. Lot of fat component. So this will be adenoma with a stromal component, which is more lipoma. Okay, and wherever possible, you just mention probably fat is 60% and the epithelial component is 40%. Next, acinar cell carcinoma. Acinar cell carcinoma can have various patterns, but here you can see nice acinar cells. And one of the clue for acinar cells, there will be a lot of lymphoid infiltrate. Okay, and this is also known as tumor-associated lymphoid proliferation, TALP. Okay, and remember that advanced histology where the acinar part of the acinar intercalated ducts are positive for SOX10 nuclear positivity. And DOG1 is also positive. So remember the tumor-associated lymphoid proliferation. And I have not checked the literature, but I want all of you to check now. Okay, right now when I'm presenting, whether we can use PD1 and PDL1 in this. And that's the concept you have to remember. Whenever you see many lymphocytes in a tumor, think of PD1 and PDL1. And think of microsatellite instability also. Okay. So if you take back medullary carcinoma of the colon or tumors of the colon that microsatellite instability, they will have a lot of lymphocytes and they will respond to PD1 anti-PDL1 treatment. Okay, one of you please check and tell me in the next break. So they can have solid pattern, microcystic and follicular pattern, and the cell types may be vacuolated clear cell, oncocytic or hobnail cells. And one very good news for acinar cell carcinoma, we now have a molecular marker that is a surrogate ISC marker called as NR4A3. Okay, and there is another very big person, Dr. Jason in soft tissue tumor. He tells a clue how to remember these new markers. Okay, keep the new marker NR4A3 as your passcode in your cell phone for a week. Okay. So you please tell this week is for acinar cell carcinoma. So the passcode is NR4A3. And if you keep on using that for 1 week, you will be comfortable with the NR4A3. Okay, next week you go for another condition, but keep writing these things in a notebook. Otherwise, you don't forget the password and then message me, sir, because of your idiotic idea, I'm not able to open the phone. I'm not responsible. Okay. And I want to give a disclaimer. I am responsible for what I am saying. I am not responsible for what you are understanding. My saying may be different from your understanding. For your understanding, you are responsible. Please remember that. And many of the new markers, they are all nuclear markers, okay? NR4A3, these are all transcription markers. So they are predominantly nuclear markers. Acinar cell carcinoma, NR4A3. Secretory carcinoma, again, I have to change it. It is not mammary analog. It is secretory carcinoma. I will make a note of it to change it. Mammary analog secretory carcinoma. 2 times I have to change. So this will have a lot of eosinophilic secretions, and the cells will be more foamy, and we have a very characteristic translocation. Okay, 1215 ETV6 NTRK3. Don't try to memorize these things. It is not humanly possible. Okay, just remember, number one, they have a specific translocation, and they have a marker for that, which is nothing but PanTrack. Before that marker, this is mammary analog, so mammoglobin and even GATA3 will be positive, P63 here and there. But PanTrack is a very good marker. Remember, somebody is talking about panel of markers. So you have to take what is the differential diagnosis. For example, if it is acinar cell carcinoma or secretory carcinoma, I will do only 2 markers. For acinar cell carcinoma, I do NR4A3, and for secretory carcinoma, I do PanTrack. Okay, so PanTrack is nice nuclear marker for secretory carcinoma. And when this gland formation is not belonging to any other, or whenever there is a signet cell carcinoma, or whenever there is a mucinous carcinoma, they are classified under adenocarcinoma NOS. So that's about glandular pattern. Madam, any questions, madam?
Sir, no, sir, no questions. Sir, actually, sir, at this time you want to address the earlier question, sir. When madam was talking, there was a question about S100 being used in arsenic cell carcinoma and secretory carcinoma. So how useful is S100 for differentiation?
I won't use S100 nowadays, madam.
Yes.
Because we have more specific markers. Okay, please forget S100.
Yes.
So for arsenic cell tumor, use NR4A3. And what is the other secretory carcinoma, madam?
Yes, sir.
What is the DD they asked?
Arsenic and secretory, sir. Arsenic cell carcinoma and secretory.
We have transcription markers, luckily. Yes. Okay, so I will use NR4A3 and the PanTrack marker for secretory carcinoma.
Sir, Ushakini ma'am has sent a message to share with the delegates. I'm just posting it here regarding one of the questions that were asked. She has told that dog1 would be positive in adenoid cystic carcinoma as mentioned, and it is marker negative in secretory carcinoma, while S100 is better expressed in secretory carcinoma. It is cytoplasmic. I wouldn't use or stress much on S100 in IHC at all in any field.
And for adenoid cystic carcinoma, we have MOAB. I will be talking about right now. Okay, we have more specific markers now. So for cribriform, very, very important practically. Okay, because here, as madam mentioned, even benign and malignant are differential diagnosis, and clinicians will kill you when you say basal cell adenoma in the FNAC and it turns out to be adenoid cystic carcinoma in the frozen section. All small blue cell tumors, I ask frozen section in my hospital, okay, because we can miss low grade and high grade carcinomas, and treatment is totally different. For basal cell adenoma, it's local excision, whereas adenoid cystic carcinoma, radical excision with the lymph nodes. So any small blue cell tumor in the FNAC, I will ask them to go for frozen section. I may be over asking for frozen section, but I don't mind doing that. What is that? I think this is MOIB. I will just, I don't know, I forgot to remove some pictures. What I can do is, just 1 minute. So, okay, you believe me, I will be showing more pictures of this adenoid cystic carcinoma. So for the time being, let us go with the things. So this is the nuclear marker. You can see the cribriform pattern. Okay, and MOIB is the translocation specific for adenoid cystic carcinoma. That is very, very helpful. MOIB. It's a translocation 6-9. fusion of MOB and FIB. Well, these are all the things I don't want to memorize. I want you to memorize MOB or remember MOB. Okay. So this is the cribriform pattern. Okay, here I took it from one of the articles where they showed 4 tumors with the cribriform pattern, and they luckily labeled it. A is polymorphic adenoma or pleomorphic adenoma. B is canalicular adenoma. C is again another pleomorphic adenoma, and D is adenoid cystic carcinoma. Okay, so for example, for I think this has to be polymorphic adenocarcinoma. Okay, PAC, it is S100 positive. Just now I told you S100 I won't do it, but for polymorphic adenocarcinoma, S100 is very classic. I show you the picture. For canalicular adenoma, location usually in the upper lip. For pleomorphic adenoma, I'll do PLGA1. Okay, pleomorphic adenoma gene 1, PLAG1. Okay, and adenoid cystic carcinoma, MOIB. So basal cell adenoma and adenoid cystic carcinoma can look alike. Ki67 is very, very useful along with the MOIB. Ki67, I think they use cutoff is 20%. If it is less than, they give a wide cutoff, 5 to 20%. Less than 5, basal cell adenoma, more than 20, adenoid cystic carcinoma. Okay, and another way to remember nicely between the cribriform pattern, you see where is the mesenchymal component or stromal component. Okay, if it is around the tumor cells are more, stromal cell element is less. Think of basal cell adenoma. Okay, if it is individual cells surrounded by stroma, it is more pleomorphic adenoma. If the stroma is surrounded by epithelial cells, it is adenoid cystic carcinoma. See, in Tamil you can say படுத்துக்கிட்டும் போத்திக்கலாம், but in salivary gland that won't come nicely. Okay, படுத்துக்கிட்டு போத்திக்கிட்டா it's a pleomorphic adenoma. போத்திக்கிட்டு படுத்துக்கிட்டா இது adenoid cystic carcinoma. Sorry for talking in Tamil. I know there may be many people, but unfortunately I don't know Hindi and I don't want to kill English. Another selfie time. I love this cartoon. It tells a lot of things. Salivary duct carcinoma, when you see comedodcis in salivary gland, it's a salivary duct carcinoma. And when you go to high power, in between these comedocarcinomas, you can see infiltrating ductal carcinoma breast in the salivary gland. And many times they will show apocrine changes. Okay, so this is nothing but ductal and apocrine carcinoma of the breast happening in the salivary gland. Okay, you will be thinking of comedodcis. So salivary gland carcinoma, we have beautiful marker, androgen receptor and HER2/neu. Okay, very, very important. Cribriform carcinoma of minor salivary gland. Previously, it is called as CAT, cribriform carcinoma of the tongue. Now it is known as cribriform carcinoma of minor salivary gland. Even though we call it cribriform, it will more look like glomeruloid to me. And when you see the high power, you see the papillary carcinoma thyroid. Okay, all overlapping nuclear enlargement, clearing, grooving. And when you see it in salivary gland with this glomeruloid or irregular cribriform pattern, think of cribriform carcinoma of the minor salivary gland. And we don't have any specific marker, but SMA may be helpful. Most of the cells will be positive for SMA, but anatomic location and HNE, you can make the diagnosis of cribriform carcinoma of the minor salivary gland. Now we are going to cystic lesions, sclerosing polycystic adenosis, which is nothing but fibrocystic changes, intraductal carcinoma, cystadenoma and cystadenocarcinoma. Now cystadenocarcinoma moved into adenocarcinoma, NOS. Okay, see, if I don't tell you this is breast, what do you call? Fibrocystic change. But please believe me, this is taken from the internet, from a salivary gland lesion. Okay, and this is a nice apocrine changes. And whenever there are small glands, you are wondering whether it is carcinoma, just do P63 to highlight the myoepithelial cells. Okay, they will be nicely positive. So this is fibrocystic disease of salivary gland, but for exam purpose, it is sclerosing polycystic adenosis. This is intraductal carcinoma, where you see the cystic lesion with epithelial proliferation lining the cyst, and you can see the myoepithelial cells very nicely in the periphery. And this epithelial proliferation may show low-grade features, intermediate grade or high grade, like DCIS in the breast. But whenever I have 3-tier system, I don't like it. I want to have only 2-tier system, low grade and high grade, no intermediate. I put all my intermediate into either high grade or low grade, depending upon the features. And the whole world is following that. Whenever there are 2-tier system, it's more practicable. Whenever there is a 3-tier system, it is not practicable. So P63, when you do the nuclear marker, you can very nicely see. That's why previously this is called as low-grade cribriform carcinoma, but now it is renamed as intraductal carcinoma because they are arising within the duct. And this is the best example of intraductal carcinoma, high grade. And whenever you see intraductal carcinoma, you go for multiple depots. Here it looks like low grade and here it looks like high grade, but here it is having carcinoma. Okay, so this is more like carcinoma arising in a background of intraductal carcinoma. Cystadenoma, like in ovary, you see only the cyst. It is more like serous cystadenoma. And when you see multiple depots and you all embed, and whenever there is solid areas, you embed it and you may see invasive carcinoma, then it will become cystadenocarcinoma, which falls under adenocarcinoma NOS. As I told you, mucinous carcinoma and signet cell carcinoma are clubbed into adenocarcinoma NOS. So the only left alone component in mucinous tumor in the epithelial lesions of salivary gland is mucoepidermoid carcinoma. And this is the best example of mucinous carcinoma. When the mucin is especially extracellular, it is mucinous. When it is intracellular, it is signet cell. CK7 will be positive in salivary gland lesions. And mucoepidermoid carcinoma, it is, you know, it is mucoepidermoid. And so you see 3 types of cells: mucous cells, squamous cells, and hybrid cells. Okay, that has both the features of mucinous and the squamous cells. So depending upon the microscopic picture, it is divided into low grade, intermediate grade, and high grade. And I usually put intermediate grade in high grade. We follow the AFIP system that I will be showing you in the slide seminar. And mucoepidermoid carcinoma can do a lot of mimicking. Okay, oncocytic clear cell. You cannot believe this is mucoepidermoid carcinoma clear cell type. This is mucoepidermoid carcinoma oncocytic type. And sclerosing I will show you in the squamous differentiation. This is mucoepidermoid carcinoma. Mucoepidermoid carcinoma, mainly these are all myoepithelial cells, so they will be P63 positive. But luckily we have a translocation marker, MAML2. Unfortunately, it is not widely used in IHC, but the FISH diagnosis is very, very important. Whenever you think of mucoepidermoid carcinoma or in the differential diagnosis, you send it for FISH for translocation 1190. So now we are coming to papillary. Previously, there are 3 terminologies. Now everything comes under ductal papilloma. Previously, this is called intraductal papilloma, which is nothing but adenoma in the papillary adenoma in the nipple, or papilloma in the nipple. And there is another terminology which is called cyalladenoma papilliferum, where there is a glandular proliferation with extensive squamoid proliferation over that. Okay, this is where the major salivary gland opens into the skin, that shows irregular acanthosis and pseudocarcinomatous hyperplasia. And when you do marker for CK7, this glandular epithelium and ductal epithelium will be positive, whereas the skin epithelium, the squamous epithelium, is negative for CK7. So this is called as cyalladenoma papilliferum. Now that comes under intraductal papilloma. And there's another variant called the inverted intraductal papilloma that looks like more like a urothelial papilloma within the salivary duct. I always remember whenever I see something, I try to correlate. Do we see anything else like this in any other organ? And if I showed you only this picture, you might have called it as inverted papilloma or papilloma of the bladder. Okay, if that happens in salivary gland, it's intraductal papilloma. Previous type was inverted type. Lastly, diverse pattern. We have only one tumor, which is now called as polymorphic adenocarcinoma. Previously, it is called as polymorphic low-grade adenocarcinoma. Now they removed the low-grade, but they grade it polymorphic adenocarcinoma, low-grade and high-grade. 3 things are very important: border irregularity, architectural diversity, and cytological uniformity. Okay, so you can see the infiltrative borders. And diversity, it can have a glandular tubular pattern, trabecular pattern, papillary pattern, cribriform pattern. So diversity is there. And this is another thing, I got it from Dr. Thompson's thing. Remember, his first name is Lester. And you see in 2016, there is a storm named as Lester, okay, Hurricane Lester, okay. It has like a targetoid picture. He showed it in this and then immediately showed this, okay. The polymorphic adenocarcinoma will have this targetoid pattern, like in lobular carcinoma of the breast, okay. So you can compare the storm, Hurricane Lester, okay. And this one is strongly positive for S100. See, that's why I tell always, don't tell always and don't tell never. Okay, S100 protein is very, very useful in polymorphic adenocarcinoma to highlight the thing. And when you see the targetoid pattern, in the breast, they are around ducts, whereas here they are around the peripheral nerves. Okay. In addition to adenoid cystic carcinoma, polymorphic carcinoma is a very well-known entity that goes around the nerve bundles. Okay, remember S100 targetoid pattern. Hurricane Lester. So now we are going to 5 types of cells. Madam, any questions, madam?
Sir, one question I'm seeing, that is how to differentiate adenoid cystic carcinoma from cribriform carcinoma.
Cribriform carcinoma should be low-grade cribriform carcinoma. No, you cannot say cribriform carcinoma. There is no cribriform carcinoma by itself in salivary gland. And you do the MOIB, and depending upon the differential diagnosis, is it cribriform pattern in pleomorphic adenoma? Is it a cribriform pattern in basal cell adenoma? So is it a core biopsy, or is it a FNAC cell block, or is it a excision biopsy? So many things we have to go through before putting the markers. If it is a cell block, I will put a PLA-G1 to rule out pleomorphic adenoma. I will do beta-catenin for basal cell adenoma. I will talk about it in a minute. I will do MOIB for adenoid cystic carcinoma. I will do S100 for low-grade the cribriform carcinoma of the minor salivary gland. And I will look at the nuclear features. If it is papillary carcinoma like thyroid features, I will go for cribriform carcinoma, CAT. Cribriform carcinoma of the tongue, now known as cribriform carcinoma of the minor salivary gland. That again depends on the location. So my markers depends upon what is the, is it major salivary gland or minor salivary gland, and what is the differential diagnosis, and whether it is cell block, core biopsy, or excision. Super, madam.
Okay, that is all, sir.
Good. We will go quickly in these cells. Squamous cell lesions are keratocystoma, squamous cell carcinoma, and sclerosing mucoepidermoid carcinoma with eosinophilia. So it is a big cyst full of keratin lined by atrophic squamous epithelium. And whenever you see keratin, there can be foreign body giant cell reaction. So it is keratocystoma. And this is squamous cell carcinoma. Even grossly, you can see the extensive gray white or pearly white appearance, and this is the major duct, and squamous cell carcinoma arising from the major ducts. And will they be SOX10 positive or SOX10 negative? Madam, 5 seconds for anybody to answer. First person when we will mention the name.
Yes.
Squamous cell carcinoma arising in the major duct, SOX10 positive or negative? Time over, madam. Any answer?
No, sir, not yet. One has come, 1 minute. But different, no, sir. That is an unrelated comment by somebody.
I use my PGs, idiots of the
negative.
Negative. Very good, madam. Otherwise, I will scold them. Idiots of the black cards of the fools. This is in the distal, so SOX10 positive. Acinar end, SOX10 and positive. Distal end, ductal end. You remember acinar end, SOX10 positive. Ductal end, SOX10 negative. Okay, squamous cell carcinoma. Thank you. What is the name, madam? Who told negative?
No, anonymous, sir.
No dog, cat, rat,
nothing.
Crocodile. No.
Pathology, Stanley Medical College. One more person has replied as negative. So that is the name is Stanley Medical College Pathology.
Congratulations. So this is another squamoid cells, and you see a lot of sclerosis and a lot of eosinophils. Okay, some mucin secreting cells. So you put everything together: sclerosing, mucoepidermoid carcinoma with eosinophilia. Okay, so once you know the diagnosis, then you can see all the features. But you have to see all the features and then come to a diagnosis. Here you can see squamous cells. And the sebaceous, we already covered it. We see the sebaceous lymphadenoma and sebaceous carcinoma, and the EMA is the marker. For oncocytic, there are again differential diagnoses: non-rural oncocytic hyperplasia, oncocytoma, and oncocytic carcinoma. Ulnar cell carcinoma and mucoepidermal carcinoma can show oncocytic features. Okay, in oncocytic hyperplasia, you see multiple nodules. There is no size criteria. Okay, and lot of parenchyma. And when you see microscopically, as I told you, the oncocytic hyperplastic cells are freely talking to the ulnar cells and adipocytes. No capsule. Okay, so no capsule, increased number, hyperplasia. Capsule. Here, this is a very nice picture. This is the first time I am seeing that stellate scar. I have seen it in kidney, but I have not seen in salivary gland. So somebody, if they want to do a research, you can do a research. Why oncocytic tumors produce stellate scar? That's I don't know the answer. And when it is infiltrating, it is oncocytic carcinoma. When it is not infiltrating, it is oncocytoma. And when you go to high power, hyperplasia, oncocytic adenoma, oncocytic carcinoma will have the same picture. It is different depending upon what is the border. Coming to clear cells, as I told you, metastatic and primary. Primary is benign and malignant. Malignant is pure clear cell and predominant clear cells. Okay. One very good thing in clear cell carcinoma of the primary clear cell carcinoma of the salivary gland, we have a characteristic translocation, EWS or ATF1 gene fusion, but there is no IHC available in that. And most of the time, the clear cell carcinoma will have a hyalinizing stroma on the background. So that's why it is sometimes called as hyalinizing clear cell carcinoma. Okay, and you can see the clear cells, and these are all myoepithelial cells. That's why they are nicely positive for P63. Lastly, small blue cells, cyeloblastoma, small cell carcinoma, basal cell adenoma carcinoma, adenoid cystic carcinoma. This is the most difficult area in FNAC. But small cell carcinoma, you see a lot of apoptotic bodies and crush artifact. Cyeloblastoma happens in kids. And adenoid cystic carcinoma, rapid growth, pain. As madam mentioned, nerve involvement, pain will be there. Basal cell adenoma carcinoma, long duration, slow growth. These are all theoretically very easy to say, but practically it's very difficult. So this is cyeloblastoma, and the lobularity is maintained. Okay, this is other name is salivary analog tumor. They look like salivary gland, but they are more primitive. Probably when they look into embryology of salivary gland at the 20 weeks, 18 weeks may look like this. That's why it is cyeloblastoma. And again, S100 is positive. In addition to polymorphic adenocarcinoma, cyeloblastoma is condition where S100 is more positive. But again, age and pattern, you can diagnose. So this is a small cell carcinoma. It looks like lymphocytes, but when you go to high power, punctate necrosis, and you can see a lot of small blue cells and the chromogranin nicely positive. The new marker is INSM1, insulinoma associated protein. So any neuroendocrine marker positivity, think of small cell carcinoma.
Sir, Rajendran sir, 1 second. Our Dean sir has logged in, sir. Sundaram sir, Professor Sundaram sir has logged in.
Hello, sir.
Hello. Good afternoon.
Very nice to talk to you, sir. Sorry, I'm not able to join the inauguration.
Sorry, I joined late today. We had a meeting.
No problem, sir. Thank you very much for involving me in your CME, sir.
Okay. Please carry on, sir. Please carry on.
Thank you. So basal cell adenoma, again, there can be a lot of patterns: solid, tubular, trabecular, membranous. And this membranous is very, very important because it is the closest mimicker for our adenoid cystic carcinoma. Okay, so, and this is the trabecular pattern, and this is cystic degeneration happening in the basal cell carcinoma. But when you see carefully, basal cell carcinoma will have the peripheral palisading. Okay, peripheral palisading even in a cribriform pattern, and they will show that cleft artifact. Those two are very important to remember. And luckily now beta catenin is positive in basal cell adenoma. Okay, and the beta catenin associated proteins are also, I think, LEF, that also positive in basal cell adenoma. And for basal cell beta catenin, you have to look for nuclear marker. Okay, Normally, beta-catenin can be present in a cytoplasmic or a border in the membranous pattern. But when the beta-catenin gene is involved in malignant transformation or neoplastic transformation, they will go into the nucleus. Nuclear beta-catenin positivity is very important for neoplastic diagnosis. And final part 4, molecular changes in SGT. Madam, any questions, madam? That is the major chunk, that pattern analysis is very, very important.
Only one question, sir. For differentiating cribriform and adenoid cystic carcinoma, will nuclear features help?
No, they won't help. Again, it depends upon whether it is cell block, core biopsy, or excision. In excision, it may help, but the one-word answer is no. Nuclear features won't help.
Okay, sir. And then I have a question.
Except the cribriform carcinoma of the minor salivary gland, where the nuclear features will look like papillary carcinoma.
Okay,
Yes,
sir.
madam.
Sir, one more question, sir, from my side. Sir, for high-grade mucoepidermoid carcinoma to be differentiated from a metastatic squamous cell carcinoma, how do you go about, sir?
Super question, madam. Send that for fish. I know you are a vegetarian, but you have to go for fish.
Okay.
MAML2.
All right, sir.
Probably in another, they are working on IHC marker, madam. I am not able to get a very good picture.
Okay.
So IHC marker will be coming for MAML2.
Okay, sir. Sure.
The way I remember, it's a lawyer, MA, Master of Arts, and ML, Master of Law, twice. So MAML2. You can have your own mnemonics to remember all these things. So we will go to molecular changes and what are the IHC markers, surrogate IHC markers. I'm not going to read about all these things. I will just mention important things. Pleomorphic adenoma, PLAG1 and HMGA2. For carcinoma X pleomorphic adenoma, TP53, I showed you a picture that is very, very important. For epithelial myoepithelial carcinoma, they are telling HRAS mutation is 25% it is expressed. This percentage prevalence is very, very important to remember. For basal cell adenoma, as I told you, 70% they express beta-catenin. For mucoepidermoid carcinoma, I told you MAML2, either with CRTC1 or C3, 80% with CRTC1 and MAML2. For salivary duct carcinoma, it is HER2 expression and androgen receptors. For acinar cell carcinoma, I told you NR4A3, 84% expressed, very good marker. For adenoid cystic carcinoma, I told you MOIB. For secretory carcinoma, NTRK3. For clear cell hyalinizing, it is EWSR ATF1. For polymorphic adenocarcinoma or cribriform adenocarcinoma of minor salivary glands, we don't have markers, but they are having mutation. Molecularly, you can go for PRKD, either 1 or 2 or 3 rearrangements with arid 1A. Okay, these are all more molecular. We don't have markers right now. So what is the way to remember? As I told you initially, whenever there is a molecular marker, you have to see whether it is diagnostic, prognostic, or theranostic, which is therapy related. Okay, for pleomorphic adenoma, PLAG1 and HMGA2, we have IHC. It is helpful in diagnostic and therapeutic. For mucoepidermoid carcinoma, I told madam to send it for fish for MAML2 fusion. It is both diagnostic and prognostic. For adenoid cystic carcinoma, MOIB is available in IHC. It is diagnostic and prognostic. For secretory, and all these markers in future, they will be predictive. Theranostic use also will be there. For secretory carcinoma, it is the NTRK, basal adenoma, beta-catenin, both available in IHC. Okay, take a screenshot of this. For acinar cell carcinoma, we have NR4A3. For salivary duct carcinoma, we have androgen receptor and HER2 receptor. For polymorphous, I told you PRKD1. For clear cell carcinoma, I told you UWSR and ATR. Okay, but unfortunately, IHC markers are not available today. Tomorrow, the features may change. For myoepithelial carcinoma, again UWSR1. For epithelial myoepithelial, it is HRAS. Take a snapshot of this. So this is the composite picture I thought I will show you. For pleomorphic adenoma, all are nuclear marker, most of them. Please remember that. HMGA2 and PLGA1, PLAG1. PLAG1 is more specific. For basal cell adenoma, it's beta-catenin. For adenoid cystic carcinoma, it is MYB. For acinar cell carcinoma, it is NR4A3. For secretory carcinoma, it is PanTrack. For salivary dead carcinoma, like DCIS in the breast, androgen receptors and HER2/neu, nice 3+ membranous positivity. Take a snapshot of this. It's a very good. I love this. I took it from many articles and many images. To get this one image, please believe me, you have to see more than 100 images to get the best for you. So lastly, but not leastly, PTNM staging and meeting the guidelines of NCCN. Very, very important. Okay, PTNM, it's like a big table here. It's very difficult to differentiate. So you have to come up with the features. What are the very, very important things? Size between 2 to 4 centimeters. Extra parenchymal extension, which is present grossly. Microscopically, when you see, it doesn't come under T4. If they see grossly, then it is T4 and destructive invasion. Okay, so depending upon these three, you classify them into TX to 4B. Lymph node, again, there are a lot of criteria are there, but you decide what is the very important. Is it a single node or multiple node? Is the node metastasis size, is it less than 3 centimeter, 6 centimeter, or in between 3 to 6 centimeter? Is there actually any extranodal extension? Is it unilateral or bilateral or present in the contralateral? These are all the 4 points, very, very important to go for staging. And please don't try to memorize these things. Humanly not possible. Whenever you see tumors, you sit and see. The more you use the system, the more you will get comfortable. Distant metastasis, PM0, no distant metastasis, PM1, distant metastasis. And one point, if you have to remember, if it is a non-regional lymph node, it doesn't come under nodal. It is a distant metastasis. For example, salivary gland tumor with axillary lymph node, it is metastasis. It is not PTN3. I hope you all understand that. And then you put everything under the staging and you come up again with a simple thing. Stage 1, very early stage cancer, less than 2 centimeter, no lymph node. Okay. Stage 3, more than 4 centimeter or 1 lymph node positive. Like that, you write down the value and point so that you can remember, because this staging system is very important for the treatment purpose. Okay. And this is what I want all of you to sit with your oncologist and see. This is a NCCN guideline. Okay. We follow NCCN guideline and they will have flow charts like this. And for practical purpose, I just cut short what are the points we need. Whenever there is a FNA biopsy, you see whether it is benign, malignant, or carcinoma or lymphoma. That's the main difference. Lymphoma, you refer to non-Hodgkin's lymphoma recommendations. If it is carcinoma or benign condition, go for second one. If it is complete resection, is it benign or low grade? When do you call low grade? If there is tumor spillage or perineural invasion, then you have to give radiotherapy. See how we play a very important role in deciding radiotherapy. When we see perineural invasion, radiotherapy has to be given. When it is adenoid cystic carcinoma, we have to give radiation. When it is total complete resection and the cancer site is major or minor salivary gland, you have to go to the next recommendation. When resection is not possible in T4B, we have to give for radiotherapy. Okay. And when the resection is possible and when it is parotid, no adverse features, just to follow up. When it is adenoid cystic, it is RT. And this is very, very important. Adverse features. All the adverse features are diagnosed in pathology, intermediate or high grade tumor. Close or positive margin. When you call it positive margin, the tumor cells are present at the margin. When do you call close? If it is less than 1 millimeter. Today it is 1 millimeter. Tomorrow it may change. So you have to keep looking the literature. If it is less than 1 millimeter, we call it negative margin, but they have to go for radiotherapy. So this is very, very important role for pathologists. When there is neural or perineural invasion, when there is lymph node metastasis, when it is lymphatic and vascular invasion, all these conditions we have to go for radiation. When it is incompletely resected or gross residual tumor, again they have to go for radiation. When it is completely resected and it recurs, again you look for adverse features, which we went through in the previous slide to decide for radiation. And this is more important in the new targeted therapy. Okay, if it is androgen receptor positive, if it is NTRK therapy, PanTRK positive, when it is HER2/neu positive, when it is MOEB positive, we have specific markers. Okay, so I kindly request all. Probably in pathology exam they are not forcing that much, but when you start practicing, you please go through NCCN guidelines or any guideline they follow in your hospital, and go through what are all the pathological features that will have a implication on the treatment, and you highlight that in your report. So that brings the end, the take-home message. These are, we can talk whatever we want, but clinician want to know whether it is low-grade tumor or high-grade tumor. Okay, please take a snapshot of this. These are all very important for the clinicians, because the prognosis is very, very important on the histological type. For example, actinic cell carcinoma, very good prognosis, whereas squamous and adenoid cystic, very bad prognosis. And this is the take-home message. So you divide them salivary gland into 4 compartments: acinar, intercalated, striated, and intra and interlobular or excretory duct. Acinar cell carcinoma and secretory carcinoma in the acinus. Basal cell adenoma, pleomorphic adenoma, adenoid cystic carcinoma, polymorphic adenocarcinoma, epithelial myopithelial carcinoma in the intercalated area. Warthin tumor and oncocytic neoplasm in the striated ducts. Papillary carcinoma, or papillary neoplasms including papilloma, papillary carcinoma, epidermoid carcinoma, squamous carcinoma, mucoepidermoid carcinoma, and salivary duct carcinoma in the ductal end. Myoepithelial carcinoma from the myoepithelial cells, sebaceous tumors from sebaceous cells, lymphadenoma, and carcinoma arising in lymphadenoma from the lymph nodes. So genetically or molecularly, you divide them into acinar end and ductal end. Acinar end is SOX10 positive and ductal end is SOX10 negative. And the specific markers are NR4A3 for acinar cell carcinoma, PanTRK for secretory carcinoma, beta-catenin for basal cell adenoma, PLA-G1 for pleomorphic adenoma, MOEB for adenoid cystic carcinoma, S100 for PAC, epithelial myopithelial carcinoma, use epithelial and myoepithelial, which is P40. Warthin tumor, oncocytic neoplasm, anti-mitochondrial antibody, squamous cell carcinoma, P63 or P40, mucoepidermoid carcinoma, FISH for MAML2, salivary duct carcinoma, androgen receptor, and HER2/neu, myoepithelial tumor, P40. When it is differential of squamous and myoepithelial, markers won't help you. Sebaceous tumor, EMA. And that's all about this lecture. I kindly request you to take a screenshot of this. Super. These are all again my references. I want to stress that. And my wife is sitting next to me. So thank you very much. I cannot request you to come as a Valentine. I wish you all good luck. I think time-wise, I'm taking a lot of time, I think. I don't know whether I can do the slide seminar or not. I can leave it to you. But slide seminar, 15 cases, I can fly through.
Sir, you can go through, sir. You can
whether
go through.
you want it or not. Put, give a few minutes. Any questions so far, madam?
No, sir, not it. Nothing. No questions at all so far.
Super. Keep asking your brain and come up with the questions. Don't hesitate. And we can even present it when we do the slide, and we can take more questions at the end. So I will just go to my next presentation.
Sir, you don't want a break, sir, or a cup of coffee?
I am fine, madam. If you all want, you can take a break. We can take 5 minutes break. All of you, please get up from the chair, because sitting is a passive smoking. Get up from the chair. Move your head from midline to the right and to the left. This is the exercise I tell people to lose weight. Okay, very simple exercise. Move your head slowly from midline to left and then left to right. And whenever somebody is offering food, you please do it fast from left to right. I hope you all got it. Madam, you got that exercise?
Yes.
Oops, this is the slide discussion. I will close the slide discussion. You put 5 minutes break, madam. Now it is 7:15 to me.
Okay.
So let us take 7:20. Or you can talk something on the delegates if you want some questions. How many delegates are there, Anand? 180.
180,
Ooh,
sir.
Super. 80 people. I am
But
others are-
Rajendran, it's a very excellent discussion and discussion about the salivary gland tumors. It is giving me a lot of things about the past and present and future also. And I
Yes,
hope
sir.
this is postgraduates and faculties equally enjoyed your discussions. And it's excellent way you discussed. And I hope
Yes,
we
sir.
will do this frequently so that the postgraduates will be getting useful information from this.
Sure, I love teaching, and that's why I
know.
started my own YouTube. You can go to my YouTube. I think 36 videos are there. So, and another request to you, Anand and John sir, once this recording is ready, give it to me. I will put it in my YouTube in parts.
Okay, sir.
So that people can listen. These are all accumulation of lot of videos and literature. Okay, and the literature available is phenomenal, but you have to keep on seeing videos and literatures so that you can accumulate and you can select the best out of all the presentations and give it more nicely. Super. Any questions? Come on, delegates. Keep asking. I have 3 more minutes.
So some people who are gone are they are also viewing on YouTube, sir, because if they are traveling, they are seeing on the YouTube link. They're following it.
Those who are present, can we go for a selfie time? Can they put on their camera? Because I don't know, after this slide seminar, everybody may leave.
Sir, we will not be able to view, sir, because by default it has been disabled.
Is it?
Yes, sir. It's only the panelist link was having the video options.
So next time you go for the system. There should be some way to open for the delegates also. See, I love that. I did it in few other conferences where you see 200 people with the camera and like a thumbnail of each one of them. They look beautiful. Yes. So super. I will go. I have 2 more minutes.
Sir, what is the limitation of frozen section in salivary gland tumor? No one is asking, so I am asking, sir.
Sure, madam. Sure, madam. Again, it depends, madam, what you are looking for. If it is basal cell adenoma or pleomorphic adenoma or adenoid cystic carcinoma, it's very easy. See, in cytology, we see only the cell, whereas in frozen section, you see the architecture and the cell. That's the beauty of pathology. When you see the architecture and the cell, you make the diagnosis very easy. So it's very, very useful in frozen section.
Yes, but anyway,
especially the margins, very, very important, because if they know margin positive, at the same time, they can go and remove some more from that area.
Yes, yes.
And unfortunately, the cytology gives benign and malignant in salivary gland, which is not acceptable by the clinicians.
Yes, yes.
See, I see more people very angry. Bose sir will kill me. And you know, you are also working with Dr. Bose. If you see pleomorphic adenoma and sir, sorry sir, it turns out to be adenoid cystic carcinoma, sir. What? Put down the phone. When he is angry, he won't talk.
Yes.
He will ask me, put down the phone. That's a bad news from Bose sir.
Yes.
Okay. So in those section, those time, frozen section is very important. But I will tell, sir, I asked for frozen section. Why you are not send it? And then clinically you will tell it is malignant. It is stuck to all these structures. I don't want to send it. It has to be malignant. That's fine. It's the clinician call whether they want frozen section or not. But we have to sensitize them. Please don't believe benign in frozen section in cytology.
Yes.
Okay, so benign can become malignant, and malignant usually won't become benign in the cytology. Super. I will see. Time started, madam.
Yes.
Thank you. So I will go to share my slide. This is like now we are going to be like a double engine, super fast. I will stop my video. Stop my hide floating media control. Can you see the screen now?
Yes, sir. Yes.
So salivary gland tumors, we will just fly through 15 cases. Okay. So 64-year-old male, upper lip tumor, diagnosis. Madam, I will give 2 seconds, madam, in the chat box. Let them feel free.
Yes.
Delegates feel free. This is upper lip. Okay. See the mucosa or the skin side of the upper lip. See the well circumscribed tumor. See the interconnecting tubules. And all interconnecting tubules. Any diagnosis, madam, there?
Canalicular adenoma.
Super, canalicular adenoma. Good. Any name, madam? First answer, name.
Uma Devi Srinivasan. Dr. Uma Devi Srinivasan. Sir.
Congratulations, Uma Devi. You please buy a Cadbury's and eat by yourself. It is our prize for you. We can't do better than that. Or Anand will send you one Cadbury's.
Yes.
So canalicular adenoma S100 and CK7 positive. I want to skip the theory part of it. Okay. So case 2, 52 male. So this is a lymph node. This is the salivary gland, some minor component, and this is a somewhat ill-defined margins. It shows multiple patterns, some papillary, some cribriforming, some glandular pattern. Diagnosis, some papillary pattern, architectural diversity, infiltration, and psychologically they look very bland. I give you the clues. Diagnosis.
Polymorphous adenocarcinoma. Polymorphous.
Super. See, madam, how we are educating people.
Seriously. 2 hours of non-stop lecture.
Even,
Deepti.
yes, even after hearing my lecture, they are diagnosing. They are great. Name, madam?
Dr. Deepti, sir.
Deepti.
Dr.
Great
Deepti.
Deepti.
Yes, yes. Deepti.
Deepti. One more sneakers for you. So glands, papillary pattern, non-specific, and remember this is roughly not that much of hurricane luster. It is forming there. Okay, remember the targetite pattern and remember the triad. Case 3, 25 female parotid lesion. Here you see this salivary gland margin is not very regular, and when you go to the high power, it is having 2 components. They have pseudocartilaginous component and a high grade malignant component. And that high grade malignant component is very cellular, shows some necrosis, and so the diagnosis.
Mucoepidermoid. Doc R has replied as mucoepidermoid carcinoma. And there is another answer, basaloid. Basaloid.
No, how will you explain this cartilaginous area? Imagine you see only this.
Yes, carcinoma expliomorphic adenoma.
Yes, and you qualify myoepithelioma. These are spindle cells. Okay, I will show you more pictures. This is carcinoma X pleomorphic adenoma, myoepithelial carcinoma. Okay, and I have to give the percentage just in case if the clinician asks. Okay, it's better. Myoepithelial carcinoma, in this case 30%. Okay, so here you can see the pleomorphic adenoma and carcinoma, and it's infiltrating at the margins, at the borders, and they are more spindle shaped. And when you do PLA-G1 positive in the pleomorphic adenoma side and P63 strongly positive, Ka67 very high in that area. Okay, so it is carcinoma X pleomorphic adenoma, myoepithelial carcinoma type. Submandibular lesion, 15-year male. You can see the salivary gland here, and you can see the infiltration. Okay, see this here, infiltrating into the salivary gland. When you go to high power, these are very poorly differentiated cells. And I want to point to one thing. See the abrupt keratinization. Can you see the epithelial pearl? So abrupt keratinization. Okay. Poorly differentiated carcinoma with the abrupt keratinization. Any diagnosis?
No, sir. Carcinoma, expliomorphic adenoma, again they have written.
Okay, good thought. So it's a poorly differentiated carcinoma and the HNE, but keep that in that abrupt squamous differentiation. Okay, that's very classic for this. See the squamoid areas. Can you all appreciate squamoid areas? Okay, abrupt, very abrupt. And the DD is poorly differentiated carcinoma, poorly differentiated squamous cell, sinonasal undifferentiated nasopharyngeal carcinoma, lymphoma, Ewing's. And we do a lot of IHCs, they are all negative, but there is one marker called NUT, okay, nuclear transcription factor in testis, okay, that NUT is positive. So that's the diagnosis, okay. There is translocation 1519 and NUT IHC is nicely positive. And so the diagnosis is NUT carcinoma, okay. What is NUT carcinoma? This is nuclear protein in testis. It's a poorly differentiated carcinoma, but that abrupt keratinization is very, very important. Cell of origin, we don't know, but diagnosis is by FISH for the fusion and for IHC for the NUT protein. Okay, I know this is out of syllabus. Some, I think 3 or 4 slides are out of syllabus. I have not talked about it, but this NUT carcinoma comes under poorly differentiated carcinoma in the new WHO type. This is very common in the head and neck area. So in the sinuses, please keep it in mind. Poorly differentiated carcinoma with abrupt squamous differentiation. Super. Case number 5, 47 male peritonsillar area. Okay, infiltration is there. Some clear cell, some glandular structures, high power, you can see it very nicely. Luminal cells, abluminal cells, invasive malignancy, diagnosis. You can see the luminal and abluminal clear cells. Diagnosis.
Myopithelial carcinoma.
What about these? What are these cells? These are epithelial.
Epithelial myopithelial carcinoma, sir.
Yes, epithelial myopithelial carcinoma. Okay, P63, if you do, they will stain all abluminal cells, and when you do low molecular weight cytokeratin or CD117, they will take all the luminal cells. Case number 6, low power diagnosis, salivary gland invasion, some cystic degeneration, invasion into soft tissue, and high power tubular and attempted cribriforming. Diagnosis. Come on. Adenoid cystic carcinoma.
Yes.
Okay.
Yes.
So this is the FISH for MOIB, NFIP, and this is the immunohistochemistry for MOIB. They can show tubular pattern, solid pattern, cribriform pattern, and basal cell adenoma, one of the DD, to make clinicians very angry in cytology. Ki67 and the MOIB will be very, very helpful. Case number 7, parotid lesion. You can see normal salivary gland, some well circumscribed lesion, and you see more like small blue cells, isn't it? In this high power, you can see some nests of epithelial cells. And in the highest power, lot of lymphoid cells, some nests. Aha, some of them are having sebaceous differentiation. And the nuclei are very bland. Diagnosis.
Sebaceous adenoma.
Super. Lymphadenoma, sebaceous type. You have to include lymph also there because a lot of lymphoid cells. So lymphadenoma, sebaceous type. Okay, high power. Great. Case number 8. This is again a parotid lesion, and this tumor is infiltrating. Again, blue cells and the irregularness. When you go to high power, see the Hyundai sign. Can you see Hyundai or Hero Honda? All costly car logos. They are atypical mitosis. Mercedes, okay, Honda, and very highly pleomorphic, isn't it? And the criteria for pleomorphism, go to the lowest, smallest cell and go to the largest cell. If it is more than 3 times, that is the criteria for pleomorphism. Okay. Diagnosis?
Lymphoepithelial carcinoma is given, sir.
Super. Okay. But this patient doesn't have any other mass. This is the only parotid mass. So this is the epidermoid carcinoma arising in lymphodenoma. But that is an excellent diagnosis. And EBER you can do in epidermoid carcinoma in lymphodenoma, EBER will be negative. And P16, you all know all squamous cell carcinoma in the head and neck mainly classified into P16 positive and P16 negative. So this will be P16 positive. So this is the other picture, squamous cell carcinoma arising in lymphadenoma. Case number 9, parotid lesion. Thank God it is not coming in the frozen section. See, you can see the extensive squamous, some infiltrating islands are there. Some minor salivary gland elements are there. Some ducts are there. Okay, this is the low power view. In the high power, very irregularness, but they are all very mature. And see another again, the lobular pattern is maintained. Okay, diagnosis?
Necrotizing xylometaplasia.
Super xylometaplasia, one of the very difficult diagnoses in frozen section. Okay, lobularity and absence of ATP. This is more like pseudoepithelioma carcinomatous hyperplasia. They used to call pseudoepitheliomatous. Why do you call it pseudoepithelium? It is a real epithelium, but it looks like carcinoma. That's why it is pseudocarcinomatous hyperplasia, and necrotizing xylometaplasia is the diagnosis. Super. What's the name, madam? That one.
Devaki, sir. Dr. Devaki Priyanka.
Congratulations, Devaki Priyanka.
Sir, it's our own PG, sir.
Oh,
very good.
College.
Great.
She got a previous answer also correct. Carcinoma extreme of she also.
Super. Super. You buy her some Cadbury's and give.
Yes.
Anand.
Yes, sir. Sure, sir.
Don't leave her without price. Or
Okay,
you
sir.
ask her to give her, you buy her Cadbury's and you ask her a treat for a cake. Okay, let her buy a
Okay,
cake for the department.
Sorry. Okay,
For
sir.
squamous metaplasia and squamous cell carcinoma, P63 will be very helpful. Okay, in xylometaplasia, the basal cells are preserved, P63 positive, whereas in squamous cell carcinoma, P63 will be negative in the margins. Okay, but sometimes the even squamous cells can take P63. It's not very useful practically, but in this picture, it's very useful. Case number 10, submandibular lesion. Okay, salivary gland, widely invasive, lot of secretions. Let us go to high power. Some squamoid cells, some mucinous cells, some hybrid cells. Diagnosis. See, this is how you have to describe. The description should bring you the diagnosis. Priyanka, come on, Priyanka.
Secretary, sir.
Secretary.
Clear, sir.
Yeah, ma. Squamoid cells all are ma. I agree, secretary is there, but I told you, mucin cells, intermediate cells, and squamoid
Sir, they
cells.
mentioned mucoepidermoid.
Mucoepidermoid.
Mucoepidermoid. Okay, it's a low-grade mucoepidermoid carcinoma, intermediate grade and high grade. Okay, and we follow the AFIP system. Cystic component, less than 20 or more than 20, perineural invasion, necrosis, mitosis, more than 4 per 10 hyperfield. Anaplasia or nuclear atypia, we give the score. The score is 5 to 6, intermediate grade, 0 to 4, low grade, more than 7, high grade. Case 11. Somebody asked the question also before, so this will tell the answer for that. Parotid lesion. Okay, lymphoid infiltrate, oncocytic cells with the lymphoid infiltrate, only oncocytic cells, but there is no capsule.
Warthin's tumor, vanilla. Dr. Vanilla.
Yes, this
Krishna.
is Warthin's, but what is this? So it's Warthin's tumor with oncocytic hyperplasia. Remember, somebody asked, if you don't see lymphoid cells, when you see only oncocytic cells, what do you have to call? You have to see whether there is capsule or not. When there is no capsule, only oncocytic cell, it is oncocytic hyperplasia. When there is capsule without invasion, it's oncocytoma. When there is capsule with invasion, it is oncocytic carcinoma. Okay, so you can remember, see in this picture very nicely. This is the Warthin component. This is the oncocytic hyperplasia component. Probably they are all spectrum, but we have to name them differently. But who cares? It is hyperplasia and Warthin tumor. Patient should do very well. Is it male or female? Male. Remember, the Warthin tumor very common in male. Super. And anti-mitochondrial antibody positive. Case number 12. Parotid, female, parotid gland, and some pink cells, Look at the lymphoid infiltrate at the margin. Tumor-associated lymphoid proliferation.
Acinic cell carcinoma, someone has replied.
Super. Okay. In this diagnosis, if you diagnose acinar cell carcinoma, give a DD. Don't be very committed. I know you took a chance here, but whenever you see lymphoid aggregate with a large pink cells, think of acinic cell tumor. And remember, I asked you to check PD1, PDL1 in acinar cell carcinoma. Has anybody checked? We have 3 more slides. You have some time. Check the literature. See, these are more solid cells. And the diagnosis is acinar cell carcinoma, acinar pattern. I have not shown this pattern in this slide. If I give this slide, this looks like more rosettes, isn't it? So, but when you do basement PAS diastase, you can see the nice basement membrane. So this is acinar cell carcinoma. It can have any pattern, acinar, microcystic, papillary, cystic, solid. They will show prominent nucleoli and tumor-associated lymphoid proliferation and NR4A3. Previously, we used to do SOX10 DOG1. Now we do directly NR4A3. Very specific. Case number 13, 66 male parotid lesion. Gland is here, some infiltrating tumor.
Myoepithelial carcinoma, they've written.
Prominent nucleoli. The patient, these are all poorly differentiated carcinoma. You have to give a differential diagnosis, and the patient had previous history of melanoma. Okay, that's how we did only HMB45, and it's nicely positive. Okay, that's why before doing IHC, give a call to clinician. They will have a lot of surprises in their sleeves. Okay. Sir, it looks like melanoma, sir. Is there any history? Yes, patient has melanoma. Why you are not told me, sir? I want to test whether you can diagnose by yourself. Okay, that's the answer I get from my surgeons. They are putting tests for pathologists, but you have to understand patient is under stress. So no testing in between the pathologists or surgeons. They have to sit together and come with. So the learning point from this case, before doing IHC, please call the clinician. It won't cost you anything because nowadays we call by WhatsApp, which is totally free. Okay, and you can save lots of money. Another best thing you can do, if the previous surgery is done in your own institute, you can pull the slides and look at morphology. If the morphology of the previous specimen and previous case and this case is similar, without IHC, you can diagnose. Previous case reviewed, morphology is very similar to the current presentation. So this is recurrence or metastasis or relapse of the same condition. Metastatic melanoma. Remember, melanoma is one of the greatest mimickers. Always keep melanoma in the differential diagnosis. Case number 14. Parotid lesion. Circumscribed lesion, lot of varied patterns, but you can see nice peripheral palisading. Some cribriforming is there, and stroma is running more over it. இதுதான் I think blanket is around you. இது வந்து படுத்துட்டு அப்புறமா போத்திட்டு இருக்காங்க bladder வச்சிட்டு. Super, basal cell adenoma. Okay, and membranous type. Again, the solid type, trabecular type, tubular type, and membranous type. And beta-catenin will be very, very useful. I know all of you have beta-catenin now in your lab. Many people don't know basal cell adenoma is positive for beta-catenin. Okay, please use it and enjoy the staining. The closest DD is adenoid cystic carcinoma. MOEB is the diagnosis. In the last case, female parotid, 40 years. So this is again a lot of secretions, but you see only one type of cell. And when you go to the high power, they are looking more squamoid and some of them are looking more microvesicular. Okay, so there is no hybrid cells here. Okay, and there is no goblet cells, mucin secreting cells. These are microvesicular cells. So the diagnosis is secretory carcinoma. Okay, so they will look like a follicular adenoma in salivary gland. Okay, with a lot of secretions. And the mammoglobin may be positive, but now we have the track. So you are in correct track if you do pan track. Okay. And I want to introduce another reference, John Rosai collection. When you put rosaicollection.org, it will take to this picture. to this website. And when you click the slides here, you will see the whole slide image. Okay. Along with the USAP, the Leica scanning people, they scanned the whole slide image of Dr. Rosai's collection. There are more than 10,000 slides available there. You can go and you can type in the search salivary gland, or salivary gland tumor will come, lung tumors, all lung tumors will come. You can play around in this site. Please remember rosaicollection.org. And thank you very much. You set your goals that scare you and excite you. Remember, Madam was telling Ushakini Madam, you get excited when the cytology is correlated with histopathology. So you set your goals that gives pleasure for you. Thank you very much and have a great day. Thank you, Madam. I am done.
Sir, thank you for the exhaustive presentation. For 2 to 3 hours, you have spoken non-stop, only information, nothing else, and with jokes in between to excite the students who are listening to you as usual. Thanks a lot for
non-stop nonsense, Madam, for 3 hours.
Wonderful.
You will say you are a very nice person, Madam, but I know it is non-stop nonsense. 3 hours is too much, but I want to convey the whole thing.
Yes.
So that's why I took some extra time. Sorry for that.
And the 15 slides you kept for testing was answered by everybody, so the purpose is served as well, sir. It is a proof that it is not nonsense and full of sense only.
Super, Madam. So nonsense, non is Tamil, sense is English.
That is very good.
So whatever I talked, non பேசுனதெல்லாம் sense oda இருக்கும்.
Yes.
Super, Madam.
So thank you so much, sir.
Thank you so much, sir.
Any questions? Everybody left? No questions, sir?
They are there, sir.
They are all there.
They will be there because feedback form has not been released yet. So
I saw 163, suddenly it is 145. I wish you all the best to get the feedback. People, don't leave without giving the feedback.
Sir, can you stop sharing, sir? I just want to share something.
Sure, I will stop sharing. It's not stop sharing. It's not working. It's not stopping me sharing. I don't know. I will, the only thing is
1 second.
I have to leave the meeting. You stop my stop, but yeah, I stopped it. Or you stopped it, I think.
Okay, sir.
My stop button is not working.
So thank you, sir, for such a mammoth session on salivary gland tumor histopathology and recent advances. Even though it was about 2.5 hours or so, I don't think anybody felt that, and I think postgraduates are really waiting for it, sir. So it's a wonderful art of simplifying something that is difficult, and as always, in your own style, you've done it. And I think we and other postgraduates will be very grateful for that. In appreciation for your talk, we would like to honor you with the certificate. I'll be emailing it to you, sir. This is a certificate that is presented to you.
Thank you very much.
Thank you so much, sir. And as our chairperson, Chandra Madam, has kindly chaired 2 sessions continuously, and we're really grateful to you, Madam, for your active contribution to the CME. And I would like to tell that as Secretary of Tamil Nadu IAPM, she has been very instrumental in starting the CME, because she has been asking us, because SRM also is part of the EC members, and she has been motivating us to start something, do a CME. And she was, whenever she came as examiner also, she was immediately telling us, start something and we will do. And she has played a big role in initiating it. And thanks a lot, Madam, for your contribution. It was immense contribution for the CME. So, and I would like to just summarize something that from the morning we've been having 3 sessions. And I just want to mention 1 or 2 points that each person gave as a take-home message that doesn't come under any textbooks or from any factual content, from their experience. So our Jagdish Chandran Bose sir, oncosurgeon, told us a lot. The one thing he told as a message for pathologists is whenever there is a controversial report or any other report, please discuss first with the surgeon before issuing the report, because it leads to all kind of problems, so that there is better correlation. And he asked us to use the approach, clinical approach, as a presentation of the lesion as well as radiology, and then correlate it with pathology. So these were the at least two things that he told we have to keep in mind as a take-home message. And Usha Kini ma'am told us so many challenges about salivary gland lesions, especially the benign as well as malignant, and how we have to be guarded about differentiating and how to give a differential diagnosis and inform the clinician on what they can expect in the histopathology and resection. Another one that he was saying was, Madam was saying, was to interpret, I think these are golden words, to interpret cytology, you should know histopathology well, so that only when you know what you can expect and what are the cells to expect in cytology, you will never know unless you know histopathology well. I think this our postgraduates and all of us will take into consideration. And as you saw, Rajendran sir has put up so many of the what do you call, sir? So take a selfie. So many high yield material he has put in his slides. And I think the one thing I would like to say was the SOX10 positive versus SOX10 negative group. He had put pictures of the SOX and number 10. I hope at least the postgraduates remember that. That's why he has put it like that. And classify it according to that, and as well as the applied histology slide he has put. And I think one thing he has mentioned that you don't see in the books is he said to measure pleomorphism or assess pleomorphism, look at the smallest cell and to the largest cell, and it should be more than 3 times to at least get it. I don't think you can get anything like that in a textbook. It's all experience, and we are really grateful and honored to have all our speakers and chairpersons to grace this CME and contribute so much to make it as a grand success. We as a Department of Pathology, we have professors, Dr. Jason Jacob John sir, Dr. Shivshekhar sir, Dr. Kalaivani ma'am, Dr. Muthu sir, and Dr. Bona Devi ma'am. Assistant professors, Dr. Balaji, Dr. Tina, Dr. Hemant Kumar, Dr. Kaushalya, and Dr. Saumya. And postgraduates, Dr. Purnima, Karthikeyan, Sundrapandian, Meenakshi Sundaram, Suvaita, Abhirami, and Devaki. The entire department worked for the CME on all aspects. So many, working across committees and to make this as a success. And it was this is the first time we are doing an online CME, so we had some, teething problems, but I think we came through. So a big thank you to everyone, the delegates, the chairpersons, speakers, and from the Department of Pathology as a whole. Thank you so much. Sir or ma'am, any take-home messages you would like to give, sir? Sir and Chandra ma'am?
Super, Anand. You nicely summarized everything. And thank you for involving me in this.
Thank you so much, sir. We are grateful.
Same here.
And
thank
thanks,
you.
Chandra madam, thank you for being with me for this whole 3 hours.
It's an honor, and I learned a lot from you as usual, sir. And I'm a follower of your YouTube lectures anyway. And this also is going to come on YouTube, I suppose. So I'll listen to that again as well. And to Sundaram sir, of course, my teacher, my pranams and my namaskarams. And to the whole team of SRM Pathology, a big thank you for involving me in this.
Sundaram sir and Ravi Kumar sir.
So the delegates, the feedback form will be posted in the chat link as well as in the WhatsApp groups. So please fill up the feedback form and you will get a certificate that looks like this. And this is under the TN chapter of APM. So our officials, our HOD, Chandra ma'am, Sandhya madam, and our dean signature will be there. So any difficulties in any of these, please contact the organizing committee. They'll be able to help you with that. Thank you, one and all.
Thank you, Anand.
Thank
you. Sign off. Thank you,
Yes,
madam.
sir.
Thank you, John sir. I don't know.
Thank you, sir. Thank you, sir.
Sir is there or not? I don't know.
Thank you, Chandra.
He's there. He's there, sir.
Shivshekhar sir. Thank you.
Sir, kilometer. Okay.
Say bye.
Okay.
Yes.
Bye, sir. Bye.